All right, good morning. I'm calling this Performance Oversight Roundtable to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Wednesday, February 18th, 2026. The time is 9:30 a.m. Today, we will discuss the performance of DC Health, DC Department of Health, for fiscal year 2025 and fiscal year 2026 to date. Today, we'll only hear from our public witnesses. Director Ayanna Bennett and the DC Health team will testify before the committee this Friday at 9:30 in room 412 of the John A. Wilson Building, as well as you can view that online. DC Health promotes health, wellness, and equity across the district and protects the safety of residents, visitors, and those doing business in our nation's capital. With approximately 940 FTEs, DC Health is organized into 6 administrations: the Agency Management Program, the Center for Policy Planning and Evaluation, Community Health Administration, the Environmental Health Administration, Health Systems and Preparedness Administration, and the HIV/AIDS, Hepatitis, STD, and TB Administration, also known as HOSTA. The committee did send written pre-hearing questions to the agency, and we'll reference those materials today. If anyone watching would like to see those materials, they are online on the council's website at dccouncil.gov/hearings. I don't see any of my colleagues right now, but we'll certainly turn to them if they join us. So we're going to go ahead and get started with our public witnesses. Okay, I want to remind everyone you have 3 minutes to testify. It is not because we don't desire to hear all that you have to say, but there are over 70 witnesses who have signed up to testify today, and I personally don't want to be here all night long. Neither will you. So you can certainly submit longer written testimony for the record. For those who are in the room, there's a clock on the test, there's a clock in front of the camera, and then we will nudge you should we need to do so. Anyone who's not able to speak today, of course, you can submit written testimony for the record, and then we'll go from there. Okay, so our first panel of witnesses, I have 4 chairs: Kristen Ewing from DC Appleseed, Leah Caslis from Children's Law Center, MJ Gray from DC Appleseed, and Jacqueline Bowens from the DC Hospital Association. Okay. Good morning, everyone. All right, Kristen, when you're ready.
Good morning. My name is Kristen Ewing, and I'm Policy Counsel at DC Appleseed, where I lead our health equity work and chair the Workforce Committee of the DC Coalition on Long-Term Care. I will briefly discuss 3 areas today: HIV disparities, sexual health education, and the long-term care workforce. First, HIV in the district. DC continues to make meaningful progress. According to DC's 2025 EPI report, 192 individuals were newly diagnosed in 2024, an 86% decline from the 2007 peak. But progress alone does not eliminate disparities. Black residents continue to bear a disproportionate burden. 69% of residents living with HIV are Black, and Black men account for half of new diagnoses. Viral suppression rates also remain low among Black individuals, reflecting persistent structural barriers. Age disparities are also stark. Young adults aged 18 to 24 account for 19% of new diagnoses, yet viral suppression among youth is 53%, compared to 75% among residents 55 and older. Early diagnosis is not enough. Sustained age-responsive engagement is essential to close gaps among youth and support a growing population aging with HIV. Federal disinvestment in HIV prevention, testing, and care makes local leadership and investments even more critical. We continue to encourage DC Health and HOSTA to create a dashboard to track HIV cases and enable timely, targeted interventions. Second, health education and prevention. Almost 20% of new diagnoses occur among youth. 70% of youth newly diagnosed in 2024 were Black, and 60% of new diagnoses among transgender residents were aged 20 to 29. These data show that we are missing critical youth populations. With OSCE currently revising the health and physical education standards, HOSTA must work with them to ensure the standards reflect current epidemiology. Comprehensive, medically accurate, culturally responsive, and LGBTQIA inclusive sexual health education is a frontline public health strategy. When epidemiology drives education policy, prevention becomes strategic rather than reactive. Finally, long-term care. Long-term care capacity is foundational infrastructure, especially as residents age and workforce shortages in long-term care directly affect the whole healthcare system. The Certified Nurse Aid Amendment Act merged the CNA and HHA credentials to increase workforce flexibility. We appreciate that proposed regulations are moving through review, but more than a year after passage, the unified credential remains non-operational. Process updates are welcome, but what the system ultimately needs are swift results. Similarly, the medication aid certified pathway credential remains stalled, with training schools approvals and confusion persisting between the MAC and the TME roles. These delays constrain workforce pathways and strain nurses and facilities. We commend DC Health and the Board of Nursing for pursuing reform of embedded CNA skills testing, the implementation of the new testing model, the merger, the MAC pathway, and related reforms must move from planning to execution. Across HIV prevention, education, and long-term care, sustained oversight, transparency, and timely implementation are essential. Thank you so much. I welcome any questions, and I have submitted a more detailed written testimony.
Thank you. Leah?
Good morning, Chairperson Henderson and staff. My name is Leah Kaslas, and I'm testifying today on behalf of Children's Law Center. Thank you for the opportunity to testify today regarding DC Health's performance over the last year. Our clients and DC residents rely on DC Health to provide critical services that improve navigation and access, strengthen a child's youngest years, and support their caregivers, increase workforce, and address poor, unhealthy housing conditions. Ensuring high-functioning, accountable, accessible government programming processes and procedures at DC Health is vital to our clients and district residents' health and well-being. My written testimony covers a wide range of topics on DC Health. We appreciate the agency's continued partnership with Children's Law Center in many of these areas and the oversight provided by this committee. Specifically, my written testimony speaks to the new investment in DC Health's Link U to improve how residents navigate and access services, resources, and information, opportunities to strengthen healthy steps by addressing financial stability and reducing administrative burden, why improvement of coordination across home visiting is needed to support improved implementation, streamline funding, and reduce administrative burden, DC Health's role in supporting the behavioral health workforce, why the delayed legislation from DC Health on community health worker certification continues to stall much-needed workforce expansion, and the transition of Healthy Homes program from DOEE to DC Health. It is clear that DC Health's role in the district is expansive. Their work is important to addressing immediate needs, as well as providing services that prevent negative outcomes or experiences from arising in the future. With my remaining time, I would like to speak about DC MAP, a long-standing DC program that provides pediatricians who have mental health-related inquiries about specific children real-time phone access to psychiatrists, psychologists, social workers, and care coordinators, which improves service delivery, patient health outcomes, and reduce costs. We recently learned that DC MAP transitioned from DBH to DC Health. However, we lack clarity on who remains in charge of DC MAP based on public information. We have provided a list of questions to this committee to ask the agency to clarify what the next steps for DC MAP are. The transition from one agency to another puts a program that's already on rocky ground into further instability. Moreover, a transfer from one agency to another without any public notification is alarming, as it lacks transparency and removes accurate accountability to stakeholders. We hope to see DC MAP continue to serve as a valuable resource to pediatricians and meet the behavioral health needs of district children and families. Renewed oversight over this transitional period from DBH to DC Health and in the coming years would greatly support this goal. Thank you for the opportunity to testify, and I welcome any questions the committee may have.
Thank you. MJ?
Good morning. My name is MJ Gray, and I'm a policy fellow at DC Appleseed Center for Law and Justice. And my role at DC Appleseed focuses on advancing environmental justice by working to ensure the district meaningfully addresses and mitigates the health impacts of environmental conditions and the changing climate. I'm testifying to request greater clarity and transparency around the Environmental Health Administration, particularly its work and coordination with other agencies. The creation of the EHA was an important step, signaling that the district recognizes the profound impact of indoor and outdoor environments on public health, especially for children, seniors, and communities that have historically borne disproportionate environmental burdens. However, more than a year after its establishment, it remains unclear how agencies are working together to address key environmental health issues. Without clear public reporting, it's difficult to assess whether EHA has improved oversight and services or whether responsibilities have simply shifted without increasing impact. The lack of clarity is especially concerning in the areas of mold and lead exposure. The EHA now houses the Healthy Homes program, which addresses environmental hazards in residential properties. Yet neither the program nor EHA has articulated clear goals for improving mold identification and remediation in residential housing. Even basic public-facing information remains outdated. An online search for Healthy Homes program still directs residents to the DOEE webpage with outdated information. That signals a troubling lack of coordination and undermines public access to services. Residents facing mold concerns are often bounced between DC Health, DOEE, and the Department of Buildings, and may be forced to hire private investigators. Meanwhile, DC Health acknowledges that childhood asthma and hospitalization rates in the district are worsening, and mold is a known trigger to exacerbate respiratory illness. Lead exposure similarly requires coordinated action, and we do commend the creation of the Childhood Lead Poisoning Prevention Testing Dashboard, which increases transparency and access to data. However, the dashboard still shows that testing rates remain concerningly low. Fewer than half of DC children receive their 2 required lead tests by 26 months. These interconnected public health and housing challenges demand structured, transparent collaboration. When EHA was created, many hoped it would serve as a hub to align agencies and drive coordinated enforcement and prevention. That coordination is not yet visible in a systematic or transparent way. We therefore urge the Council to require greater accountability from EHA and its partner agencies, including regular public updates on EHA initiatives, including a dedicated web page outlining their projects, data trends, and performance metrics, as well as mandated recurring interagency meetings between DC Health, DOEE, and the Department of Buildings focused on lead, mold, and other environmental health priorities, with public reports summarizing outcomes and action steps from those meetings. Thank you for the opportunity to testify, and I welcome any questions.
Thank you. Ms. Bowens.
Thank you very much. Good morning, Councilmember Henderson, and thank you so much for the opportunity to testify this morning. Rather than to repeat some of the comments that were made earlier, I would just say that the DC Hospital Association certainly supports our efforts. Our conversation will focus in on the nursing and maternal health. And rather than repeat that, I'll just say that we certainly support the comments and applaud the agency for their efforts, particularly the nursing board, as relates to patient care techs, as well as certified nursing aides, and the work that they've done to really streamline those processes. I'd like to really focus, I do have testimony submitted for the record, but would like to speak specifically to our work in the maternal health space. We are working closely with the department on improving maternal and infant mortality, and as you're aware, DCHA was awarded funding to manage the DC Perinatal Quality Collaborative by DC Health and has sought and received additional funding from HRSA to expand our work. In May 2025, we launched the Count the Kicks program, an evidence-based program that teaches expectant mothers about the importance of tracking fetal movement and improves patient-provider communication to reduce preventable stillbirths. We are pleased to share that as of DCHA's December 2025 utilization report, DC has shown the strongest growth across all states implementing Count the Kicks, with an 83% increase in engagement among registered users. Additionally, we are continuing to build upon our success in recognizing obstetric hemorrhage events. Hospitals have made significant progress in adopting standardized quantified blood loss measurement practices, with documentation rates of recognition increasing from 69.8% in Q4 2023 to 92.8% in Q3 2025. Through the Perinatal Quality Collaborative, we will continue to improve maternal mortality and morbidity outcomes. Again, there is longer testimony that has been submitted. And as I said, rather than repeat, please refer to that. And thank you for the opportunity to testify today. 56 seconds left.
Jackie, I was not prepared for that. It's not, okay. Let's use that as a model. No. Well, thank you all for testifying today and submitting testimony for the record. Jackie, I'll start with you. Is you said it pretty quickly, but I just kind of want to underscore in terms of the Count the Kicks initiative. So the committee provided one-time funds, only $75,000, and we had an 83% increase in engagement, which is huge.
I think we're so proud because keep in mind we have the Perinatal Quality Collaborative, so we're able to have all stakeholders around the table and get everyone invested. So I think that really has been the focus, and we've leveraged additional funds on our own. So that seed money that you gave us was critically important, and then we reached out to get additional funds and other initiatives that support the work of the Count the Kicks. So again, we see that all as one universal initiative.
Okay.
And we have the data. I'm happy to share it with you.
All right. And what's the focus now for the Perinatal Quality Collaborative?
The hemorrhage. So we're looking at reducing the hemorrhages. And then we have also established across the board, all of our birthing hospitals have the same target. And then we bring our quality collaborative together monthly, and then we look at best practices, and each of the hospitals help with each other where we're seeing progress in one way. They are best practices. So I think the most important part has been that they're all tracking the same measurements.
That's good. But from a data perspective, this is one of the challenges that I've had with DC Health. Like, we are like 10 years behind on every report. I haven't seen a maternal health report since like 2021, maybe. Okay, sure, it's 2026. I haven't seen any sort of recent data that reflects post-pandemic. Are you all working with them to provide the updated data and information from the hospitals on this?
Yes, I believe that is the case.
Okay. All right.
I have a team, so, but I mean, we have data, and we are consistently supporting and sharing that data. And so we have grants both with DC Health in this space as well as HRSA. So, obviously we have requirements with respect to data, and we also issue a monthly utilization report. And so that data, which we share with, we're pretty transparent about it. We also share it with all the hospitals and members of the community as well.
Yeah, I mean, I think that these are some of the questions. So in the pre-hearing responses, which I do suggest that people go take a look at, for all of the folks who say that there's not enough transparent information about what's going on, I feel like during performance oversight, we asked for perhaps the biggest data dumps of reporting of information that you can get from the agencies about a variety of different things. And just sort of going through it yesterday, I was talking to my staff about we asked a question about the top 10 leading causes of death in the district, which, I think everybody always gets what the number one thing is incorrect. But what did stand out to me was the high number of sepsis that has led to death. And that is something that happens in, surgery rates, et cetera. And of course, I'm not going to say of course, but in this particular year, it was certainly higher for women than it was for men. So then I have to make some inferences and assumptions because we don't have necessarily all of the information. But I'm glad that the Hospital Association is working on this and working with our hospitals to continuously try to improve in this particular area.
And Councilmember Henderson, we also keep track of a lot of those indicators, and again, happy to share our internal data with you as well.
Okay, great.
So, we have made a determination that hospitals compete, but they don't compete when it comes to quality.
Right.
And so how we look at that data and track it, we can share.
Great. NJ, thank you for being here. I wanted to ask, you had some pretty strong criticisms for the Environmental Health Administration, but it seems like what you want from that division of an agency is more than what we desire from any other division, which is you want mandated meetings with all of these other agencies, plus mandated reporting every month of what they met about and talked about. Did I hear that incorrectly?
Speaking of what would be the ideal, having some sort of regular meeting, doesn't have to be monthly, but some sort of required meeting to really push that interagency collaboration would be ideal. The Environmental Health Administration does seem to be that ideal place to have that hub for alignment because these environmental health issues really do span multiple agencies. But right now,
But you're looking for a public meeting, because I'm going to assume, given that staff have come over from Department of Energy and Environment over to DC Health, that these conversations are happening, but you are looking for evidence of such collaboration?
right, some sort of report that the public would be able to access about what that collaboration looks like, even if the meeting itself is not public. Like you said, a lot of the staff has moved over from DOEE, but there seems to be confusion about, at least from our perspective, of how the staff is continuing to work together. If some staff was left behind on DOEE, are they still doing things for the Environmental Health Administration, or have they been given new responsibilities and are no longer working together? It's just not particularly clear. Just some sort of mechanism that's going to really make the Environmental Health Administration's work clearer.
Okay, got it. All right. Leah, we'll ask some questions about DC MAP. And Kristen, thank you for being here and raising the CNA credential. deeply frustrated with both the Board of Nursing and DC Health at the, let's see, glacial pace for which they seem to be moving, not recognizing the crisis that many of the institutions are facing in terms of this particular workforce. And this is the struggle, right? We can push and move and do the legislation, but we are not the Board of Nursing. We do not move forward on the implementation front. But I feel like in some cases we are allowing for perfection to be the enemy of the good. Did I say that right? Yeah, okay, great. And so a year later, we still don't have the thing that everyone in the industry has sort of identified as something that could help propel us forward. So we'll certainly be asking some questions about that. Thank you all for being here today. I don't have any further questions. We're going to go on to the next panel. Rachel Johnston from DC Charter Alliance, Jacent Brown from DC Central Kitchen, Carrie Stuffless from Food and Friends, and Dean Brenner from the Alzheimer's Association. Okay, Rachel, when you're ready.
Good morning, Chairperson Henderson and members of the committee. My name is Rachel Johnston. I'm a Ward 4 resident and the Chief of Staff at the DC Charter School Alliance. DC Charter Schools are deeply committed to supporting students' health so they can engage in learning. They have reached 97% immunization compliance in key grades, with 46 charter schools achieving 100% compliance, reflecting strong family engagement and partnership with OSSI and DC Health. Additionally, 113 charter schools participate in DC Health School Health Services Program or employ a private nurse. And more than 500 trained AOMs. There are more than 500 trained AOMs across charter schools, up from 373 last year. Our schools rely on partnership from the city to make and sustain this progress. We thank the DC Health School Health Services team, including Dr. Washington and Sabrina Gandy, for engaging with us and our schools this school year after the transition from Children's School Services to in-house management. They have met with school leaders, provided updates, answered questions, and recently shared a list of roles and responsibilities for Health Suite staff, providing the clarity we've requested for years. However, we are concerned about the direction of the program. At this time last year, every school in the program had full-time coverage. When the transition began, DC Health stated that Health Suite staff would be available at schools from 8 a.m. to 4:30 p.m. daily. Unfortunately, that has not been the reality. Today, 1 in 3 schools does not have full-time coverage. Schools have also raised concerns about staff readiness to respond to emergencies. This comes as pediatric chronic health conditions, including diabetes, epilepsy, and asthma, continue to rise. School health staff are essential to managing emergencies, monitoring chronic conditions, and serving as health experts for school communities. They cannot fulfill this role if they are not consistently present. Recognizing this year's challenging budget cycle, we offer recommendations to strengthen support without significant fiscal impact. First, be transparent with schools. During last spring and summer, communication was limited, and public statements and FAQs emphasize continuity and coverage. While the level of communication has improved, that messaging has not remained consistent. Earlier this month, a school was told to expect 20 hours of weekly coverage unless students require specific medical treatments. We understand transitions bring challenges and that DC Health continues to hire, but this mixed messaging creates confusion and makes planning difficult. Second, examine and revise the current strategy to recruit, hire, and train staff. Persistent vacancies suggest current approaches may be insufficient. Alternative recruitment strategies and stronger preparation before staff are placed in schools may improve retention and quality. Third, identify alternative ways to meet students' needs. We suggest piloting direct funding to schools to hire their own RN or LPN, building on lessons from DBH's Pilot 1B program. Several charter schools already employ their own nurses, demonstrating that this is feasible. Schools opting in could decline a DC Health clinician, easing DC Health's hiring pressure. We also recommend providing a list of approved AOM trainers schools could contract with and partnering with FEMS to expand access to CPR training. While AOM and CPR trained staff are not substitutes for licensed clinicians, both are critical to student safety. CPR training is also required under the Cardiac Planning and Response Amendment Act of 2024. Meaningful improvements are needed to ensure student health needs are met. The DC Charter School Alliance values our partnership with the city and looks forward to continued collaboration. Thank you for your time and attention, and I welcome your questions.
Thank you. Ms. Brown?
Dear
Oh,
Chairperson,
you got to turn your mic on. There you go.
that's right. Dear Chairperson Henderson and members of the committee, thank you for convening today's oversight hearing for DC Health.
My name is Dr. Jacent Brown, and I'm the Chief Impact Officer at DC Central Kitchen. As you know, DC Central Kitchen has served the district for 37 years, providing nutritious food and economic opportunities where they are needed most. As this is a performance hearing, I want to state clearly that DC Health's partnership, professionalism, and technical expertise has become essential to how we perform each day and how well we are able to address hunger, poverty, and health disparities in the city. We work closely with DC Health via our Healthy Corners programs, an award-winning model bringing healthy food, infrastructure, technical assistance, and community outreach to small corner stores and neighborhoods without easy access to grocery stores. While our partnership with DC Health is longstanding, the agency has been especially steadfast proactively and a proactive ally in a year of rapid change. As our program sources products from local farmers, empowers SNAP and WIC customers to redeem their benefits on healthy foods, and works with small business owners to build trust and technical capacity, the policies and politics of 2025 have had a direct impact in our work and residents we serve. The Nutrition and Physical Fitness Bureau has helped us adapt to these external changes, collect and incorporate community and partner feedback, and align efforts across other local and federal initiatives that can benefit our residents. Notable collaborations include educating WIC customers about Healthy Corners offerings, informing eligible residents about the Sunbucks Summer Nutrition Program, and coordinating up-to-date information and resources during the disruption of the government shutdown. Thanks to our collective efforts, Healthy Corners has been able to remain resilient and deliver for our residents and small businesses. In 2025, we sold 468,561 units of healthy foods, a total that's up from 390,000 units just 2 years ago. These efforts produced a record total of $699,000 in small business retail sales. We reached an all-time high in redemption rates for our SNAP Match produce incentives after shifting our program model to include even smaller purchases, fruits and vegetables. Now DC SNAP customers purchasing a produce item for as little as just 50 cents at a participating retailer can receive $5 in additional purchasing power for fruits and vegetables in a time of cutbacks and layoffs. We are helping residents stretch their budgets, make healthy choices, and support local businesses with a 97% coupon redemption rate that far exceeds national averages for comparable programs. So far this fiscal year, we have added new Healthy Corners stores located in wards 4 and 8. And because of Healthy Corners is a national leader, we have also worked with George Washington University throughout 2025 to publish an open source best practice guide. The committee, the council, and the mayor deserve credit for steadily investing in effective, innovative food access programs like Healthy Corners. I will skip in the interest of time to say this committee should be proud of what it has done to support DC Health's continued progress and innovative contributors. And please continue to support other programs such as the Joyful Markets, Home Delivered Meals, Produce Plus, and Produce RX, and community supplemental food programs.
Thank you. Carrie?
Good morning, Chairperson Henderson. I'm Carrie Stoltzfus, CEO of Food and Friends. Thank you for your support of our mission and for the time you have personally spent volunteering with us. Food and Friends is a community-based organization that home delivers medically tailored meals and medical nutrition therapy to residents facing serious illnesses. We meet our clients at the point where they're struggling to shop and cook on their own, often making our services their only option. They're referred to us by their healthcare provider to receive nutrition that's tailored by our registered dietitians to address their conditions, symptoms, and side effects. We were the first organization nationally accredited by the Food is Medicine Coalition, meaning we're held to strict standards of nutrient content and food quality and safety. In FY25, with the support of Dr. Bennett, DC Health, Mayor Bowser, and the council, we delivered over 1 million medically tailored meals to over 3,000 district residents and their dependents at no cost to them. Nearly half of those live in Ward 7 and 8. Our meals and nutrition counseling sessions with clients provide critical education and support that help them manage complex conditions like diabetes, cancer, kidney disease, and HIV/AIDS. This year, when healthcare costs are front of mind for all of us, Food and Friends has completed a study showing that our services are associated with hospital cost savings. Clients who received our services saw an average $9,000 reduction in hospital costs over a 6-month period. The top 25% of healthcare spenders, who were responsible for 75% of costs, saw on average $52,000 in savings. This shows that with tailored nutrition, even those with the most complex health issues can spend less time in the hospital and more nights at home. Food and Friends is an investment that bears returns for the individual and for the health system. Our support from DC Health makes it possible to produce those returns. For the coming year, we will request level funding of our $1,335,000 grant from the Community Health Administration. We take the responsibility to leverage our district support with philanthropic funds seriously. For each dollar we receive from the district, we raise $3.65 from other sources. This public-private partnership makes our CHA funding crucial to our ability to serve so many neighbors. We also support the work of our colleagues meeting nutrition needs across the city, including DC Central Kitchen, the Capital Area Food Bank, and Martha's Table. Food and Friends is at a once-in-a-generation growth point, and we plan to double our capacity to serve district residents over the next decade. In the nearly 40 years we've been in operation, DC has invested in this work, and that investment has paid dividends in the health and well-being of thousands. As we look to remain anchored in our home in DC for the next 40 years, we ask that you continue to fill this critical gap in the district's healthcare safety net. Thank you for your continued support of our neighbors and this vital work.
Thank you. And Dean.
Chairperson Henderson, my name is Dean Brenner, and I live in Ward 3. I'm a volunteer with the Alzheimer's Association, for whom I'm testifying today. As a former caregiver for my mom, I care deeply about the approximately 15,000 DC residents living with Alzheimer's and thousands of family caregivers struggling to take care of them. Compared to all U.S. states and counties, DC has the highest percentage of people over 65 living with Alzheimer's disease. Women, African Americans, and Hispanics are all disproportionately affected by Alzheimer's. Thanks to your leadership and your counsel, Ms. Balkis, and Dr. Bennett and the DC Health team, we've made significant progress on Alzheimer's, but we have so much more to do. The most pressing problem we have now is that very few DC clinicians are up to speed on the latest developments concerning Alzheimer's. New research has shown that lifestyle changes can help reduce the risk of dementia well before symptoms appear. There are 2 new FDA-approved medications which are successfully slowing cognitive decline, but these drugs can only be given to people in an early stage of Alzheimer's or even pre-Alzheimer's. And there are now 2 FDA-approved blood tests to detect biomarkers that equate to Alzheimer's, making diagnosis far easier and quicker. But clinicians did not learn about any of these new developments in med school because this is all so recent. So early detection and diagnosis of Alzheimer's, which is now crucial for people to qualify for treatment, is very, very limited in DC. DC residents are not benefiting from these groundbreaking developments because their healthcare providers are often just unaware of them. The most important step that can be taken to modernize DC's public health response to Alzheimer's is ensuring that all DC residents can see a clinician with sufficient training on these recent developments. Fortunately, doing that will not require any funding from the district in its budget. Establishing a minimum standard of training on Alzheimer's and other forms of dementia for all DC licensed doctors, physicians, assistants, and nurses would vastly improve care for so many DC residents. This minimal standard, which could be made to fit within the existing licensing cycles, would ensure that all DC healthcare providers have a baseline understanding of the disease, including the latest developments regarding how to make a diagnosis and the latest treatment options for those who qualify. Adopting this minimal training standard would be the single most important action you can take for DC residents, and it would cost DC taxpayers nothing. Several other states, including Illinois, Massachusetts, Delaware, Kentucky, and Rhode Island, have training requirements. We need that in DC too. With Alzheimer's high prevalence, high cost, and now the ability to reduce risk and offer treatment, it's important to ensure that every DC resident in every ward receive care from a clinician who has the necessary up-to-date training to provide state-of-the-art care. That's why we need a uniform training standard across DC. I look forward to continuing to work with you on this important issue. Thank you.
Thank you. Thank you so much to this panel of witnesses. not just for being here, but for the work that your organizations do on behalf of district residents every day. Rachel, I'll start with you. So you made a suggestion around providing funding so that charter schools or LEAs can hire their own nurse. Now, you know, this committee has gone through this before with the Department of Behavioral Health to mix success. And I'm going to say mix because that first year it did work very well. And then for some LEAs, it got harder after that. Why do you feel differently that this could work for nursing?
That's a great question. So I think we learned a lot from that pilot program, from the logistics of running the program, the way in which the grant was done. We could probably streamline a lot of that. I think our schools have demonstrated on the nursing front slightly differently from the nursing side, they've demonstrated on the nursing side slightly different from the DBH side, is that we have 17 schools that currently do this. So it's not like it can't be done. They use, right now though, it's coming out of their UPSFF funding. And so I think what we struggle with is this is hard to do at a greater scale without some funding. And I think what we've seen is there's a different set of providers that are doing nursing than there are doing social work services. And so there are organizations out there that provide nurses, LPNs, and the oversight required that schools have already built relationships with and can contract directly with to make the process a little bit simpler. And some schools have actually hired nurses in-house, W-2 employees. So I think we've seen this work, and it would just require the funding to do it.
Okay. I mean, I think that at least when I talk to school nurses, for some of them, they actually desire to be at only one school, establish a relationship with the teachers, the families, you know, basically know their kids. And they themselves don't like the idea of perhaps having to rotate amongst various schools. Like they want their elementary school and let that be their group. I'll pose this to DC Health. Frankly, I don't feel like DC Health is in a position to turn down potentially good ideas because they've had such high vacancy in terms of getting the RNs and the LPNs who they thought would come. But we'll certainly ask questions about that.
And we're happy to collaborate on like the design and work with the schools that have already hired so they could share kind of what's working to make this program for the schools that would be part of the pilot program successful.
Okay, I'll ask some questions on that. Dr. Brown, you know, I feel like between Healthy Corners, I don't know. I don't know how DC Central Kitchen is able to keep up with the number of programs that you all have flowing out of your facility. But it has had such a strong impact. And we know that in some cases, changes on the federal funding side have trickled down to have some impact on this. Do you want to speak a little bit more about that?
Sure. And to answer your first question, we have never closed since 1989. So we continue to work, and I work with some of the most amazing, some of the most dedicated people on the planet, and that's how we're able to execute for the community. With federal funding, we've done a really excellent job, a lot of lessons learned over the years to make sure that we braid funding between federal, local, and also philanthropy to make sure that we're not in a position where we're solely dependent on the federal government. That being said, it is a significant piece of what we do, and we want to be, if nothing else, good partners with the federal government. So with all of the uncertainty that's happening, it really is challenging, especially when the local government had to shut down because of the federal government. We continue to run our programming on our own dime. And now we're working with some of the most amazing DC government employees to make sure that we're making up that time when the government was shut down.
Okay. Yeah. I mean, if I'm looking at the documents that we have about DC Health's budget, their budget pressure issues are mainly solely related to federal grants that might have been cut, but the work needs to continue. And so trying to absorb that from the local side. But I think you made a really good point in terms of the braiding question. I don't think we've done that well enough. And I always don't like to be in a position where we are solely dependent on one particular source for funding, because when that source is not stable, then
People
that-
don't get served.
people don't get served, exactly. And the same could be said in terms of the work that you're doing, Carrie, at Food and Friends as well. Dean, I wanted to ask, so just for clarification, are you asking for an additional, what do they refer to it as, continuing education requirement?
Exactly. So
Okay.
right now in DC law, there is a general continuing medical education requirement, but there are two specific set-asides, if you will. One says that physicians in DC, all medical professionals, must get training in HIV/AIDS
Yep.
for X hours. And then a second one says all medical professionals in DC must get training in cultural competency in how to treat patients who are LGBTQ+. So there could be a third that says all physicians must get a minimum, all healthcare professionals must get a minimum training requirement in Alzheimer's and other forms of dementia. That's our ask.
Okay, all right, we'll certainly ask some questions about that. Thank you all for being here today. Thank you. Okay, we're gonna go to the next panel. Max Broad, DC Voters for Animals, Shipla Patel, is the medical director at Children's National. Eric Benna and Dallas Salisbury. All right, Max, when you're ready.
Great. Hello, Councilmember Henderson and Ms. Balkas. It's a pleasure to be with you today to continue the conversation on rodent management and talk about DC Health and, continue to commend them in their work on this. I want to start by expressing deep gratitude to that outgoing program manager, Gerard Brown. I hope he's enjoying sleeping in or something today now that he's retired. His leadership has shaped how the city understands rats. He has emphasized repeatedly, we can't poison our way out of the situation. It's not a rat problem, it's a human problem. And he has said that, the numbers back it up that DC has conducted over nearly 35,000 abatements last year. So we have to ask ourselves, is bringing us closer to our goals? Meanwhile, the harms of poison continue to mount. These products do not just kill rats, they harm the very wildlife that controls rats for free. Raptors, foxes, owls, coyotes, and other predators are turning up poison because they eat contaminated rodents. And not only that, children are being harmed too. At Children's National Hospital alone, there were 12 cases of rodenticide poisoning between May and December alone of last year. California has banned the worst of these poisons, yet DC residents can still buy them online with just a few clicks. That's why we launched DC Responsible Rat Management, the coalition calling for prevention, not poison. As we advocate for what rat experts agree is the best tool to reduce rat populations, sanitation. Dr. Bobby Corrigan, one of the nation's leading rodentologists, puts it plainly. Sanitation is prevention. If we do not cut off the food supply, nothing else will work. We are encouraged by the collaborative approach of new leadership under Andre Pittman at DC Health on rodent and vector control. And we hope he carries forward Mr. Brown's torch centering prevention. If you're listening today, Mr. Pittman, it's been a pleasure to work with you. And hopefully you're not sleeping in. And so other jurisdictions are showing what works when sanitation, not poison, is the center of the strategy. Boston is doing rat-resistant trash bins. Baltimore is trying out contraceptives for fertility control. New York has a rat czar and a rat pack trainings. Somerville, Massachusetts is doing public awareness campaigns. It's happening all across the eastern seaboard. DC should not miss the boat. These are great peers for our city to grow our repertoire of modern approaches that reduce rat populations without harming children, pets, or wildlife. When poison is used by DC Health, responsible management involves retrieving dead or dying rats quickly to prevent secondary poisoning. We want to emphasize this and ask that DC Health clarify how soon staff should return to collect carcasses and what practices they follow to find rats who have ingested the treatment so as to prevent other animals, whether wild animals or pets, from being poisoned by our own government. Climate change makes this urgent, and biologists warn that with climate change, it will accelerate the rat population. Once they're established, they're extremely difficult to push back. Prevention is not optional. It is the only sustainable path forward. We look forward to having Mr. Pittman and DC Health join us on future calls of the DC Responsible Rat Management Coalition, which is open to all. Thank you.
Thank you. I learned so much. Dr. Patel.
Thank you. Good morning, Chairwoman Henderson and the members of the committee. My name is Shilpa Patel. I'm the Medical Director for Impact DC, which stands for Improving Pediatric Asthma Care in the District of Columbia at Children's National Hospital here in Washington, DC. Thank you for the opportunity to provide testimony regarding our continued partnership with DC Health. The Impact DC program is a matrix program of care, education, advocacy, and research that has been caring for the district's highest risk children with asthma for almost 25 years. In fiscal year 25, Impact DC saw over 1,000 children with asthma. Impact DC has repeatedly demonstrated improved care and outcomes for children with asthma in the district through expert, guideline-based medical care, patient and family education, and most importantly, care coordination. Our core goal remains unchanged: to reduce preventable emergency department visits and hospitalizations by strengthening guideline-based care and addressing social and environmental drivers of health outcomes. Asthma is the most common chronic disease of childhood, but continues to disproportionately affect children in the district, particularly those living in wards 7 and 8. Addressing pediatric asthma is especially important for children in the district for the following reasons. The number of DC children afflicted with asthma is more than twice the national average. The district's rate of emergency department visits is over 4 times the national rate, accounting for almost 1% of all ED visits made across the nation by U.S. children with asthma. Children living in wards 7 and 8 have an asthma-related ED visit rate over 20 times that of Northwest DC. The DC investment in Impact DC's novel intervention and collaborative programs has produced real returns in improving asthma care. Impact DC continues to use and enhance the DC-supported electronic asthma registry, which works as a population health data management tool unique to our patients. This tool allows Impact DC to track districts' pediatric asthma healthcare utilization trends real time. Despite an increase in the total number of children with asthma in the district, we learned that asthma-related emergency department visits in the calendar year 2025 decreased by 35% compared to calendar year 2024. Our ability to monitor this data has allowed us to enhance care coordination for our high-risk cohorts. And we define these high-risk cohorts as more than 5 ED visits, 3 hospitalizations, or an ICU visit for asthma in the past year. The data from the registry has also been instrumental in powering an interactive healthy housing map to identify multifamily housing units, buildings in Washington, D.C. with both high rates of asthma morbidity and unhealthy housing conditions. This work has helped to inform an ongoing collaboration between Impact DC, the National Housing Trust, and the Children's Law Center, and is focused on helping 6 of the highest morbidity properties with unhealthy housing conditions retrofit and renovate to create healthy housing for all residents. Our program is also committed to continue our partnership with schools to improve school-based asthma care. And we serve as a resource to train that all school staff are well-versed in asthma. We are excited about the access to undesignated albuterol school health suite and are committed to working to train nurses. With continued support, commitment, and collaboration from DC Health, Impact DC is working steadily towards improving children's quality of life through controlled asthma. I appreciate the opportunity to provide testimony today and would be happy to answer any questions for the committee.
Thank you. Eric?
Good morning, Chair Henderson. My name is Eric Baina. I'm a social worker and I'm Deputy Director of Home Care Partners. We're a nonprofit that provides certified home health aides to DC seniors and adults with disabilities in all 8 wards who are primarily low income and cannot afford to pay for services. We accomplish this through generous funding from DC Department on Aging, and as a licensed home health agency, we are subject to Department of Health regulations, which is why we're here today. We're also a member of the DC Coalition on Long-Term Care, and we've long been focused on the critical shortage in the direct care workforce, certified nursing assistants, and home health aides. I will kind of go off script here and just kind of give my personal experience. Thanks to your legislation, Chair Henderson, it created an advisory committee to merge those 2 certifications. And after this hearing last year, DC Health finally convened the committee, and I was luckily selected to be on it. Just wanted to talk about my experience, and in one word, it's been frustrating. From March to June of last year, we met nearly weekly. We merged curriculum, skills lists. We came up with a smooth transition plan to move all existing license holders by the end of 2025. In July, the Board of Nursing at their public meeting voted to endorse this plan. I remember it was July 3rd. I was sweating. And then nothing happened. it kind of, the fruits of our labor went to DC Health to shrivel on the vine. And, DC Health higher-ups kind of overruled the work of the committee. They came up with a much more complicated bureaucratic plan, the details of which have not been communicated even to me, someone who's on the committee. We haven't met since October. Several of our meetings have been canceled at the last minute. You're sitting at the computer and 2 minutes before you get the cancellation notice. We are supposed to meet tomorrow. So hopefully at that meeting, I'll be clued in on what the newest iteration of the plan is. But as you know, there's been no draft rules released, regulations, nothing submitted to the register, and here we are a year on. Unfortunately, that seems like a pattern. If we just look at DC Health, over 4 years, we've been waiting for Department of Health to approve medication aid training providers. A 2024 rule change allowed DC CNAs to work in home care, but Senior Director Sam Hurley at DC Health said to wait until DC Health issued guidance. We haven't seen that guidance a year later. 2020, the Dementia Training Direct Care Workers Act. It's been 6 years and we don't know how the many thousands of workers covered by the law will fulfill the requirements. The impact of these inefficiencies is very real. It means seniors who are going without care because there aren't enough direct care workers in DC. I'll just wrap up and say that these issues cut across multiple agencies, DC Health, Board of Nursing, DHCF, DOES, OSSI. Our coalition continues to advocate for hiring of a long-term care strategic coordinator to bring these siloed pockets of DC government together. Our DC government partners, starting with DC Health, need to step up and ensure a whole government response. Thank you so much for the opportunity to testify, and I'm happy to answer any questions.
Thank you. And Mr. Salisbury.
Chairman Henderson, today marks 12 years since the Board of Long-Term Care Administration created a subcommittee to explore licensure of assisted living administrators. It is 8 years since the DC Health published regulations creating a requirement for licensing DC administrators. Today marks the 4th year since the assisted living administrator licensure regulations became effective and legally binding, and 3 years since a 1-year waiver expired. Under the code, operation under a licensed assisted living administrator is a mandatory condition of assisted living residents' compliance and licensure, and administrator licensure regulations were promulgated on that date. So years have passed. The administrator license became effective on February 18, 2022. The waiver expired in 2023. The Board of Nursing is considering a new waiver, but it would not retroactively cure 3 years of statutory noncompliance. The condition remains unsatisfied. Yet DC Health continues to renew assisted living residents' licenses as if they were in compliance with the law. This is not a policy disagreement. It is a question of improper statutory execution by DC Health. Residents rely on state-issued licensing as a representation of compliance with the law. They commit life savings, activate long-term care insurance benefits, and accept Medicaid waiver placement based on that representation. When residents have asked DC Health surveyors and facility management about the absence of licensed administrators and the legitimacy of the facility license, they've been affirmatively assured there is no issue. But enforcement discretion does not amend the statute, and it does not bind CMS, long-term care insurers, or courts. If this issue is examined in a federal waiver review, an insurance dispute, or litigation, the controlling inquiry will be whether the mandatory licensure condition was satisfied, not whether DC Health chose to tolerate non-enforcement. That is why this is not theoretical. It is a performance oversight issue for DC Health and the Board of Nursing. I want to acknowledge that the Board of Nursing has taken some preparatory steps, forming a subcommittee, developing a not yet available application, and moving toward a jurisprudence application. They're constructive actions, but subcommittee preparation and no licensure is not licensure. No administrator licenses have yet been issued after 12 years of consideration and 4 years of a legal requirement. and a new Board of Nursing waiver would not alter the legal reality that statutory conditions have not been met since February 18, 2023. So I urge the committee to press the director of DC Health to move forward with this. My written statement includes 4 specific questions. My submission online provides 12 questions for DC Health for the hearing on Friday. The district can resolve this internally through execution and oversight. If it is not, the issue will eventually be examined externally. The question before this committee is whether this gap is closed through responsible action now or whether it is forced closed under federal or judicial scrutiny later. I will note that the current amount of money having been accepted from Medicaid under illegal terms is approaching $500 million that under the statutes could be declared to be fraud by the district because of their failure to comply with the federal code. This is a serious issue. I urge you to take it under consideration, and I urge you to raise the issue with DC Health. They can solve it. They must solve it. Thank you very much.
Thank you. Thank you to this panel. I feel like this panel is a very great representation, just a little bit of what we're talking about for DC Health. We go from talking about rodents to talking about asthma to be talking about long-term care. Like the agency is doing a lot. And also I learned something new from each and every one of you. So thank you. Mr. Salisbury, I'll start with you. We'll follow up about the licensure and compliance pieces. And I don't think it's just DC Health. This is also a question for Department of Healthcare Finance. So we're going to take your suggestions seriously, and then we'll certainly follow up on that front. But thank you for being here and for elevating this issue. Mr. Bennett, I said to the last panel, this is one of those things where I'm very frustrated on. You testified, you were enthusiastic to be able to serve on the advisory committee. You all did the work. We're moving in the right direction. I'm thinking we're making some traction. We're doing the things. And to hear from you, you guys made a recommendation in July and then you haven't heard anything. I guess you had a meeting in October. I think that's what you said. And then every subsequent meeting has been canceled except for, oh, wait. You have a meeting tomorrow, the day before DC Health comes to testify. How convenient on that. I sent a letter to DC Health in January asking for the status of what was happening with this because, again, for those who are not familiar in terms of, we refer to it from the perspective of long-term care workforce, but there are so many different health facilities that are able to use certified nurse assistants in a variety of different ways. So it's not just long-term care, but it is also other industries as well. And your testimony is very interesting in conjunction with their reply, which we did receive, which they said DC Health transmitted the proposed regulatory package for review to the Executive Office of the Mayor on February 3rd. But it sounds like from you that the advisory committee has no idea what was actually submitted.
That's correct.
Turn your mic on because I want everybody here on the record.
That's correct. The regulatory package, if it was submitted on February 3rd, it was not run by us as to what that contained. And I specifically spoke to the DC Health staff on the committee on February the 4th, and I was told that it was still under development. So I don't know what, internal review they're doing and where they are in the process, but it seems like they don't value the committee and their stakeholders' input in their internal review.
This is so hard because I do a PSA every time I do one of these board of insert, right? Nursing, podiatry, et cetera. Trying to get PSA of people to serve on boards and commissions, because I do feel like that's an excellent way to, one, get involved on policy, but also serve your community. And then we have people who give up their time to help devise something, and then you don't even circle back to say this is what the final pieces were. So this is what I'm going to ask, because I also feel like sometimes EOM review is like purgatory. Like it comes over to this building and it hits into a black hole, and I might not see it for another 2 months. I'm just being honest. It would be interesting to know what the differences were in terms of what the advisory committee recommended versus what DC Health settled on. And I don't necessarily know how we do that yet, because you don't even know what they submitted. And so hopefully we could have that conversation and maybe try to figure out something there on the dialogue front.
Definitely. After the meeting tomorrow, I'll send your staff an update.
Okay, great. Thank you. Dr. Patel, Thank you for being here. I pulled up your testimony because I felt like some of the statistics that you were citing here, I think Kristen talked a little bit, well, maybe she did. She talked about a lot of stuff in her thing, but I think she did talk about asthma, if I'm remembering correctly. But some of these statistics, the number of DC children afflicted with asthma is more than twice the national average. The district's rate of emergency department visits for asthma is over 4 times the national rate. And we account for almost 1% of all ED visits made by children in the US with asthma. That's incredible.
It is. I think part of it is also the district is compared to states, so the distribution is not as different. But even when you look at other large metropolitan areas, we're in the top 10 or 15. When you look at the American Lung Association, Allergy Network, when they publish top, childhood asthma cities, DC is in the top 10 to 20.
And this is even, you go further in your testimony to talk about how the Impact Network has even been able to decrease some of these numbers, but still, it's still persistent. What's our biggest barrier here? And I know even from like on the school side of things, we are not where we need to be in terms of the number of families who have submitted an asthma action plan at their school. And so, yeah, when you have a nurse or even an AOM person who doesn't necessarily know what the plan is, that does usually result in a call to FEMS and a trip to the emergency room, et cetera, et cetera, et cetera. How do we improve on this?
So specific to the school, I do feel like school health telemedicine is a very important intervention that other cities have used. So instead of immediately sending a child who may not need to miss school or go to the emergency department, they have consultation with children's national pediatricians to essentially understand if things can actually be done in the school health suite, even if it's by somebody we trained who's not a school nurse, in terms of administrating what a parent would do at home for that child in the school. And then the other thing is having that medication. So I think undesignated albuterol is already it's finally in the schools. We spoke to Dr. Washington, it's there. We're reviewing the protocols with them, making sure the nurses are, not only nurses, but school staff is generally trained to administer that if needed. But I think some of the services that we're losing is the school health telemedicine that we were kind of up-ramping. And so we would really, really love to use the equipment that's already there to kind of continue school health telemedicine so they can actually have real-time consultation in terms of kids missing school unnecessarily sometimes.
What has Impact DC's relationship been with the new Environmental Health Administration at DC Health?
It's actually wonderful. I sit on the DC Health Leadership Committee, and they also sit on that committee with DC Health. So I'm the Impact DC representative along with Yahad and some other community members and DOE, like what used to be DOE and DC Health. So we're just coming up with recommendations in terms of how that's going to move forward. And one of the biggest asks that we have is kind of what was mentioned earlier is kind of communication across agencies. So when something gets reported, there's really no feedback in terms of what actually was done or if something was done. And then the family continues to continue to repeat ER visits or back to primary care without really an understanding what's happening with the housing situation. One of the mechanisms I've proposed is actually something similar to what Maryland does is on CRISP. They have essentially, anytime a housing assessment is done, it's reported onto that. So it really provides anyone who has CRISP access to be able to see what is being done, what was the housing assessment, what were the recommendations, what was done. So you kind of have at least a tool for data sharing when something is done.
Wait, do you guys do a housing assessment for a young person you work with?
We don't. We do. Yes, we do. We screen for housing questions, healthy housing questions, and then we will refer to our healthy housing partners and do virtual healthy home visits, mainly with Yahad. We've also started working with our local DC MCOs to help the partners get reimbursed for that care because it's a very small program right now, and have started conversations with like larger organizations like GHHI, Green and Healthy Homes Initiative, to see if they can be expanded. But that virtual home visit, I think, is one tool that we can use.
What's the bigger driver? Is it mold? Is it carpet? What do we?
It's all of it, but mold and pests, I would say, are the biggest ones. So pest dander, so cockroach dander, mice dander, cat dander, all of that do.
Cockroaches have dander?
Yes, they do.
Let me tell y'all.
It's actually the majority of the dust is human skin and pest skin that's in what's inhaled. And it not only local environments in your healthy housing, when you improve healthy housing, not only do you reduce asthma exacerbations, but you potentially prevent sensitization and future asthma in young children who are developing their immune systems in first like months of life. So I think healthy housing is a really important thing. When we start doing that, we can definitely see those disparities and the rates kind of go down. Of course, it'll see years to see that, but it is an important driver of asthma rates.
Yeah, okay. I now see a little bit at what MJ was kind of getting at here in terms of the agency connection here, because then I'm thinking on my other side, right? I get these alerts from the Office of the Attorney General often in terms of him going after, we're going to call them slumlords, right? Individuals for whom your properties are in complete disarray. You probably can't tell me the last time you put in an air filter, cleaned out your HVAC system, done all of these different things, and you have young children who are living in those environments, which is impacting their health.
So I encourage you to go to the healthy housing map that we created. You can easily see which those buildings are. The buildings that have the highest housing code violations and the highest morbidity and mortality of asthma are highlighted there. And some of the work that we're doing, the National Housing Trust actually, of course, did not seek to help the for-profit landlords, but actually the nonprofit landlords that actually still need help, but are on that list in terms of being the hotspot. So in terms of policy change, I think the housing map is a nice place to kind of go and understand what is the current state of the housing stock in the district and who is managing those properties and what enforcement is really occurring at that level.
And do you label if it is government housing?
It's just labeled as a name. It's not like the name of the building management company.
Okay.
Yeah.
All right. We'll follow up
It's
there.
a public resource. It's available.
Thank you. Thank you for being here.
Thank you.
Max, I didn't know that rodentologist was a job. And I feel like some child at career day would get super into this from that. But, I hear you. Ona here went to, what do we call it? Rat Academy. Yeah, that's a thing we do in DC. I have several colleagues who have introduced RAT acronymed name bills. So this is definitely an issue, and it's something that has come up. And even over the last few weeks in my conversations with Department of Public Works, right, of this slow pace for us to get back to picking up the trash. And our rats are living large in the alleys, truly, because we haven't picked up trash in 5 weeks. And we know that sanitation is part of those issues. And, some of the things that you talked about, whether it be rat-resistant trash cans, although I feel like our rats in DC are different. They are more strong-willed, and their teeth do things that other rats' teeth don't do in terms of their ability to bite through what a normal person might say that's a rat-resistant trash can, but no, they have found a way into those. But then some other things around fertility management and those kinds of things. But it does still come back to the sanitation piece of things. Our public trash and recycling receptacles are a problem, I think, once you get outside of downtown. Do you want to speak on that?
Yeah, absolutely. And just so you know, I testified at the DPW hearing last week, and Councilmember Nadeau also brought up this question of, what does rat resistant look like?
Yeah.
I will say that Georgetown bid has been investing in metal public containers that are completely encased. And that's been really, really exciting to see. And they've also been doing, they worked with a restaurant to do a fully encased cage for their garbage containers to prevent rats that are metal. And so that's definitely a really great approach, because you're right. The public bins that we see that have an open hole in them are just buffet.
Yes.
Yeah, that's the problem. Yeah.
Look, I was walking the dog the other day, and I'm going to go back out and do my own little sort of cleanup situation. These the small parks, the triangle parks right next to the WMATA, it doesn't help that some people are using these public trash receptacles for their own personal trash, which PSA, if you didn't know, don't do that.
Don't do that.
Don't do that. You clog it. It's not designed for that type of thing. But also, whether it be DPR, whether it be DPW or DGS, acronym of alphabet soup, who's responsible for trash, recycling, and compost, like, we need to be more consistent in our scheduling in terms of how we address some of those things. But to your other point of your testimony around poison
Mhm.
and what we can do there, because the internet is a wild, wild west
Yeah.
place.
Yeah.
We need to do some more further investigation there.
Yeah, absolutely. And just going back to your point about, DPR, GGS, DPW, all like, I think that's something we're investigating now as a coalition of like, does there need to be more coordination amongst those agencies, and what would that look like, and how would that benefit DC? So we're examining that question ourselves.
Yeah.
And then as per poison, I brought this up before, but like, like in my own neighborhood, around the block from a dog park. Pardon the Freudian slip. Somebody sprinkled, rat poison, like it was salt before a snowstorm. We can't be doing that. Like we can't just be having people just put poison everywhere. It's meant to attract animals. It doesn't just attract rats, it attracts animals. Not only does it attract animals, it's brightly colored, it looks interesting. If you're a kid, you're spending more time close to the ground, you don't want to be exposing yourself to that. We know people are coming into the hospital with having ingested poisoning, especially young children.
Okay, we'll ask TC Health some more questions about that. If you haven't uploaded your testimony for the record, please do so, but thank you all for being here today. Thank you. Okay, I broke my own rules. I went over my own time. Don't do what I did. Okay, Sarah Bootwell from GW Medicine, I'm sorry, that was Dr. Sarah Bootwell. Dr. Rochelle Logan from the DC Primary Care Association, Catlin Roth, and Stella Dawson Klein. Okay, Dr. Bootwell, when you're ready. Oh, just lower your mic just a little. There we go.
There you go. Thank you, members of the DC City Council, for the opportunity to speak today. My name is Dr. Sarah Boutwell. I am the Director of the Division of General Internal Medicine at GW Medicine and a practicing primary care physician. Our division cares for more than 28,000 patients, many covered by Medicaid and Medicaid expansion, and we train the next generation of physicians who will serve this city. Since November 2024, DC Health funding has supported our lean transformation work in primary care. This initiative focuses on redesigning everyday clinical workflows so that care is more reliable, more efficient, and more patient-centered. Lean transformation addresses the operational barriers that quietly erode care quality: unnecessary waiting, inconsistent workflows, duplicative tasks, and administrative burden that pulls clinicians away from patients. We call our model PIVOT, patient-inspired, value-oriented transformation, because improvement priorities come directly from patient and frontline staff experience. In our first workflow redesign, we found that 14 medical assistants were rooming patients 16 different ways. That variation created delays and errors. By developing standard work together across roles, we improved reliability and coordination. Following that change, hypertension control increased by 2%, diabetes control improved by 4.5%, and patient satisfaction rose by 11%. We then expanded this approach to scheduling, paperwork, and medication refill processes. Completed appointments increased by 6.5%, improving access to care. We launched targeted nurse outreach for patients with uncontrolled blood pressure and overdue mammograms. One patient told us that it was the first time she felt truly seen by a doctor's office. We also reduced unnecessary electronic message volume, shortened response times, and reduced after-hours documentation time for providers, cutting daily pajama time by 6 minutes per clinician. Small operational gains like these compound into meaningful burnout reduction and better retention. Workforce outcomes have been equally important. Staff engagement scores rose substantially, team cohesion improved, and medical assistant turnover declined. After 1 year, every team member reported feeling part of the care team. That cultural shift is essential for sustaining high-quality primary care. In closing, this grant has shown that when we invest in frontline teams and give them the tools to improve their work, Everyone benefits. Lean transformation has helped us deliver better care, improve access, and create a healthier workplace. Sustaining and expanding this work means continuing to invest in primary care, not just as a cost, but as a foundation for a healthier DC. Thank you for your continued support and commitment to our patients and communities.
Thank you. Dr. Logan.
Good morning, Councilmember Henderson and Committee on Health members and staff. I am Dr. Rochelle Logan, Chief Program Officer for the DC Primary Care Association. The DC Primary Care Association drives collective action to sustain health centers and their impact on transforming care. Our vision is that every resident in DC and every DC community has access to high-quality preventative primary health care. We appreciate the opportunity to provide testimony regarding oversight of DC Health. DCPCA's partnership with DC Health spans multiple administrations and bureaus. We partner closely with the DC Health's Cancer and Chronic Disease Bureau in its efforts to improve cancer screening and care outcomes. Community health centers play a critical role in prevention, early detection, and ongoing management, particularly for populations that experience barriers to care. By embedding patient navigators who work alongside care teams, we can mitigate barriers and improve screening completion and follow-up outcomes. Our health centers provide prenatal care and share DC Health's focus on reducing preterm and low birth weight deliveries. DC Health developed valuable new data reports that provide a closer look at perinatal outcomes across communities. Still, the overall data and key measures continues to worsen, and DC remains in the bottom quartile in state rankings on most measures. The lack of progress is now intersecting with significant erosion in the healthcare safety net. DCPCA urges DC Health to work with sister agencies, specifically DC Healthcare Finance, to implement the following remedies. For one, we would like them to authorize community health centers to certify presumptive eligibility for pregnant patients. Health centers already support their patients in applications for health coverage, and we are confident that they will meet the standards for presumptive eligibility authority. Initiating coverage quickly will mitigate critical delays in care, particularly for high-risk patients. Secondly, extend postpartum coverage for the full year to all women eligible for coverage during pregnancy. Again, we understand that a lot of this may fall under DC Healthcare Finance, but it is important for DC Health to be aware of this as they're creating new initiatives. Failure to implement these policies may lead to continued increases in low birth weight and preterm birth, maternal morbidity, infant and maternal mortality. We thank Dr. Ayanna Bennett and her talented and dedicated team. By working to transform the healthcare delivery system, DC Health plays a critical role in improving population health outcomes. Thank you.
Thank you. Catlin? Or?
Good morning.
Morning.
I'm Dr. Andrew Sumner. I'm here on behalf of Dr. Catalin Roth, who is seeing patients today. So I am a licensed physician in the district. I'm a resident of the district. I have been working as a consulting physician in the death with dignity law. That's where we're here to talk about death with dignity today. So I'm just going to read Dr. Roth's testimony for the record. Good morning. My name is Catalin Roth. I'm a physician practicing internal medicine, geriatrics, and palliative medicine in the District of Columbia. I've been licensed in DC since 1997. I'm board certified in internal medicine, hospice medicine, geriatrics, and palliative medicine. I'm a founding board member of End of Life Options DC. I started my medical career during the AIDS epidemic, and I've witnessed much terrible suffering over the years. I believe that physicians have an obligation to provide dignified palliative care to patients nearing the end of life. And I believe that competent patients who are nearing the end of their life have a right to request aid in dying. I've been prescribing medication under the DC Death with Dignity law since 2018. This is compassionate care. Aid in dying is but one option at the end of life. The DC law supports the autonomy and dignity of patients and prevents unnecessary suffering. Although good hospice and palliative care can ease the suffering of dying for many, I've seen many patients whose suffering has not been able to be relieved despite excellent palliative care. DC law is very similar to the laws of many other states in the United States. We have excellent data on the safety of aid in dying for more than 30 years of cumulative experience. DC law is only available to persons who are DC residents who have a limited prognosis and who are mentally competent. Process takes several weeks, several written and oral requests, and the confirmation by a second physician. Physicians apply the rules very strictly with humility and care. There is no evidence of errors, abuse, or of a slippery slope. I would like to make several points. When the DC law was first passed, the Department of Health provided education to physicians, hospices, and the community about the law. But these efforts stopped with the COVID epidemic. There's a great need to educate doctors and to inform the public about their rights under the DC law. Department of Health needs to step up here. DC Board of Physicians should be supportive of the law and of patients and doctors who seek information and support and referrals. Currently, they have declined requests to provide any physician education. Finally, Department of Health needs to have better administrative, legal, and IT support for less experienced doctors seeking to help their patients, including offering referrals and mentorship. Thank you very much.
Thank you. Can you just tell me again your name for the for the record, Doctor?
Andrew Sumner, Sumner.
Okay. Thank you, Dr. Sumner. All right, Stella.
My name's Stella Dawson. I am the widow of Mary Klein, who worked so hard for the passage of the Death with Dignity Act in 2016. As you know, that act has been under continual attack from Congress. Most recently, a bill was introduced that would not only repeal the bill, but ban the district from ever reenacting it again. And I've been lobbying with end-of-life options in order to ensure that they don't overturn the rights of DC citizens to choose, have the option of a peaceful death. One of the chief arguments that the opponents use is that medical aid in dying is assisted suicide, and it opens the door to abuse of vulnerable people. And the primary tool that we have in responding to those criticisms is the good, reliable data that we collect. DC Health is required to collect that information and issue an annual report, and yet it's failed to release any report since 2022. I urge you to correct this problem. It leaves the impression that the city has something to hide, and it deprives policymakers and us as advocates of the essential facts that we need. Let me illustrate for you some of the ways in which we have used this data in order to defend medical aid in dying laws. I'm quoting from a report from Compassion Choices that relies on the many jurisdictions around the country that allow medical aid in dying. The data shows that the claims that MAID pressures the elderly and disabled to use the law, they're not supported. The average age of people who, the range of ages of people who have used medical aid in dying, they range from 19 to 101. 21% are under the age of 64. The median age certainly was 73, but that's to be expected given the comorbidities that people as we age get, so you're going to die as you get old. So the allegation that it puts pressure on the elderly, that they're most at risk of using medical aid in dying, the data shows us that it certainly is not just the elderly who take advantage of this law. In the district, the age of people on the reports that we have showed that they ranged from age 40 to 98. And looking at the diseases that are reported, 67% of the people who use the law are dying of cancer and 11% of neurological disease. A physical disability, which is what the opponents say will put pressure on people who are disabled to use the law, a physical disability will not qualify you for the medication. So there's no evidence that anybody who has only a physical disability has ever been able to access the medications. Secondly, it says that poor people are most at risk. But when you look at the data would point to those people who are probably the most privileged in our society who are most likely to use the law. White, college-educated, and a slight bias toward males. This is why this data is so important, that we can answer some of the criticisms that are leveled at it. And I do urge you to make sure that the District of Columbia is releasing its reports so we have the evidence, so we can respond to the attacks, the egregious attacks that are constantly going on Capitol Hill.
Thank you. Thank you to this panel of witnesses for your testimony. Ms. Dawson-Klein, I'll start with you. I have been asking for these reports, I think since the day I became chair of this committee. They're not terribly long. We're talking like 2 pages. Why we are so far behind in being able to produce this, I think you're spot on. It is providing fodder for those opponents who want to suggest that the district is doing something nefarious because we can't possibly put out a 2-page report on what is happening. And so that allows for, I said this morning, I was doing an interview on a completely different topic, but it was talking about how in the absence of transparency and absence of information, we allow for misinformation to flow and to take hold. And so this is my urging again to DC Health. I'm gonna ask you on Friday. Because again, we're talking about 2 pages. And so I have to wonder, they're probably going to tell me EOM is reviewing it. And when I told y'all, EOM is like purgatory in this building in terms of reports. But like, I don't understand how it could take years at this point to review data that you have, data that is, forms had to have been signed. So it's not a question of, oh, can we decipher? It's literally just publish and let that be that. So thank you for being here and for your continued advocacy and defense of a local law that went through the process here in the district. And Dr. Sumner, thank you for being here to read Dr. Roth's testimony because you're right, this is something that's under continuous attack, but we appreciate your continued advocacy and engagement on this particular issue. Dr. Logan, thank you for being here. Thanks for the work of the Primary Care Association. As you were sort of talking about some of these things, I was like, nope, this is healthcare finance from 2 weeks ago, but I think everybody has a role in terms of when we're talking about preventative care. And since I have so many physicians on the panel, even though, no, I think you all see adults. No one said no one's a pediatrician, so everybody sees adults. Okay, earlier in our first panel, there was, well, not our first panel, earlier, Dean Brenner from the Alzheimer's Association suggested that there be a continuing education requirement. So in DC, we have a continuing education requirement about treating individuals with HIV/AIDS, culture and competency for LGBTQ community. And there's a recommendation that there be some training around Alzheimer's and dementia. What are your thoughts on that? Not that you're speaking on behalf of any of the organizations for which you are representing, but you as a physician who is licensed to practice in the District of Columbia.
As an assistant professor and working with learners at all stages, there are many, many things that demand our time. And while I fully respect and understand the concern about Alzheimer's and the impact of dementia on the population, I would say that there is definitely more understanding that needs to happen in terms of the impact on our population. Our population is aging, and so dementia is certainly something that has an increasing impact on the care that we provide. How much of that time should be directed at dementia versus nutritional needs versus asthma? These are a lot of different things, and I don't think that I could make a comment exactly what needs to be part of CE at this point.
Okay. Anyone else want to add? You're just going to let Dr. Boutwell take it all by herself. Okay, that's fine. That wasn't the topic for which you came to testify. And I do want to ask you a question, Sarah, about the testimony that you did provide about the transformation work that happened at GW Medicine. This was a grant or from a grant, I guess in part by DC Health?
This was a grant. It was Lean Transformation in Primary Care. So it was through the Primary Care Office in DC Health.
Okay. And I mean, some of the statistics that you cited in the improvements of just workflow design are pretty incredible. I think it kind of speaks to sometimes it doesn't require a monumental shift, but that small changes can have big impact in terms of patient care.
Correct. This was nothing that we did was extreme or unusual. Honestly, a lot of it was just learning how to listen to each other. We take
Within the organization?
Within the organization. So we take time to actually sit together, medical assistants, administrative assistants, nurses, physicians, APPs, and actually listen to each other about what the work is. And by doing that, we're learning how we're wasting our time. A good example is when I would need to do a vaccine for a patient at the end of the appointment, I couldn't find my medical assistant. So I'd run laps in the clinic. And we simply moved so that we shifted where people were sitting. I sit next to a medical assistant now who usually is handling 2 or 3 doctors, and I can find them. And the patient gets their vaccine quickly. I get fewer steps, but I'm okay with that because the patient has better care.
Thank you. All right. Well, thank you so much for being here. Thank you. Please provide your testimony for the record. We're going to go to our next panel, but I have a momentary question, so hold on one second. All right. Okay. Dr. Julia Reed from Potomac River Clinic, Dr. Charlene Otley from Potomac River Clinic, Meredith Oliet, apologies if I'm getting that incorrectly, and Nick Stavely from Fresh Farm. Okay, Dr. Reed, when you're ready.
Good morning, Councilmember Henderson and the members of the committee. My name is Dr. Julia Reed, and I'm a pediatric audiologist serving children and families in the district. I evaluate infants who do not pass the newborn hearing screening and guide families through early diagnosis and early intervention. Permanent hearing loss affects approximately 1 to 3 out of every 1,000 newborns. It is a low incidence but high impact disability. The first months of life are a critical period for brain development. When infants do not have timely access to sound, the brain reorganizes in ways that increase risk for language deprivation and long-term educational, social, and vocational challenges. Hearing technology nowadays is highly advanced, making it possible for children with deafness to have outcomes like never before. Children who have access to these technologies early enough have significantly better language, educational, and social outcomes than those who do not. In fact, when a child receives early intervention, we can mitigate against early delays and ensure them the same opportunities and outcomes available to their hearing peers. Additionally, early hearing care reduces long-term societal costs, which are estimated to be more than $1 million over the life of each child. That is why national standards, known as the 1-3-6 benchmarks, require screening by 1 month, diagnosis by 3 months, and enrollment in early intervention by 6 months. DC is screening newborns, but screening alone does not produce these outcomes. Without a strong connected system that carries families from screening to diagnosis to intervention, the process stops short of what children need. Nationwide, about 25% of infants who do not pass the newborn hearing screening are lost to follow-up. In DC, that number is nearly 80%. In 2022, 213 infants born in the district did not pass their hearing screening and required diagnostic testing, or an ABR, auditory brainstem response test. Only 13.6% received the ABR by 3 months, and only 22% received an ABR at all, with the rest being lost to follow-up or documentation. Based on the expected incidence rates, an estimated 22 infants with permanent hearing loss may have gone unidentified in that year alone. And this is not a parental issue, it's a systems issue. Barriers include gaps in data tracking, limited diagnostic capacity, cross-state coordination challenges, and insurance obstacles. The district has the ability to fix this With stronger follow-up systems, transparent reporting, and coordinated oversight, we can ensure that no infant is lost between screening and intervention. Early identification works, but only when the follow-up system works. Thank you.
Thank you. Dr. Otley?
Good morning, Councilmember Henderson and members of the committee. My name is Dr. Charlene Otley, and I'm a speech language therapist in the district, and my work focuses on ensuring infants and young children receive timely hearing identification, intervention, and family support. I appreciate the chance to speak today. Across the United States, the quality of and access to healthcare still varies widely, and those differences disproportionately affect racially, ethnically, and socioeconomically marginalized communities. We often describe these patterns as health disparities, meaning measurable differences in outcomes. But many of the differences we see in real life are better understood as health inequities, unjust barriers and conditions that persist when people are not treated as equally deserving of timely, high-quality care. These inequities are very real in hearing healthcare. Early hearing screening is important, but it is only the first step. Outcomes depend on what happens next, whether families can get timely diagnostic testing, reach early intervention, and access the supports their child needs. Here in the District of Columbia, we see this clearly. Loss to follow-up is highest in wards 4, 7, and 8. This means that too many babies, particularly those from marginalized communities, are not getting to the next steps fast enough, and we know firsthand that delays in the early months matter. Families are not the barrier, systems are. Limited language access, complex referral pathways, and institutional mistrust shaped by historic and ongoing inequities can delay the coordination between hospitals, diagnostic centers, and early intervention services. When information is not clear, culturally responsive, or linguistically accessible, and when navigation depends on time, flexibility, and insider knowledge, families can fall through the cracks. National early hearing detection and intervention data and prior studies show diagnostic follow-up is significantly lower for infants of mothers of color, including Black, non-Hispanic, and American Indian and Alaska Native mothers, and those from socioeconomically marginalized backgrounds. The stakes are high. For children with severe to profound deafness, the strongest spoken language and educational outcomes are associated with cochlear implantation as early as possible, ideally before a child's first birthday. Yet research shows Black and Hispanic children are less likely to receive CIs in a timely way, even when privately insured. This tells us that the problem goes beyond insurance. It points to racial inequity in access and coordination and the ways our systems can perpetuate them. When hearing loss isn't identified or addressed early, infants can miss a critical period for brain and language development. That can create lifelong educational and social challenges, a cascade of missed opportunities starting in the first months of life and compounding inequities over time. This is why we are acting. We aim to redesign the pathway that connects families, providers, and public health so that families can act on screening results without delay. This is a solvable problem. With timely identification and coordinated access to services, we can stop preventable delays from becoming lifelong barriers, and we can start equity at the very beginning. Thank you.
Thank you. Okay, Meredith, help me say your last name. Willette?
Willette.
Oh,
I know it's a doozy.
okay. Meredith
Wouldn't have
Willette.
guessed that, right?
No, I mean, I was like, is the O silent? It's fine. Go ahead.
Good morning, Councilmember Henderson and members of the committee. My name is Meredith Willette. I am a speech language pathologist and the clinical director at the Potomac River Clinic, a nonprofit serving deaf and hard of hearing children in the District of Columbia. A child's hearing outcome should not be determined by race, family income, or a family's ability to navigate fragmented systems of care. But right now, too many families face preventable barriers between a newborn hearing screening and the diagnostic testing and early services that follow. In partnership with DC Health, we currently provide no-cost ABR testing for DC residents, and we offer the shortest wait time for unsedated ABRs in the region. Nevertheless, all of our efforts after 20 plus years, we too often still meet families who found out their child is deaf after several years of being misdiagnosed with autism or intellectual disabilities, when in fact it was an unidentified hearing loss. Even when families are ready to act, the system doesn't make it easy. Our clinic is small and not metro accessible, which can make it hard to reach, especially for families who may have less flexibility with transportation, work schedules, or childcare. That's why we're proposing a mobile audiology clinic so that we can meet families where they already are by bringing screenings and diagnostic services into communities like daycare centers, libraries, churches, federally qualified health centers, and neighborhood events. We can reach more infants earlier, reduce missed follow-ups, and connect families to the right supports quickly. Our focus is the first few months of life because we know early identification and intervention make a profound difference. Families need a continuum of support, and our plan is to first strengthen the coordination and outreach with DC Health, birthing hospitals, pediatricians, FQHCs, and other referral sources so that referrals are streamlined and that families can receive the clear next steps. Second, to remove barriers to diagnostic testing by providing timely, no-cost ABRs, offering flexible appointment times, and ensuring interpreter access so that language is never a barrier. Third, to accelerate access to amplification and cochlear implant evaluations by offering free loaner hearing aids and a streamlined path to specialty care. And fourth, provide ongoing case management so that families aren't navigating this alone and infants are connected immediately to the early intervention and culturally responsive resources. With your partnership, we can reduce loss to follow-up in DC and ensure that every baby with hearing loss receives timely, equitable access to diagnosis, support, and intervention. We've provided a joint written statement with additional information and data, and we are happy to answer any questions. Thank you.
Thank you. Nick.
Good morning. Thank you, Chairwoman Henderson, for holding this hearing and allowing us to speak on behalf of district residents, DC Health, and our local farmers. My name is Nick Stavely, and I am the Director of Food Access for Fresh Farm. I'm here today to express our gratitude to the Council for increasing funding for the immensely popular Produce Plus program in FY25, to share about the program's impact over the past few years, and to look forward to the future of the program. Fresh Farm is proud to partner with DC Health to manage this important program, which improves resident health and increases equitable access to fresh fruits and vegetables for underserved Washingtonians, especially for those living in wards 5, 7, and 8. Day in and day out, Fresh Farm is able to push Produce Plus forward because of our close partnership with the DC Health team, who work tirelessly and creatively to improve the health of district residents. In 2025, because of the increase of funding from the DC Council, we were able to approve 11,000 residents for the program, a 37% increase over last season. These folks spent over $1.2 million on fresh fruits and vegetables at over 50 farmers markets, mobile markets, and farm stands across Washington, DC, a 22% increase in spending over 2024. Through our work with DC Health, we have been able to move more funding for fresh fruits and vegetables to DC residents every single year since we began managing the program in 2022. 2025 also marked the fourth straight year that more than 2/3 of program participants were residents of wards 5, 7, and 8, areas that showcase the worst of our city's disparities in food access, income inequality, and a legacy of systemic inequalities that impact communities of color, underscoring the consistency of our enrollment and outreach efforts. Consistently, under Fresh Farm's management for the past 4 years, the majority of all participants spent at least 80% of their allotted funds, with more than 1/3 of participants spending 100% of their allotted funds every year. This year, we were also able to leverage the Produce Plus program technology in order to help seniors take home more than $400,000 worth of fresh fruits and vegetables, in addition to the Produce Plus benefits being spent. In 2025, nearly 3,000 respondents completed our end-of-year survey, with 97% saying that they agreed or strongly agreed that because they participate in Produce Plus, they eat more fresh fruits and vegetables and that they feel healthier. What's more is that in 2023, we added a survey question asking if folks felt that they were treated with respect while using Produce Plus. And every year since we added that question, no less than 97% of respondents agreed or strongly agreed. And that's not just when folks are out at market throughout the whole summer, buying between all the participants and the farmers. That's also throughout the thousands and thousands of phone calls, emails, text messages, threads that our staff uses to communicate and support district residents. Produce Plus is a vital resource that is trusted by thousands of district residents. Although I'm here on behalf of the program, I do need to acknowledge and I want to shout out the other Equitable Food Access Initiative grantees like DC Central Kitchen's Healthy Corner Store program, Food and Friends, Capillary Food Bank, et cetera. All of these programs work together to improve the health of district residents. Fresh Farm would not have been able to make such progress with this program without DC Health support. The community asks you to prioritize the Produce Plus program as we head into a new budget year together. Thank you again for the opportunity to provide testimony today.
Thank you. Thank you to this panel of witnesses for your testimony. I'll start with Nick. Nick, you know, as you mentioned, we have a number of healthy food access programs, whether it be the Emergency Food Assistance Program, medically tailored home meal delivery, Joyful Markets, Produce Plus, Healthy Corners, the stuff that we do for WIC. I love the Produce Plus program, and I think one of the things that has made it so easy for us to, when we advocate amongst our colleagues around placing money, is because Fresh Farm administers this program so well. You don't always find that in terms of like government programs, but you know, it wasn't a large enhancement that the council did, but even with the enhancement that we were able to do, you guys cut the wait list in half, which is
Yes, that's correct.
huge. Still a wait list. Still, you know, we still got a couple thousand people who are still trying to get into this program.
2,000 folks.
But, you know, being able to have that type of impact, I think speaks to it, but also I think speaks to the popularity and the growth of the program. And I know that we'll have some testimony from some participants and some of your market champions on that. What else could help?
Increased funding to fully eliminate the wait list. I'd say that we have never marketed the program since we've been managing it.
Wait, so you've never marketed the program and yet you've had this like immense growth
Correct.
since its inception?
Yes, yes.
Word of mouth is your best marketer.
It is, and one of I don't know, it's highlighting, I think, the need for Produce Plus and all of these other food assistance programs with just additional societal pressures and everything with the federal support. Produce Plus is, I think, really unique in how much flexibility we have to make the barriers to entry as minimal as possible. Fresh Farm also runs matching programs for federal and local benefits spent at market like SNAP, WIC and Senior FMNP, but the flexibility of the local funds with Produce Plus has allowed us to get those funds to people easier with less input and less buy-in monetarily from them. We make the funds available to them without requiring a match. So I think we're almost finding that kind of equilibrium point of what the like natural demand is for the program. This round of approval and the spending is also without us doing additional community engagement or communication directly with participants. There's so much work we're capable of doing via email or text or phone call to improve the spend rates and improve the card activation rates, but we've been prioritizing increasing the breadth of the program, but there is still a lot of work that is fairly straightforward for us to increase the depth of the program and who we're serving.
Can you just remind me again, what was the spend rate in FY25? Like what percentage of folks actually spent all of their dollars?
38% of everybody who participated spent 100% of their funds, and 58% spent at least 80%. 58% of everyone who activated a card spent 80% or more of their allotted funds, and 38% spent absolutely all the funds that we gave them. And this is about with 75% of total people approve activating a card, which even with the big increase in the approvals, that metric is in line with previous years. So there's a lot more there's people we approve that don't activate a card. There's people that activate a card and they don't spend that much. With our digital management of the system and our text capacity and like phone call capacity with our wonderful staff, there is a lot more outreach we could do to nudge more folks to spend that we've been just running up against the food budget.
Yeah, I just want folks to underscore for those in the public, particularly for our seniors for whom I think the minimum that like the bare minimum you can get on SNAP as a single senior is like $30 a month. So these types of programs where you're able to braid various pieces, plus the SNAP match, plus the other, like that's what's helping people get by. The SNAP benefit on its own, I don't know anyone who could survive off of $30 a month, period, right? But thank you for being here. We'll certainly talk to the next panel about that. Dr. Reed, Dr. Otley, excuse me, and Ouellette. Yeah. Okay. Thank you guys for being here and for the advocacy that you're doing on behalf of, pediatric hearing, frankly, which leads into speech and language pathology. Was I right in sort of hearing, well, there's two things. So one, Dr. Reed, you mentioned in your testimony, 80% of the newborns in the district who don't pass the hearing screen are lost to follow-up. Did I hear that? You would use your...
Yes, that's correct.
Okay, so is that a pediatrician referring someone to a specialist such as yourself?
No, so the newborn hearing screening, when you're born in a hospital, that is something that is offered before discharge. And if you do not pass that, then you're referred for a second screening, an outpatient screening. And then after that screening, you're referred for a diagnostic evaluation. And so people who do not pass the two initial screenings, that was the 80% lost to follow-up. They don't move on to get the next step, the diagnosis, whether it's a diagnosis of hearing loss or a diagnosis of normal hearing, just like a false positive on the screen.
Right. Okay, so it's been a while since I've done this, but so the screen happens in the hospital. Your follow-up would happen at your pediatrician visit?
So different
Or you
centers
have to come back.
Different centers offer it, and so that's part of the. I'm not sure the percentage of people who get that screening, that second screening, but part of that oversight of who is doing that second screening is where there seems to be people falling out of the pipeline. And then, so that's something that our clinic offers. There's other clinics that offer that as well. You don't have to be a trained audiologist to do the screening, but that next step, that diagnosis, is done by an audiologist.
And what is the largest barrier? Is it the ability to get an appointment in a timely fashion or something else?
Yes, and.
Okay. Dr. Otley, I don't know if you want to add to that.
Yeah, I think that is one of the biggest barriers. Transportation, language access, the long wait times, I think is one of the biggest barriers that people are facing. And just being able to access that service. And then just the double screenings, right? A screening in the hospital, another screening, and then diagnostics. So there's a lot of loopholes that people have to go through just to get to the end result.
Okay. But in a logical sense, though, if a newborn fails it in the hospital, it's documented in their papers for which they would take upon discharge that you should technically take to the pediatrician for that first visit a week after being born. Yeah? Yes, please.
And that's one of the problems is how much is lost to follow-up and how much is lost to documentation. So in 2020, DC passed the Healthy Babies Bill, but it's actually still waiting for hospital regulations to come forward. And so what is collected at the birthing hospitals when a baby fails a newborn hearing screening is entered into a database in DC that's called Oz. And the Oz database is reliant on a phone number and a name. And that's of the baby for the parent, one name and one phone number. And that's all that's moved forward. So it's the onus is on the parent to follow up on that. So right now, unlike our neighboring states, Maryland and Virginia, that collect pediatrician information and everything else, we don't have a way to reverse find these families. And so part of our plan is that mobile unit, because we work with DC Health, and so they refer babies to us if people call them. So right now, if you leave a hospital and you get this referral sheet slapped in the middle of this, and it just gets lost in that pile of paperwork with an exhausted parent leaving a hospital, particularly if you're introducing language barriers where they didn't understand what that referral meant. Oftentimes, the parents share with us that someone sort of undermined or diminished, like, oh, it's probably nothing, it's probably nothing. So you're a sleep-deprived parent, and now that pressure is on you. So that's why we would like to have a single point system, like a lot of other states in the United States.
Okay.
That run, like in Oklahoma, they have a program where one nonprofit administers all of the follow-up screenings and diagnostics, and they actually only have it's less than 5 to 10% loss to follow-up because they're going out, they get the information on these families.
One-stop shop.
Exactly. And so that's why we could break down the language barrier, the transportation barrier. And when you look at in our testimony, the information from wards 4, 7, and 8 are where the highest percentage.
Which is interesting to me when you said Ward 4, because I was like, wait a minute, we don't normally have Ward 4 in the mix of these conversations, but given the language differences in Ward 4, now this makes a little bit more sense.
Right.
Okay. All right. We could follow up more on that. This seems like as you sort of mention it, right? Like, it is kind of weird what we do to newborn parents, but like they literally discharge you with a folder that somebody is expecting you to read somewhere in between of your 12th diaper and your 2 hours of like closing your eyes. And you're supposed to sort of digest all of that information.
And hearing loss is often concomitant to other health challenges. So if you leave the hospital with a preemie or any other health disparity, and you're worried about nutrition or something else, the cascade of where this might fall, if someone told you it's probably nothing.
Like the biggest thing I think they used to prioritize was about birth or weight, like making sure your baby maintains weight. That was like that should be your focus because that's what's going to come up in the pediatrician conversation, not some of these other things.
Exactly.
Okay. This is super helpful. Thank you so much for being
Thank you
here
so much.
and advocating on this. We're going to go to the next panel. If you haven't provided your written testimony for the record, please do so. Marie Brown, Kimberly Price, Juanita Blessingame, and Brenda Person. Oh, it doesn't matter which order you sit in. We'll just call you the way we call you. Good morning. All right. Miss Brown, when you're ready.
Good morning.
Good morning. Oh, if you could just lower the mic down so they can hear you at home. There you go.
Okay, great. Good morning, Committee on Health members and at-large Council Member Christina Henderson. I am Marie Brown, a lifelong DC resident, and I appreciate the chance today to discuss the impact of Produce Plus program for both myself and many other DC residents. 10 years ago, I started working as a market champion and also began shopping as a customer with the program. Produce Plus plays an important role in supporting food insecure individuals and families, particularly our seniors, who I am passionate about helping. Helping seniors to sign up and attend farmers markets not only improves access to fresh local fruits and vegetables, but also encourages social gatherings. The markets foster a sense of community, allowing people to connect, make friends, and keep each other informed about what's going on. Farmers markets also provide variety and education. You can experiment with different ways of eating, especially through cooking, demos, and tasting, as well as find culturally important foods like fresh peas and lima beans. Access to different markets means more food variety and choice. Children are also experiencing different foods and introducing their families to them. Produce Plus is impacting generations. Empowered with the financial means to be able to do so, DC residents are making healthier food choices through Produce Plus. The vision and the commitment from DC Health to improve the health of district residents is a key factor in the success of Produce Plus. This is important because even when employed, residents may still face challenging times, and Produce Plus address the diverse needs and those living in the district. In 2025, we received almost 14,000 applications to the Produce Plus program. And even with the increased fundings, we still had a wait list of 2,000 individuals. The program's demand is still evident, especially in wards 5, 7, and 8. We ask you to prioritize the Produce Plus program as we head into a new budget year. It is vital and proven resource of DC residents that needs your support and protection. Thank you for your time and your considerations.
Thank you. Ms. Price?
Good morning, council members and Anderson. Thank you for the opportunity to share. My name is Kimberly Price. I am a both customer and mock champion for Produce Plus. One day, almost 14 years ago, I was on the way to the doctor. Then I spot a sign about Produce Plus, a program offering fruits and veggies for DC residents. Now I admit, it was good to be true, but I found out it was real. It's a lifetime for low-income residents, and it doesn't have any benefit like Medicaid or SNAP. This program let us go to the market without losing benefits. The money we spent on groceries can go to other things and keeping our plates healthy. Being part of Produce Plus has made eating healthier on a tight budget. When I first joined Produce Plus, we used the paper checks at the market, and our seniors were standing in long lines. So I spoke up and I got involved. Now I'm proud to be mock champions with Fresh Farms, making sure everyone get they need. And you know what happens? When I sign people up, it's like a ripple effect. You tell one person, they tell your friends and family. In 2025, we were thrilled to be improve more people for the program. Thank you for increased fundings. But even still, we have the wait list for 2,000 people are not able to use the programs. So we need to serve the thousands of DC residents that rely on Produce Plus. Many of them live in wards 5, 7, and 8. The work of DC Health is important to help DC residents. So we're asking to priority for the program and head to a new budget year. Produce Plus made life better, and we need your support. Your support means so much for us. Thank you for listening and backing up DC Health and backing out Produce Plus for the health of DC residents. Thank you.
Thank you. Ms. Blessingame?
Good morning. Our committee chairperson at-large Councilman Christina Henderson and members of the Committee on Health. My name is Wendy Blessingame, and I'm here today on behalf of Fresh Farm and the DC community to tell you about the meaningful impact the Produce Plus program, funded by DC Health, has on DC residents. Looking back over more than 10 years, the demand for the program has always been high. The program has gone through many changes, but going from paper vouchers to the digital cards was a big improvement. What is consistent about Produce Plus more than 10 years later is the need and focus on serving low-income DC residents who often reside in food-insecure areas. Produce Plus also increases access for those whose income isn't low enough to qualify for federal benefits like SNAP and Medicaid, but it's still not enough to afford all of their necessities like food. In 2025, we received almost 14,000 applications to the Produce Plus program. And even with the increased funding, which we thank you for, we still had a wait list of 2,000 individuals. The program's demand is still evident after all these years on, especially in wards 5, 7, and 8. DC residents get the benefit of nutritious foods without having to go to a farm because the markets are located in their neighborhoods. The source is right there for them to discuss directly with the farmer. In stores, you don't always know where your food came from. You don't know how long it's been sitting there. and usually there's no one to talk to and ask. The food at the farmers markets is fresh and local, and the taste is definitely different from the food at the store. Our community looks forward to coming to markets. The socialization of coming to the market, especially for us seniors, is an outlet to get out of the house and pick up some good, nutritious, and affordable food. Some folks will stay 2 and 3 hours to talk and see people, even if they are not shopping. This also helps small businesses like farmers to be able to feed their families, so it all comes full circle. I am one of many people who will tell you how important Produce Plus is to them. Thousands of district residents rely on the critical service that the Produce Plus program provides because of the consistent support and commitment from DC Health. Therefore, we ask you to prioritize the Produce Plus program as we head into a new budget year. Your support will strengthen our community and local businesses. Thank you.
Thank you. Ms. Person.
Good morning, Committee of Health members and at-large Councilman Christina Henderson. My name is Brenda Person, and I'm a market champion with Produce Plus, as well as a Produce Plus customer. I've been working with Produce Plus for over 6 years. I started out as a volunteer with DC Green, passing out checks to clients to purchase fresh fruits and vegetables at the farmer's market. When Fresh Farm took over, I continued working with Produce Plus. Produce Plus is important to me because it helps stretch my budget, and I can purchase fresh, top-of-the-line fruits and vegetables that are grown pesticide-free. Produce Plus helps DC residents of every age group, from young adults and families to our seniors. It teaches folks how to spend their benefits on good, wholesome produce and how to try new products that they haven't ever tried before. When I first became a Produce Plus customer, I was a diabetic, and I weighed over 160 pounds and I wore size 16. 3 years into the program, my doctor noticed that my diabetic stats had changed and asked what I was doing. And I told him about Produce Plus program. And he said, well, what are you doing? And I told him, I'm eating more fresh fruits and vegetables, pesticide free. And he said, okay. So as of today, and it's been 3.5 years, I can now proudly say I am a borderline diabetic. I wear a size 12, which I am very thankful for. And I contribute all of this to me making healthy food changes through products that I have gotten from Produce Plus. But in 2025, we received over 14 applications for the program, and that even wasn't enough because more people were still calling in after deadline dates and everything, and we had to do a wait list of over 2,000 people. The program demand is strikingly, especially in wards 5, 7, and 8, where the food stores are very limited. It's like a food desert over there. DC Health has been done a good job supporting DC residents. As you can see by the demand each year, we're getting more and more clients, and we're stretching the budgets. And right now, they're only like getting $40. But if you all can contribute more, we can probably take more applications and give them even more. So basically, the Produce Plus program is a critical service that thousands of DC residents rely on, and us as a market champion ask you to prioritize the Produce Plus program as we head into a new budget year. And I thank you for taking this time to listen to each and every one of us.
Thank you. Thank you to this panel. It's good to see you guys in person because I think during the budget, you all were, some of you were virtual, so it's good to see you. And for your continued participation. I feel like, Ms. Price, you were sort of talking about once you got into the program that you started telling other people about the program, and you guys are the phone tree of talking about some of the good things that have been happening. Can any of you talk to me a little bit about what happens when someone is approved for the program, but you notice they haven't started using or spending any of their funds? Do you all engage?
Well, I'm sorry. When I be at Minnesota Avenue, people can't read the email sometimes. So they show up and say, Kim, I'm approved yet? And I say, you approved. And they be happy after that. But the problem is people they can't read sometimes.
Okay.
So I try to help them like that.
Okay.
And Then we have that early summer, a lot of our seniors go into the hospital and they can be in there for the whole summer. And by time to notice that they've been approved, it can be September.
And the markets are winding down.
No, they kind of wind it down, but we kind of grasp them again to let them know to go ahead and use their card. We also encourage them, if they can't use their card, give it to someone else they trust, that can go to the market, so that money can be used.
Mm-hmm.
So we have our difficulties with our seniors. Our biggest thing is pulling our seniors out of the house, getting them to get the card and to use it. And a lot of that is transportation and no one's to take them. So it's our seniors. Then we got some young folks too that's been holding on to the card, that been wanting to be with the program, but they was too holding on to it for the whole summer sometimes. So we reach out, we get them. So, and then we pick up on, getting the people off waiting lists. That helps. So we do a lot.
Okay.
But as Nick said, that overall, the people who are not using the cards is basically a small percentage.
Yeah.
We would love to have a 100% participation, but you're not going to get 100% participation in anything. Okay. And I think that people who don't use the cards at all are a very small percentage. And most times it's something like an illness. In cases, there's even been deaths. I mean, we've had people call to say people have died. But as a rule, once a person finds out that they have been approved, sometimes the telephone number changes from the time they put the application in, or the email changes. It's those kind of things sometimes. But overall, most of the times when a person has been approved, once they come to market, you don't have to worry about them using the card anymore. They come back and say, "Can I have some more money?"
Yeah. Yeah. And that's what I said.
Yeah.
Our farmers market scene in DC, it's not just about the fresh fruits and vegetables. It's a social aspect to it, which is always so funny. I remember when I was campaigning and, go to the farmer's market and people were like, "Oh, I'm in a rush." And I'm like, "You're not in a rush. If you were in a rush, you go to a grocery store." People who are in a rush don't come to farmer's markets because you're taking time, right? You want to pick it up. You want to feel it. You want to smell it. Is this a good watermelon? You're asking the farmer, "Hey, can you help me pick out a good sweet, especially on the watermelons?" Yep. And so it's a very interesting, I love this program. I love that we do this. I love that we provide it. I wish we could do more. Yeah, thank you guys for being here. I don't have any other questions.
Thank you.
Thank you. Thank you so much. You too. All right. So we're going to go to our next panel of witnesses. Chioma Aru, Corey Thompson, Janita Finley, and Susan Sedgwick. I just want to say, we're 27 people deep and no one has not been here, which does not often happen in these hearings. So appreciate all of you being here and your testimony. Okay, Chioma, when you're ready.
Great. Good morning, or I guess afternoon at this point, is it? Oh, still morning, great. Chairperson Christina Henderson. I am Chioma Aru, the Health Justice Project Director at Advocates for Justice and Education, Inc. AJE is a parent-led nonprofit founded in 1996 and serves as a DC's federally designated Parent Training Information Center and Family-to-Family Health Information Center. We are also a Title V implementing partner for children and youth with disabilities and special healthcare needs, otherwise known as SHIN, and their families. Our work centers leadership development for directly impacted parents and youth so they can become skilled, confident advocates navigating education, healthcare, including behavioral health and other DC systems of care. We do this through direct services, training, and systemic advocacy. In FY 2025, AJE became a Title V SHIN implementing agency for the first time. We're deeply grateful for DC Health's Title V team for treating us as true partners and for investing in our service delivery model over the next 5 years. This partnership comes at a critical time. Since the passage of the so-called One Big Beautiful Bill, instability in healthcare access in DC has intensified. We observe the mixed status families, low-income caregivers, and families of children with disabilities are experiencing increased fear, delayed care, and uncertainty. At the same time, our Health Justice Project represents meaningful progress in building more responsive systems. The Health Justice Project started with conducting a 2023 community needs assessment, which identified persistent barriers, such as 26% of families reported not receiving appropriate or helpful care, 19 cited inadequate insurance, 17 lacked access to quality services nearby, and 12% identified transportation barriers, as has also been noted by the previous panel. These findings guide our work. In response, we strengthen parent leadership by onboarding our fourth cohort of parent ambassadors who now co-chair our bi-monthly community health advisory panel, bringing together families, clinicians, and agency partners to address inequities in care. We are also launching a youth advisory board and preparing for year 2 of our health policy camp, which is using a 2-generation approach to equip caregivers and transition-aged youth with disabilities to shape policy and building pathways into the future. However, optimism must be paired with urgency. Projected healthcare cuts and economic strain would disproportionately impact Shin and their caregivers if immigrant parents lose coverage, if working families fall off insurance cliffs, and if behavioral health systems remain overstretched. Title V cannot meet its mandate alone. For too long, DC has underinvested in disability systems across the lifespan. We urge DC Health to treat Title V Shin as not a supplemental, but as a core public health infrastructure, strengthening school-based health services, expanding culturally responsive provider training, and investing in family-centered and person-centered coordinated systems are preventative strategies that reduce long-term costs and increase pathways to high-quality, self-determined, and dignified lives. Thank you for the opportunity to testify, and I welcome any opportunity to answer questions.
Thank you. Corey?
Good morning, Chairperson Henderson, Director Balkas, and members of the committee. Thank you for the opportunity to testify. My name is Corey Thompson, and I serve as a SNAP and WIC Outreach Associate for DC Hunger Solutions. I'm also a proud Ward 6 resident. For nearly 25 years, DC Hunger Solutions has worked to connect residents across all 8 wards to critical nutrition programs. In my role, I attend community outreach events each week where I speak directly with residents experiencing food insecurity. I meet working parents whose wages can't keep up with rising food costs, seniors on fixed incomes struggling to afford groceries, and residents unable to meet basic needs. Trends show that food insecurity in the district is on the rise. At the same time, food prices in the DC area have increased over the past year, and it's estimated that DC households spent more than $3,000 above the national yearly average on groceries in 2024. These realities highlight the urgent need to strengthen the nutrition programs DC families rely on every day. One program that plays a critical role in supporting families is WIC. Nearly 14,000 DC residents are enrolled, and over the past year, DC WIC has increased participation by streamlining applications, expanding outreach to families, and introducing an enhanced food package that is more culturally inclusive. WIC is one of the most effective public health interventions available, and continued investment ensures families can access the nutritious foods that safeguard maternal and child health in DC. While WIC supports families with young children, SNAP remains the foundation of food security for many households in DC. In FY25, DC Hunger Solutions pre-screened more than 1,300 residents for SNAP eligibility and assisted over 700 applications. Yet SNAP alone cannot meet the full scope of the need. Some residents are just over the income limit, but still food insecure, while others receive the minimum benefit of $31, which is far too little to afford food for a month. Additionally, under H.R. 1, expanded work requirements could put nearly 20,000 DC residents at risk of losing SNAP this year, and the elimination of SNAP Ed has removed vital nutrition education that help families manage chronic diseases and stretch their SNAP dollars. Furthermore, many of our non-citizen neighbors are excluded from federal nutrition programs altogether, and many mixed status families aren't applying out of fear, even when their children qualify. This is why strong funding for local food access programs, including Produce Plus, which we just heard about, Grocery Plus, Joyful Food Markets, Family Food Markets, and SNAP matching is so critical. DC Health's partnership with Dreaming Out Loud's Marion Barry Avenue Market and DC Central's Kitchen's Healthy Corner stores further strengthens local food programming by expanding access points east of the Anacostia River, where only 5 of DC's 80 full-service grocery stores are located. Together, these programs complement SNAP and fill critical gaps for households facing rising costs and uncertain federal nutrition supports. We thank the district for its leadership in protecting residents from hunger. Sustained and strengthened support for DC Health, DC WIC, and our local food programs will ensure that this leadership continues and that every family in every ward has a fair opportunity to access the food they need to thrive. Thank you again for your time and your commitment to the health of and well-being of DC residents. I will submit a more detailed testimony for your reference, and I welcome any questions you have. Thank you.
Thank you. Ms. Finley.
Thank you. Good morning, everyone. My name is Janita Finley, and you pronounced it absolutely correctly. My whole life, people have called me Genital. So I appreciate, and there's no L in my first name. I think they just get nervous. So I appreciate it. You're more than welcome to call me Nita. I serve as the managing partner for Company Recycling Center and the founder of Company Recycling Center's Medical Ascension. Medical Ascension is a workforce development program for healthcare, as well as a community-based chronic disease prevention program right here in the District of Columbia. We've served more than 700 young people since 2020, and we run a special component of it, which is called our Medical Ascension Community Health Stations, where we actually have our young people, after they train, to do health screenings at different locations. And that's what I'm specifically here to talk with you all about. These Medical Ascension Community Health Stations have occurred at a variety of locations, including Martha's Table at the Commons, which I heard here earlier, Allen Chapel AME Church, DC Dream Center, Wellington Park, Stanton Oaks Apartment Complex, Hattie Home Senior Wellness Center, Wesley Housing Senior Apartments, Washington Senior Wellness Center. I could go on, but I won't. These are not clinic settings, you may notice. They are the everyday places where residents already gather. And that matters because so much of our health is shaped by what happens outside of the clinic. At our Medical Ascension Community Health Stations, which I'll start to refer to as MACs to save time, our Medical Ascension youth actually provide blood pressure monitoring, BMI and healthy weight counseling, stroke risk awareness, nutrition guidance, prevention education. A lot of what has been discussed here, our young people are doing at a massive level. And they do this in environments where our residents already gather. We even often establish short-term residencies at different sites. So we've established these at the senior wellness centers, so much so that seniors will ask, like, "Why are they coming back next week? I've got to get my numbers checked." We've seen the impact. The seniors will come back and share stories with us of how their blood pressure was elevated. That encouraged them to go to the doctor. Now, when they went to the doctor, they switched their medications or they added a medication to reduce their risk of stroke after confirming elevated blood pressures. We've also seen people change healthy behavior habits. Some of our sites have been at DC Dream Center. We had a security guard say, "My whole life, people told me to lose weight. Now I go to the doctor. They're always suggesting me to go to a gym. That doesn't work for my lifestyle." Our Medical Ascension youth are trained in motivational interviewing. So the first thing they asked her is, "What do you enjoy doing for fun?" She said gardening. After saying gardening, later on through the conversation, she was like, "I'm going to find a community garden near me." She came back a couple of weeks after and told us she found a community garden that she walks to regularly. Our question is, or actually our request is that we've reached out to the DC Department of Health since 2024 and shared how this model can truly impact changes in health as well as workforce development in healthcare. We have not been able to get very far. We've reached out to the Cancer and Chronic Disease Prevention Bureau, have not been able to get very far with them. We reached out to other groups within the DC Department of Health, have not been able to get very far with them. So what we're asking for is to create a sustainable funding pool to be able to support these Medical Ascension Community Health Stations, as there is a huge demand for it. I have a whole list of places that have asked for it, and also to support the Medical Ascension Healthcare Workforce Pipeline, as these young people are very likely to return to DC once they get their healthcare degrees and continue to serve their communities. Thank you.
Thank you. Ms. Sedgwick.
Good morning, and
morning.
thank you for having us at this hearing. I want to first congratulate you on passing the Certified Nurse Aid Amendment Act. Its provisions are a good first step in increasing the size of the certified direct care workforce, which provides services sorely needed by many of us in DC. It's comforting that you understand the importance of having a robust direct care workforce, trained and certified, available to serve those who need help with, as euphemistically called, activities of daily living. My name is Susan Sedgwick. I'm an 81-year-old DC citizen and taxpayer. About 7 years ago, as a member of Capitol Hill Village, planning for my future, I became aware of the shortfall of direct care workers and the barriers for entering this workforce. Your legislation addresses this. I am concerned that the Department of Health is having difficulties in implementing some of the Act's provisions. As you are aware, they've not been able to implement the medication aid endorsement, though it was approved 4 years ago. So their track record's not great. I look forward to hearing the committee witnesses testimony later this week to see if they have a reasonable plan and schedule for implementing the Certified Nurse Aid Amendment Act provisions. And secondly, how they plan to share this relevant information with those who train and/or hire CNAs. Why do I care about the direct care worker shortfall? I'm going to skip over all the details and the blah, blah, blah of personal things and why we need CNAs to help us live and go right to my bottom line here. DC's senior population at all income levels is projected to increase. Some of us age and become disabled faster than others. Without more CNAs, many of us will be forced into a competition for services of going without. It's not a pretty picture. I support quality standards to ensure a quality workforce, but encourage the removal of unnecessary barriers to workforce entry. I do not understand why the city is not focused on training people for these important healthcare jobs. Thank you for allowing me to testify and ask any questions you like.
Thank you so much, Ms. Sedgwick, for being here. Thank you for this whole panel for being here. But it's good to see you again. I think we met through the Capitol Hill Village a little bit ago. But honestly, there's like a through line amongst your testimonies. You're talking about a workforce that needs to be developed. Ms. Finley, you've developed a program to start the pipeline to get to that workforce that's there. And unfortunately, the two are sort of not linking together, but I can see where it is. A year ago, I think we approved for students through the SYEP program to start to be able to get trained on CNA so that there's just so much more that we could be doing with our young people in the summer to put them on the pathway towards health care, workforce jobs, or just jobs sort of in general. Even last night, I was like watching the local news. They were talking about how we have a shortage of lifeguards. And I'm like, okay, could we not use the summer to teach our young people how to be lifeguards so that the next summer they don't actually have to do SYP. They can go make the $21 an hour as lifeguard. Like, we're just not sort of thinking in that sort of workforce piece. And it's super important because as you talked about, Ms. Thompson, right now I got these workforce requirements that I got nearly 20,000 residents who may not be able to do it because we haven't aligned. And it seems so easy to me. It just takes someone to have a little bit of vision around being really dedicated on these different things. Ms. Sedgwick, you might have heard earlier, we're certainly going to ask DC Health where they are, not just on CNA, but also with the medication aid approval. The medication aid program, it's something that our adult ed workforce programs could be training people and putting them into the workforce to help at the nursing homes and other assisted living facilities. And so we'll ask about that. Ms. Finley, I want to ask, what age kids are you working with?
So when we first started, we actually started with middle school and high school.
Middle school?
Because all the research says that by the time a young person gets into 9th grade, they've already decided what they will and won't do, especially when it comes to STEM. We had to stop and separate middle school and high school because we had 9-year-olds in the room with 18-year-olds, and we would ask them how old they are, and they'd be like, I'm 9, but my mom told me to say I'm 12 if you ask. So we have now separated. And so the group that we actually have running the community health stations, which Marcia is on your team, right?
Yep.
She's actually participated in one of them before.
Okay.
Those are high school young people. And then the middle school ones our goal is to give them the skills and the confidence to want to stay on that path so they can get into high school to gain the skills and show competency and then actually run the stations.
Yeah.
And they're very proficient. They have there's a whole curriculum. They have to actually demonstrate the skills before they actually go out into the community. And we also have adult staff there.
Of course.
It's just that the young people are doing the skills.
Okay. So we're talking about
loud.
No, it's fine. So you're talking about like blood pressure check.
Yeah, so they do blood pressure checks, BMI, waist circumference measurement, but most importantly, beyond like the things where you get numbers, they give you real information of what those numbers mean, things that you can do at home to make changes. And the feedback we always get is that's even more important than just having the numbers.
Yeah.
Because a lot of times you'll go to the clinic and be like, oh, your blood pressure is high, or you know what, oh, your BMI is high, or your waist circumference measurement is high. Go to the gym. And we've heard time and time again that these are not real solutions for the population that we mainly work with. This is wards 5, 7, and 8. It's not real solutions to tell someone to go to the gym. Hearing about Produce Plus, right? A lot of our participants who go to the max are on Produce Plus, but that's not enough money to afford to just buy healthy food all the time. Like, you have to give real solutions. Something as simple as, hey, if you have canned goods, rinse them off to get all the salt off of it. And then that helps, right? These are real solutions for people who don't have lots of disposable income.
Yeah. I'm just, a couple of years ago, I had a interesting conversation with the dean of Howard Medical School. And she said, oftentimes when we're doing these medical exposure programs, we wait until high school to do it. And she was like, at that point, it's too late. Not just in terms of they decided what they want to do with their careers, but from a math and science perspective, they don't even have the prerequisites to be able to take the classes in college to be on the path towards medical school or nursing school or otherwise. And so starting in middle school is such an excellent thing. I know you were saying in your testimony you haven't had good traction in terms of DC Health, and we can certainly ask them some questions about that. But what about the Department of Employment Services? Because they have a middle school career exploration program that they do in the summertime. And this seems like a natural build off of that.
So we had applied for it for 3 years. This is our first year actually getting funding from them. So we are a provider for the CREST program, which I think is what you're referring to, for the middle school young people this summer.
Okay. All right. So we're making some small incremental progress, but I think this is a very interesting what you are doing here. So we'll certainly ask some follow-up questions there. Ms. Thompson, thank you so much for being here. And Ms. Aru, thank you for being here as well. I don't have any specific questions because I think I understand where we're going. I understand what the problem is. And I think we need to get some, not just responses from our agencies, but also some active solutions about what we're doing. I have been asking questions for months of our agencies of what conversations we're having about these work requirements. And everyone keeps telling me, oh, we've got time, we've got time. Time's up. And I don't know to the extent that, number one, we've been communicating with members of the public, what you have been doing for months before is no longer going to be enough. And two, do we have a strong enough infrastructure in place where we can seamlessly direct folks to where they need to go to be able to keep their benefits? So whether it be an education training program, a workforce training program, like what type of documentation is going to be needed. Now you're going to have to log into the system and do all these things. And I don't feel like, I don't know, it almost feels like in some ways the agencies are just hopeful that the federal government is going to say, oops, psych, we're not going to do it anymore. And I don't see that happening. But that's neither here nor there. So we'll certainly ask some questions there. All right. Thank you guys so much for being here today and providing, please make sure you provide your written testimony for the record. Okay. We'll go to our next panel. Neil Richardson, Catherine Forster, Andrew Freeman, and Barbara Harrison. As they are coming, if you are here in person and you thought you were testifying in person, but you might not see your name, this is now the time to go talk to Ashley over here and make sure you get on the list. Because I have, after these four, I have 4 more people on the list. Mr. Robert White, we got you. But now's the time to make a move to let us know. Okay. All right, Neil.
Good morning. My name is Neil Richardson. I'm the coordinator for the DC Coalition on Long-Term Care. The DC Coalition on Long-Term Care is a 30-year collaboration uniting consumers, advocates, and healthcare providers to partner with district government on long-term care issues and programs. Our mission is to ensure that all residents in Washington, D.C. That have chronic conditions or disabilities can age in their communities safely. We're the only organization that's representing this wide spectrum of issues. So right off the bat, we know we have a critical workforce shortage in home and institutional health care, from home health aides all the way up to nurses. We all know that. The DC Coalition wants to acknowledge that there's budget challenges in the district, but when it comes to healthcare, We can't put when it comes to healthcare, we can't put those things aside. There's a cascading ramification for all the times that we don't take action. So you championed, Councilmember Henderson, and we thank you. We're very grateful. The Certified Nurse Amendment Act of 2024, but to this day, we haven't seen many things implemented yet. We may have a coordinator that's part of the age-friendly program, which is going to be fantastic, and we're looking forward to that. But one of the things we really looked forward to was doing the kind of some of the easy stuff, and you've heard this from some of our other members today about the advisory committee merging the CNA and the home health aid license. You've already heard it, you've read about it. I'm not going to go into a lot of detail about that because you know it, and I only have a little bit of time. But it's a pattern of what bureaucracy looks like when it doesn't work well. And there's bureaucracies in there for a place, but when it doesn't work well, it really holds things up. And this pattern with long-term care issues include, we've been waiting for the medication aid training, which we talked about in the last panel a little bit. We're still, the council removed these unnecessary barriers to allow CNAs to work in home care settings. They still can't, don't know why. In 2020, the council passed the Dementia Training for Direct Care Workers Act. 6 years later, implementation remains stalled. Thousands of workers providers still don't know how to comply. And this is something we've just been hearing in our last monthly meeting recently. Coalition members are consistently reporting that the Office of Health Facilities Licensing fails to process license renewals in a timely manner. So the agencies are operating outside of the license. And so where they're going, particularly like for federal grants or other grants, when they don't have an up-to-date license, they can't actually do their work legally. So there's real consequences when all of these things do not work. So I'm going to leave this on our DC native, but what is going on, as Marvin Gaye said? Thank you.
Thank you. Catherine.
Good morning.
You just got to turn your mic on. There you go.
Good morning, Councilmember Henderson and members of the committee. My name is Katie Forster, and I'm a prenatal genetic counselor at Sibley Memorial Hospital. I'm joined by Barbara Harrison, a genetic counselor at Howard University Hospital, and Andrew Freeman, a pediatric genetic counselor at Children's National Medical Center. We are here today on behalf of the Maryland and DC Society of Genetic Counselors. Genetic counselors are certified by the American Board of Genetic Counseling, or ABGC, yet the District of Columbia currently has no legal standard determining who can represent themselves to the public as a genetic counselor. We are here to explain why licensure is in the best interests of DC residents. I'd like to start by explaining a bit about the work performed by a genetic counselor. Genetic counselors are master's trained healthcare professionals who help individuals and families to understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. Genetic counselors can be found in many specialties, including prenatal, reproductive medicine, oncology, pediatrics, neurology, cardiology, psychiatry, and more. Genetics is a complex area of healthcare, and protection of the public is critical. Licensure would protect residents by ensuring that genetic counselors practicing in DC meet training, certification, and continuing education requirements. It would also allow the District of Columbia to define scope of practice, prevent unqualified individuals from practicing, and suspend or revoke licenses from those who cause harm. Licensure for genetic counselors would also align DC with other states. 37 states, including both Virginia and Maryland, have already enacted licensure laws with efforts underway in 48 states. At the federal level, the Access to Genetic Counselor Services Act has been introduced into the U.S. Senate and House of Representatives with bipartisan support. The bill would recognize genetic counselors as Medicare providers, defining genetic counselors as those licensed by their state. Importantly, genetic counseling is also readily available and frequently provided via telemedicine. Although ABGC lists 35 genetic counselors in the District of Columbia, we anticipate that the number of applicants would far exceed this amount. ABGC lists 205 genetic counselors in Maryland, and yet the Maryland Board of Physicians has issued over 400 licenses. Similar patterns have been seen in other states as well. Licensure for genetic counselors would be budget neutral, as regulatory costs would be offset by licensing fees. In fact, licensure would likely positively impact the economy in the district by increasing access to genetic counseling services and providers. In closing, licensure for genetic counselors is a practical step to ensuring that DC residents receive safe, reliable, and accountable genetic counseling services with no financial burden to the district. We respectfully urge the council to enact licensure for genetic counselors. Thank you for your time and consideration, and we're available for any questions.
Thank you. Andrew?
Actually, Catherine's testimony was on behalf
Yeah.
of
Oh,
three of us. So
one testimony
yes,
for
myself and Barbara.
Got it. Okay, wonderful. All right, well, thank you so much for you all being here today. Neil, we've had a number of individuals who have testified about the particular challenges and issues we've had on this. I think some of my frustration sort of lies is I know what it looks like when DC Health can move fast. Right? When we prioritize something, things can actually move fairly quickly. We had that example last September when, we had this change that happened on the federal level, and we needed to make a change in the law in order for our pharmacists to be able to continue to give vaccines. We did that fairly quickly in terms of both what DC Health needed to do on their end, communicating with the pharmacies, et cetera, and what we needed to do over here. And so it's a little frustrating where I don't feel like we're all taking this part on long-term care seriously enough in terms of just the aging population that we have in the district and in our region. We're going to have to deal with the issue one way or another. And it's almost like we keep putting it off, even though the number of folks who are over the age of 60 in the district continue to grow. And so this problem isn't going away. And the licensure piece, the training piece is the infrastructure that's necessary that allows for some of the young people that Ms. Finley is working with to be able to access various points in this. And so we'll certainly ask DC Health about that, but thank you for being here. And not just about the CNA piece, but even going back to, the dementia training bill that happened prior to me even becoming a council member, and the fact that that still hasn't seen full implementation yet as well. Okay. Ms. Forster, Mr. Freeman, and Ms. Harrison, thank you all for being here. We don't often have people who are coming to say, hey, license my profession. I have folks who say, there's too much paperwork, there's too much this, there's too much that. Is there concern around, we would refer to it in a licensed way as unlicensed practice, but I guess that there are not enough standards in terms of who can call themselves a genetic counselor in the district? Is that really where this sort of lies?
Yeah, so I think our primary concern is making sure that we keep the public safe. There's been a lot of research that's shown that there's a lot of benefit to patient outcomes, as well as hospital systems overall, through adding genetic counselors to the care team. But genetics is such a complicated and very rapidly advancing science that it really requires a special set of expertise. So we are often working in conjunction with physicians, not necessarily in our own practice. Licensure, and a lot of times does also, though, give genetic counselors the ability to order testing and to be able to practice independently, which would then also expand access to genetic counseling services. For the
Okay, so I think you said you're at Sibley, and Andrew, you're at Children's, which has locations in multiple jurisdictions. So are you licensed in Maryland?
Yes, so I do hold Maryland and Virginia licensure.
But not DC. Oh, this is interesting.
And another point to add on to Catherine's, so as Catherine mentioned, genetic counselors frequently work in tandem with physicians, specifically like medical geneticists who go through, medical school, residency, fellowship. However, that field is not growing with the demand for genetics healthcare services, whereas the genetic counseling field is growing exponentially with new programs popping up every year. And so with licensure and getting that more credibility with the licensure would give us more not necessarily autonomy, but independence and more of a say in that healthcare setting. Where
And genetic counseling is already a Medicaid covered, well, not in DC, I imagine.
So we are currently not recognized healthcare providers by Medicare, but it has been introduced to the House and the Senate this year with bipartisan support. So,
okay. I'm glad that they're on that path. This has not really been a do something Congress. So that's why I'm sort of laughing at that. But this is just sort of interesting here. Okay.
it's been a long path to this point too. We've been working for 16 years for it. So,
Got it. Got it. Okay. What board would you be under?
I believe the Board of Medicine in other states, in Maryland, for example, they're under the Board of Physicians.
And that's what you desire? This is very interesting. First off, we don't have a lot of people who come say, license my profession. We certainly don't have folks come and say, yes, put me under the Board of Medicine, which already has no shade to the Board of Medicine, but they do have a lot of professions and scopes of practice that are currently under them. So
I think when we looked at the options, it was the one that fit most with what we do.
Right. And similarly, like in Maryland, it's not the Board of Physicians. It's just, I think that's where we end up lying. And just to, it's just very applicable to the residents in DC. I mean, you've heard this morning about deafness. You heard this morning about Alzheimer's disease. All those things are places where genetics has a role. And so being able to make those discussions around genetics, potential genetic testing, which can open up opportunities for treatment, for clinical trials, for better understanding how something's going through the family, can be very valuable to families. And so having someone who really has that knowledge, because many physicians and other health providers don't have significant or adequate training in genetics, yet because how ubiquitous genetic testing is becoming, like almost every area of medicine has some type of genetic testing that should be offered or should be discussed. And so being able to get genetic counselors who are appropriately trained in those places is important.
Yeah.
And the licensure makes sure that those individuals have the training that they need.
Yeah, I feel like every couple of weeks, KFF has like a new article that's talking about something with regard to genetics. Okay. Thank you. Thank you for your testimony. We're going to go to our next panel of witnesses, and this is our last in-person panel. So I just want to televise for people virtually where we're going, because it is 12:15. We've been sitting here since 9:30. So once last in-person panel finishes, then we are going to take a 10-minute break, and then we'll come back and get to our virtual folks. Okay. So Najesh Boros. There's so many different ways that this could have been pronounced, and so I'm going to apologize in advance. Okay, Robin Roche. Resch. Okay, Michael Davis and Robert White. Okay, tell me how to pronounce your name.
It's Nagesh Borse.
Borse.
Yes.
All right.
Thank you.
Thank you.
Good afternoon. The testimony I'm about to deliver reflects my personal views and experiences and does not represent the views of the district government or any district agency. Chairperson Ms. Henderson and the members of the committee, thank you for this opportunity. My name is Dr. Nagesh Borse. I'm here today as a district resident and a father of minor DC residents to raise a serious concern about systemic oversight gap affecting DC children who receive psychological services from out-of-state providers operating under SIPACT. This is not about access alone. It is about access without accountability. The core problem I see here is that the DC has appropriately expanded access to mental health services for minors, including circumstances in which youth may seek care without parent consent. That policy intends, the policy intent is sound. However, when this access framework is combined with SIPACT, a regulatory vacuum emerges. Psychologists who are not DC licensed can provide services to DC minors. DC Health lacks disciplinary authority over them. SIPAC does not investigate or entertain or discipline complaints, and home state licensing boards often delay or decline jurisdictions when the child is not a resident. The result is stark. DC minors can experience harmful bias or retaliatory psychological practices with no regulator able or willing to act. That is not a dispute. It is a structural failure. Why this is a public health issue? This gap exists amid a well-documented youth mental health crisis. Youth suicide is among the leading cause of death for adolescents. Mental health-related emergency department visits for youth have surged. Teen girls, in particular, have experienced sharp increase in suicide-related emergency visits. When children raise credible distress through pediatric visits, school reports, or direct communication, and no authority can review or intervene, the system fails at the precise moment protection is needed. In DC, courts increasingly rely on small group of out-of-jurisdiction psychologists as regional experts in high-impact family and custody matters. These providers are not licensed in DC. They're not accountable to DC regulators, yet they exercise extraordinary influence over children's lives and family structure. Psychological opinions, often subjective, can alter parental rights and children's future without independent review, due process protection, or meaningful appeal. That level of unreviewable authority is incompatible with public health and child safety principles. I respectfully urge the committee to consider 5 targeted actions. First, reevaluate DC's implementation of PsyPact in the post-COVID context, prioritizing child safety. Second, limit PsyPact use to direct clinical treatment only. Third, require DC licensure for custody evaluators, forensic psychologists, and court-appointed case managers. Fourth, create a DC level complaint review pathway whenever DC minors are affected, regardless of provider location. And fifth, implement enforceable anti-bias and cultural competency standards for professionals whose opinion shape legal outcomes for DC residents. In closing, interstate compacts were designed to expand access, not eliminate accountability. If a child in DC is harmed and no authority can act, the failure is not clinical, it is a regulatory. Clinical psychological care, especially when it shapes identity, family, and future, deserves the same oversight we expect in any other medical discipline. Thank you for your leadership and your commitment to protecting the health, dignity, and safety of DC children. Thank you.
Thank you. Robin?
Good afternoon, Chairperson Henderson and members of the Committee on Health. Thank you for your leadership in overseeing DC Health and for your continued focus on health equity across the district. My name is Robin Resch. I am a Ward 6 parent of DCPS students, a practicing inpatient registered nurse, and a member of Parents United for School Health, also known as PUSH. I am here today because the DC Health School Nurse Cluster Model raises serious concerns about student safety, nurse recruitment, and transparency. Under the cluster model, one nurse may cover up to 5 schools. While this approach was introduced to address staffing shortages, it has resulted in reduced on-site coverage, increased burnout, and confusion among families about who is responsible for their child's medical care during the school day. Many parents do not even realize that their child may not have a full-time nurse physically present in the building. As a practicing nurse with experience in nurse recruitment, I can say clearly the current structure makes school nursing significantly less attractive as a profession. Floating between multiple buildings, managing unpredictable coverage gaps, and carrying responsibility without stable on-site support is not a sustainable model. It is not surprising that this model has been criticized by the DC Nurses Association and the DC State Board of Education. School nurses are often the only healthcare professionals immediately available when a child experiences an asthma attack, seizure, allergic reaction, or diabetic emergency. Delays in response, even minutes, matter. This is not just a workforce issue, it is a patient safety issue. PUSH has attempted to work collaboratively with DC Health to improve transparency and strengthen the staffing pipeline. Our advisory charter outlines constructive solutions, improving real-time nurse scheduling transparency, strengthening RN to student ratios, developing part-time recruitment pathways, expanding internship pipelines, and exploring loan forgiveness programs. There are parents in the city who are nurses, and there are healthcare professionals who want to help. There are creative recruitment strategies available. but meaningful collaboration requires access to data, including staffing levels, coverage gaps, emergency transport rates, and recruitment metrics. To date, that transparency has been very limited. We're not seeking authority over DC Health operations. We are seeking partnership, data sharing, and a seat at the table to help solve a problem that directly affects students' health and safety. The cluster model may have been designed as a temporary solution, but if it becomes the long-term standard without evaluation and public accountability, we risk normalizing a lower standard of school health access for DC students. I urge the council to examine whether the cluster model is meeting its intended goals, to require transparent reporting on coverage and outcomes, and to support collaborative engagement with parents and healthcare professionals who are ready to help. Our children deserve consistent, qualified medical care in their schools, not a system stretched so thin that emergencies become a matter of luck. Thank you for your time and oversight.
Thank you. Michael.
Good afternoon, Chair Henderson and committee members, also Ms. Balgus and staff. My name is Mike Davis, and I am a Ward 7 resident. I have been a DC resident for 25 years. I speak to you today, as did a few witnesses about an hour ago, about DC's Death with Dignity Act. It passed the council with a supermajority about a decade ago in 2016. My community, and indeed most Washingtonians, were supportive of the act, and they remain supportive. The act provides competent adult patients who are suffering at the end of life with an additional healthcare option. The motivating idea behind the act is that competent and terminally ill adults do not have to suffer prolonged agony unnecessarily. It provides a much needed sense of comfort and peace for dying individuals and their families. I have learned of federal efforts to overturn the will of DC residents and repeal this law. That must not happen. There are many residents who want, and some who may ultimately need, this option. The annual reports from DC Health underscore that the law has been working as intended, and those reports are pivotal to the success of this program. I would like to thank the team at DC Health who recently spoke with me and for their commitment to improving the process for all residents. In addition to being very supportive of this law, I support enhanced education regarding the Death with Dignity program. The bill became law a decade ago, but there is still a lot of confusion about how it works, what it does, and what it does not do. So I hope that DC Health would consider creating a Death with Dignity education campaign to ensure residents are aware of the program and understand the process and how it works. Thank you for holding this hearing today and providing the public with an opportunity to provide testimony. And in particular, I appreciate your attention and engagement across dozens of witnesses.
Thank you. Mr. White.
Good afternoon. My name is Dr. Robert White. As a fellow of the American College of Physicians, I am speaking on behalf of the DC chapter about an issue that busy DC physicians and other DC licensed health professionals may not have recognized: birth date-based license renewals. When I renewed my DC medical license in December 2024, I thought the $550 fee, $500 for the medical license and $50 for the background check, covered the usual 2-year period as it has been for decades of renewals. The dates of my license were December 2024 and January 31, 2026, my birthday month. What I saw was 2024 and 2026, a 2-year interval, the usual for me for decades. Last month, I renewed my medical license again and paid the same $550 fee I paid 13 months earlier. I had a residual 11 months left from my last full payment in December 2025, or DC Health owed me $252.04. DC Health was aware of this unfair issue in an August 2025 notice sent to all DC licensed health professionals. But DC Health did not follow its existing and regulatory language regarding transition to birthday renewals, Regulation Section 4006.4. Quote, if the director changes the renewal system under Section 4006.3 in order to permit an orderly transition, the term of a license that is in effect on the date of the director's determination may be extended up to three years, end quote. In my case, at the end of 2024, DC Health had regulatory authority to issue me a license to expire at the end of January 2027. In August 25, when DC Health implemented changes to the licensing process, I should have been reissued my DC license to expire at the end of January 2027. Again, both would run out what I paid for in a 2-year license, plus a 1-month extension. Also, these required no change in continuing medical education. In summary, the DC health professionals may needlessly and unfairly pay more for their license renewals this cycle in the transition to birthday license renewals. Thank you for having me.
Thank you. Thank you so much to the panel of witnesses. Dr. Borsi, we often have a lot of people who come to advocate for us entering various compacts. You name it, there's a compact someone desires, but I think what you brought up in your testimony is around, interstate compacts is supposed to be about access, not limiting and accountability. And whether or not agencies, even if they're not the home license or home licensing agency for a particular physician, should still be doing their part on oversight. So for the last couple of years, we have been pushing DC Health to improve their complaint process, because the complaint process was you go to the DC Health website, you click on the form, you had to print the form, then you had to, was it a fax? Fax the form. This was we're 2020. It just didn't make sense to me. And they have now finally developed an online a form where someone doesn't have to print and do all of these different hoops. And guess what? The number of complaints went up because people just have access on that front. In particular, can you be a bit more specific about what you would hope that DC Health would be doing as it pertains to these types of compacts, not just with Psych Compact, but others? I think in your testimony, you listed some specifics.
So I think each compact has a different regulatory authorities, if I understand correctly. I mean, the psychology compact, it sounds like the home jurisdiction has oversight on the psychologist, but maybe it's different for other boards, and I'm not expert on those different compacts. But I think the problem I see is that because the Psych Pact doesn't take any responsibility for it, I, as a parent, has to rely on the home first identify who is the home jurisdiction, because then I have to go figure out how to search that individual, find out what their process is, and then find out that I'm a non-resident for that jurisdiction, and so I'm not the top priority for them. And also, I think the another thing that I realized is that just because everybody's part of Psych Pact doesn't mean the inspection authority or those who are doing the work has increased as well, right? So I will give you a neighboring jurisdiction has only one inspector, right? So if I'm sending a complaint from DC for another jurisdiction, the priority list and where I stand may be not the same as they doing it for their own residents. So there's a lot of those kind of concerns that I have. And, you know, as a parent, I just want to get best care for my child. I don't want to worry about, you know, am I hiring somebody who is off packed, not packed. I just want to make sure that they get a care. And if I have concern, I can raise it with the right authorities. And it's very complicated. I will tell you, it's different for social worker. I think we do have a more authority on that, but it's just, I think each compact and each discipline has its own way of handling, which as a resident is very hard for us.
No, I hear you. And I don't think, I mean, DC government agreeing to be a part of the psych pack, I don't think absolves them of the responsibility when something has gone wrong. And perhaps we need to do some more improvements on that. So thank you for being here.
And if I may just add, if I as an adult cannot find out all these intricacies of how to do it, for a minor who we are allowing to have no parent consent access to the psychologist, I don't know how they will be able to do any of this on their own.
Thank you. Thank you. I hear you on that. Ms. Roche, I said it right? Roche.
The O silent.
Got it. Okay. Thank you for being here and for the work and advocacy that you guys are doing. We'll certainly have some questions for DC Health around the implementation. As you know, like this is the first school year where DC Health has brought the school nurse program in-house, which I think we always anticipated that there might be some bumps in the road. But there were some things, even when we had a hearing last year on school nurses in particular, that we had identified that were going to be challenges in terms of recruitment. And I don't feel like, I don't want to say I don't feel like, I don't know if DC Health has followed up. So for instance, when PG County raised the salaries for their school nurse program, we always knew that was going to be a challenge if we were not doing our own market research and choosing to match in some way. It's always so funny to me when people say, because this is the same issue that I foresee happening on school-based behavioral health. So Department of Behavioral Health wants to bring the school-based behavioral health program 100% in-house. And I asked about the salary pieces and they'll say, oh, but we offer great benefits. And I'm like, child, everybody's offering good benefits, but at the good benefits does not allow for me to be able to go to the grocery store and pay my mortgage, right? So like that part has to be important too. The base salary is important in terms of what we're doing. So we'll certainly ask some questions and follow up there. Mr. Davis, thank you for being here. I think you heard probably the commentary that I had earlier around death with dignity. We're gonna keep pushing. I feel like every time I send a letter to the city administrator around outstanding reports that are due, this one is part of it. And like I said earlier, this is not long. It's 2 pages, and I think the first page is just a cover. So like, we're talking about a 1-page thing here, and we have been unable to produce that on time for years, which is, I think, a huge problem. So we'll certainly follow up on that as well. Dr. White, thank you for being here. You know, we talked to DC Health about their transition from to now the birth date renewal, and we knew that there would be some kinks here as well, but your testimony around DC Health not following its own regulations in terms of when
I was amazed when I stumbled onto that.
When you found it.
When I found it's the next one. And there's nothing that I have found that they have mentioned or anybody else has mentioned. I've been in direct contact with DC Health, and they said, "Oh, we can't discount or anything." And then I saw 4006.4, and there was the perfect regulation to do this. I mean, I was in shock.
Well, you know, sometimes regs cover a multitude of things, but people don't ever think to go look there. And that includes some of the folks who work for agencies. So we will definitely follow up on that. And don't be surprised if DC Health probably gives you a call in the in-between.
Okay.
All right. But
Thank you so much for being here. Thank you to this panel of witnesses.
Thank you for having me.
Okay, we have one more public witness, Sarah Buckley. Okay, and then after Sarah goes, then we will definitely take our break. All right, Sarah, when you're ready.
Thank you so much. My name is Sarah Buckley. I'm a parent of 2 students at Amadon Bowen Elementary School, a member of the PTA, and a member of Parents United for School Health, which is what we've been calling this collection of parents that have formed an advisory committee to try to connect with and advise DC Health on school health suite issues. I want to first acknowledge and thank DC Health for working with the parents to establish this advisory committee. I particularly want to thank Dr. Sarah Beckwith and her team for making real strides in firmly establishing our committee and setting up structures that we hope will provide greater transparency, respect, and ultimately better policies for DC's students. But I also need to be clear, the School Health Suites program is still failing those students. In 2023, this council repealed the Public School Health Services Amendments Act of 2017, which had mandated that each DC public and charter school be staffed with a full-time registered nurse or licensed practical nurse. That repeal made way for the cluster model for school nursing. Under the cluster model, in theory, a nurse is assigned to oversee a cluster of schools, each of which is supposed to have its own nurse or other health professional, sometimes called a health technician, sometimes a nursing assistant. Although health technicians are not licensed nurses and accordingly have a more limited scope of practice, this was billed as a solution to a nursing shortage and a way to give every DC public and charter school someone in their health suite full-time. But the past 3 years' experience has shown that the cluster model is not delivering on that promise. Today, there are fewer nurses employed in the health suites program than before the cluster model was implemented. The number of schools in a cluster has grown from 4 to 5, and many schools now only have 20 hours a week of any health suite coverage. Despite this failing record, DC Health has stated that it is committed to a team model for health suite staffing, i.e. continuing to rely on health technicians and nursing assistants in a cluster model. So I'm asking you, DC Council, to demand more. Demand a plan for increasing the number of nurses in the school health suite system. Set clear benchmarks for the number of nurses and the number of hours of nursing coverage schools receive. Demand that DC Health at least meet the Center for Disease Control's recommendation to have 1 credentialed nurse per 750 students. Reinstate the Public School Health Services Amendments Act and its legal obligation to provide a nurse for every school, or at least fix the code that was left after the act was repealed, DC Code Section 38621, which now states that the minimum hours of coverage for health suite is 20 hours per week. I want to quickly address one other issue. There's plenty to say about the health suites program and also DC Health Administration medication program. But there is one short training that is epinephrine specific that DC Health eliminated this year. So DC Health used to offer a 1-hour-long EpiPen specific training, no longer offers it. My son has life-threatening food allergies, and we have traditionally asked his classroom teachers to take the 1-hour training so that even if if they are not able to do the multi-day administration of medication training, they can become trained in recognizing an allergic reaction and administering the one medication that could save his life. That training is no longer available. And I have heard from DC Health that they want to ensure that any teacher administering medication gets the full AOM training for safety reasons. But taking away an EpiPen training makes my son less safe. It doesn't increase the number of AOMs, it just increases the chance that my son and others will not have access to an adult that can identify and respond to allergic emergencies. So thank you.
Thank you, Sarah, for your continued advocacy on this issue. As I said earlier, when Robin was on the panel, we'll certainly ask some follow-up questions to DC Health about what's their plan going forward. usually when we do these in-house transitions, everyone gives us these like predictions of how well they feel like they'll be able to hire and the vacancy rates, et cetera. And then we don't often talk about, okay, what happens when you don't meet the target? And now we need to talk about what happens when you don't meet the target and perhaps being a bit more creative in terms of how we approach these issues. So we will certainly follow up with DC Health about this on Friday. Thank you for being here.
Thank you.
Okay, so for the folks watching at home, we're going to take a 10-minute break and we'll be back with our virtual witnesses. We'll be back. Okay, and we're back. All right, so we're going to turn to our virtual public witnesses. If you haven't done a virtual hearing with us before, it requires active participation. So when we call your name, you'll need to affirmatively accept our invitation to become a panelist. There will be a little box that pops up on the screen for you to come up. So we're going to do panels of, well, let's start with 6 and see how we go, then go from there. So Jaspreet Chaudhry, Barbara Briggs, Ashley Ruff, Veronica Sharp, Kate Finman, and Christina Carbello. Okay, we'll give it a minute for folks to come on in. Okay, I see Jaspreet when you're ready.
Thank you so much. My name is Jaspreet Chowdhury, and I am the Senior Legislative Counsel at Compassion and Choices. We are the nation's oldest and largest nonprofit organization working to improve care and expand options at life's end. Thank you so much for the opportunity to testify regarding data collection for the DC Death with Dignity Act. Accurate data collection and reporting on medical aid in dying is useful to improve the medical practice, identify opportunities for education, to improve access, to quell concerns about medical aid in dying, and to counter false narratives. When data collection is mandated, as it is in the DC Death with Dignity Act, the reports must be timely. Partners and public health departments across the country provide data that is used to assess the health of our communities. We appreciate their partnership in providing accurate information about who utilizes medical aid in dying while protecting the identity of patients and providers. The DC data reports have been so helpful. The reports help the public understand how medical aid in dying works and helps Compassion and Choices protect and defend the program. The DC Death with Dignity Act went into effect in 2017, and we have yearly reports through 2022. However, we are missing the last 3 years of reports. My colleague Donna Smith met with members of DC Health on January 14, 2026 for introductions and received a commitment that overdue reports would be published within 30 days. As of Tuesday, February 17th, yesterday, the reports have not been published over a month after the commitment was made. We appreciate the chance to reestablish our connection with DC Health and look forward to working together to ensure timely and accurate reporting on the utilization of medical aid in dying in DC. Donna Smith will be in touch, and we look forward to continued partnership. I have submitted written testimony with more detail, and I'm happy to answer questions. Thank you again.
Thank you. Barbara?
Yes, hi, good morning, Councilmember Henderson. Can you hear me okay?
Yes, we can.
Thank you so much for this opportunity to testify. My name is Barbara Briggs, and I'm a member of the Executive Committee of the Sierra Club's DC chapter, and I'm testifying on behalf of the organization. The Sierra Club is the nation's largest environmental organization, and we have about 7,000 members here in DC. I believe this may be the first time that we've given testimony on DC Health, and it's high time. Given the interplay between climate, energy policy, and human health, the role of DC's Department of Health is crucial. I will focus today on one area where DC Health's leadership is particularly important: the continued use of gas for cooking and heating DC buildings, and the slow walking by the executive of the transition to all electric buildings and cleaner renewable energy sources that DC has already committed to. Emissions from DC buildings represent more than 70% of the district's contribution to climate disrupting greenhouse gas emissions. This figure does not take into account leakage from the drill sites, pipelines to DC, and from the gas pipes under our streets. Climate change itself represents a major long-term health threat to DC residents who are already experiencing higher rates of illness and death due to heat, climate-related weather events, and environmental changes. Burning gas in DC's buildings also contributes to health-harming pollution. Gas stoves in homes, restaurants, and schools emit nitrogen dioxide, carbon monoxide, benzene, and other pollutants that affect the health of families. Boilers and furnaces that burn gas vent their fumes to the outdoors, where they contribute substantively to outdoor air pollution, to which we are all exposed. We detail the health impact of these pollutants in our written testimony. We urge that DC Health use its outdoor air monitoring program and other sources, including our Beyond Gas community science investigations, to develop public education campaigns to encourage residents and landlords to reduce the air pollution emitted from gas burning appliances, and to make sure DC carries out necessary longer-term efforts to rid our community of these health-harming pollutants. This work is particularly important for DC's low-income communities and renters who do not have the financial resources and often don't have the decision-making authority to transition from polluting gas equipment to electric heating, which would make indoor air healthier. Given the profound health implications of climate change and the combustion of fossil fuels that drives it, we urge DC Health to give increased attention to these areas, including with high visibility public education and weighing in on DC climate and energy policy that impacts the health of our community. Thank you.
Thank you. I don't see Ashley. I don't see Veronica. I don't see Kate, but I do see Christina. There you are.
Right, can you see me okay?
Yes.
Great. Good afternoon, Chair Henderson and members of the committee. My name is Christina Caraballo. I am a DC resident, former Brandywine Valley volunteer, and foster mom. The last 2 years, I have fostered 8 dogs and usually have a foster in my home. I also regularly volunteer walking dogs at HRA. I am here to speak about DC Health's responsibility to enforce a stronger animal care and control contract. The recent DC audit report confirmed that DC Health failed to adequately monitor its shelter contract. That cannot continue. 4 areas require immediate attention. First, public access and response. The contract requires only 40 hours per week, with no stray intake on Mondays and limited hours to respond. In 2025, over 43,000 dispatch calls were logged, yet fewer than half became cases. Residents report calling multiple times or being told to handle animals themselves. DC Health should require broader access, guaranteed intake, and measurable response standards. Second, the contract does not require owner surrenders, leaving residents with no options and animals abandoned. This is unacceptable in an open access system. DC Health should require enforceable intake provisions. Third, the contract lacks enforceable spay-neuter requirements, despite this being a core public health intervention that reduces intake and long-term cost. DC Health must require proactive, affordable services. Fourth, humane care and standards outcome. The contract includes exercise and humane care requirements, yet walking and enrichment standards are not consistently met. As a volunteer, I have observed dogs deteriorating in kennel environments when those standards are not held. We now have dogs staying in the shelter for close to over a year, unusually long for DC and harmful to their well-being. Fostering is one of the most effective tools to reduce length of stay and improve outcomes. However, the contract contains no foster performance requirements, and placements are often short-term rather than foster to adoption. Dogs who thrive in homes can shut down in kennels, and when placements are cut short, they are returned to environments that accelerate their decline. This is not producing acceptable outcomes. DC Health should incorporate clear, outcome-based standards, including foster utilization benchmarks, length of stay targets, and documented outreach for potential fosters prior to euthanasia. I also submitted 2 FOIA requests in April of 2025 for outcomes data and an individual case and have not received a response. Timely access to data is essential for accountability. DC residents and animals deserve a system that is accessible, accountable, and humane. Thank you.
Thank you. I think we've just been joined by Kate Finman.
Hi, Councilmember Henderson, committee members and staff, thank you for the opportunity to testify on DC Health's performance on animal care and control. My name is Kate Finman. I'm a Ward 6 resident, a community cat volunteer, and a former volunteer at both the Humane Rescue Alliance and the Brandywine Valley SPCA. I'm here today to specifically focus on DC Health's abandonment of open access animal services and how DC residents are not receiving the resources we need because of it. An open access shelter accepts all animals from the community that comes through its doors, including stray animals, wildlife, and owner surrenders. What DC currently has, because of DC Health's contract, is explicitly not that. The current animal care and control contract does not have specific intake or field service requirements, which leaves DC residents and their animals alone when they need help. When a neighbor found a stray domestic turtle last year, they were told that animal control doesn't help with reptiles. When neighbors report loose dogs, which is a safety and health concern both for the dog, but also for the community, animal control's response is slow if they respond at all. Most egregiously, the current contract explicitly suggests that the shelter refuse owner surrenders for kennel space and turn away people who have to make the heartbreaking decision to give up their animals. This, of course, doesn't solve any problems, and I could share many stories of animals who were turned away with their owners in the morning, only to be brought in as strays later in the day after being abandoned in the neighborhood. I know DC Health understands the importance of an open access shelter and the value in it because previous contracts have mandated the shelter and take all animals. Of course, in practice, the previous contractor was not an open access shelter and did not fulfill their contract, which is where all the issues came from. I honestly cannot understand why, when switching to a new contractor, DC Health decided to abandon residents and essentially put in place the very systems that were failing. Prioritizing space by simply artificially limiting the number of animals in kennels does not actually lower the number of animals or people who need help. Instead, it just leaves DC residents without good options and puts the onus on well-intentioned residents to figure things out for themselves without resources. This is a people issue in addition to an animal one. If DC Health wants to limit the number of animals that require services from the shelter, which we should in fact do, it must mandate and fund robust, proactive, and highly accessible spay-neuter initiatives. This is the only proven way to truly and sustainably solve the space crisis our shelters are facing. And yet, the current contract does not include any public spay-neuter requirements, despite the fact that DC Health is mandated to by law. We need a stronger animal control contract that creates open admissions animal shelter, including options for owner surrenders, and that mandates and funds truly accessible and proactive spay-neuter. Thank you.
Okay, thank you so much to this panel of witnesses. I don't think anybody else has joined. I'm checking the list here. But again, I think this panel, as I said earlier, sort of represents the variety of issues that DC Health deals with. So I'll just start from the beginning. Jaspreet, as I said to the earlier panel, there are a number of witnesses, public witnesses, who testified about the exact same thing that you brought up in terms of death with dignity. And we certainly have some questions for DC Health around where those reports are. Why can't we ever seem to be, well, I'm going to say ever, because when this law was first passed, we did produce the reports in the timely fashion that they were supposed to. And then we fell off in 2022. And so we're going to figure out what's going on there. Ms. Briggs, thank you so much for testifying. I think we asked some questions around the Environmental Health Administration, which probably seems to be the part of DC Health that is most aligned with what you were asking about in terms of using its data and information about the outdoor air quality to do a public information campaign around that. And so we have some questions for EHA because they're already a new division within DC Health in terms of their partnership and relationship with the other agencies. And frankly, in general, how DC Health is elevating its role and mission in the conversation around the environment and public health. So thank you for being here as well. Ms. Finman and Ms. Carbello, thank you so much for being here. You know, so we often, and I know there's going to be some witnesses after you who's going to be talking about animal control and care. And I think we had our contract with HRA for a very long time. And it's funny now, everybody, folks now say, no, HRA was perfect. It was not. We received lots of complaints about what was happening under HRA. But I want to ask this question around guaranteed intake, which I think both Christina, you and Kate brought this up. When our previous contractor did do guaranteed intake, there was a higher euthanasia rate of what was occurring there. Is there a different model that we should be looking towards? Brandywine's euthanasia rate is much lower than what it was with our prior contractor.
I think so there's ways to prevent owner surrenders that are not just refusing owner surrenders. That's the problem that we have here. For example, the pet pantry program to help people be able to afford to care for their animals, public spay neuter, things like that are not being offered. So right now, DC residents are not being offered really anything to help keep their animals. They're just being told, you have to keep your animals because we're not going to take your animals.
So I'm not sure that's entirely true. I've actually been out to the clinic that we are operating in Blue Plains, and I've seen the surgery. So I know we are offering spay and neuter services. Whether or not it is publicly known that those services are available is a completely different thing. But I would not say that our contractor is not offering this.
The current public spay or the current spay neuter options that are being offered are entirely privately funded. And for example, for a dog that weighs more than 90 pounds, it costs $300 to neuter that or to spay that animal, which is not accessible for a lot of people. And so I do agree that the current contractor is providing spay neuter in a much better way than the last contractor, but there's still a lot to be desired in terms of cost. And also there's currently no public oversight of the spay neuter program. BVSPCA could take it away at any moment, and the DC government can't do anything about it because it's not in the animal control contract.
Ms. Carbello, I don't know if you wanted to jump in.
Thanks, Kate. And I just wanted to jump in and add to what Kate said on the lack of the foster program. So one thing HRA did really well and continues to do really well is has a robust foster program. Brandywine's long-term foster program doesn't exist. And for the cats, I think it does, but for the dogs, it does not. And we're not getting these animals into fosters, which is not only not helping take care of the dogs who struggle in the kennels, but it's also not helping free up space so that we are able to take in more owner surrenders. I am personally against euthanasia. However, I'm also have problems when there's dogs on the street because there's no place for owners to bring their pets in when they can't get cared for. So we now have a crisis of dogs just being tied to poles, tied to fences, and just left out in the cold. which I think is a huge problem. So focusing on some of these other programs, like a robust foster program, can help free up capacity within limited shelter space.
Okay. All right. Well, thank you so much for being here. If you haven't yet, if you could provide your written testimony for the record, we'll certainly follow up with DC Health on some of these issues on Friday. Thank you so much. All right. So we're going to go to our next panel. Natalie Hughes, Michaela Deming, Ann Thiel, Kurt Gallagher, Colleen Dans, and Vic Gonglaves. Give it just a minute for folks to come in the room. Again, witnesses will need to affirmatively accept our invitation to become a panelist. Okay. All right, I don't see Natalie, but I do see Michaela.
Good afternoon. Thank you, Chairperson Henderson, members of the committee and staff for the opportunity to testify. My name is Michaela Deming, and I'm the Policy Director for the DC Coalition Against Domestic Violence. We are the federally recognized statewide coalition of domestic violence service providers here in DC. And our membership includes domestic violence specific housing providers, counseling and case management services, legal services, and culturally specific services. Domestic violence continues to be a significant safety and public health concern for DC residents of all ages. In the district, 47% of women and 43% of men have experienced violence perpetrated by an intimate partner. And our member programs serve upwards of 1,000 victims of domestic violence on any given day across all 8 wards of the district. We would like to thank you, Chairperson Henderson, the Health Committee, and all of Council for allocating funds for our ongoing prevention project. DC Health is working with the coalition to support the training of pediatric primary care providers in the DC MAP program on domestic violence, cultural humility, trauma-informed care, and safety planning and crisis intervention. As you know, pregnancy can be a dangerous time for intimate partner violence. Many women report that abuse starts or intensifies when they become pregnant. And homicide is a leading cause of death for pregnant women in the U.S. They are more likely to be murdered during pregnancy or soon after childbirth than to die from the top 3 leading obstetric causes of maternal mortality combined. And this disproportionately affects Black women. Through the training that the coalition provides with the funding, DC MAP staff is better able to recognize domestic violence in culturally competent ways and offer trauma-informed support to families. We did successfully implement a plan and then implement a full day training for DC Health staff last year. And we are in the planning process to implement that training again this year. This DC MAP training program is the first primary prevention effort related to domestic violence funded with DC local funds. And it is critical that this work continue and that funding continue. We also have some other projects that we work on with DC Health, including supporting healthy youth, facilitate transformation, and healthy versus unhealthy relationship trainings. These are all funded through federal pass-through dollars or direct funding that the coalition gets federally, but is all related to the work that DC Health does or should be supporting. And so we appreciate the continued support and know that these prevention efforts continue to be essential for DC to prioritize. And through this preventative lens, we know that we are able to address concerns for youth and family violence, along with myriad physical and mental health impacts that they will bring. With multi-year funding, our coalition and member programs will be able to continue and expand these efforts. We know that intimate partner violence is preventable, and we continue to seek sustainable resources here through DC local funds and federal funds and private funds to support this programming, policy initiatives, and community awareness. We're committed to being DC's leader in efforts to stop violence before it starts, and we hope you to join us in this effort. Thank you, Chairperson Henderson, for the opportunity to testify, and I'm happy to answer any questions.
Thanks, Michaela. Ann?
Thank you. Can you hear me okay?
Yes.
Okay. Thank you for the opportunity to testify here today. I would like to express my concerns about the vendor who currently provides animal care and control services in DC, Brandywine Valley SPCA. Since BVSPCA started to provide animal control services in January 2025, the quality of these services has rapidly deteriorated. There have been numerous reports of unanswered calls, ignored voicemails, and outright refusal to pick up animals. BVSPCA has told callers to let the dog go, wait until business hours, or keep the dog overnight. This places a huge burden on DC residents. It's simply often not feasible. There's a list now of more than 40 known incidents that illustrate these insufficient services. I'm happy to attach these as an appendix to my testimony. I also want to look at the data for a moment. Owner surrenders decreased from 2,902 in 2024 to 482 in 2025. That's an 84% decrease. Stray intake calls decreased from 18,462 in 2024 to 12,114 in 2025. That's a 35% decrease. According to the Department of Health data, 2,605 stray animals were housed in 2025. This would represent a nearly 40% decrease from 2024. We see a decrease of service at every level, and yet between 2024 and 2025, contract costs increased from 5.8 million to 9.9. That's a 71% increase. And I'm curious how you justify this to DC taxpayers. It is also my understanding that the BVSPCA shelter is overwhelmed with managing the animals it has taken in. I also understand that BVSPCA transferred animals from out of state to the DC shelter in late December. Now, I do understand that transferring animals out of a full shelter can help relieve the shelter's burden. I struggle to understand how transferring animals in is useful. So DC animals are not being taken in, but animals from out of state are. And again, I'm curious how this can be justified to DC taxpayers and residents. I would like to ask that you take these concerns seriously and do not dismiss them by saying you have been receiving fewer complaints about BVSPCA than about the previous vendor. Many factors can impact how many complaints you receive. And I think that every complaint should be taken seriously because the lives of animals who do not have a voice are at stake here. I ask that real and effective action is taken to restore quality animal control services to the residents and the animals of DC. Thank you.
Thank you. Kurt?
Good afternoon, Councilmember Henderson and members of the committee. My name is Kurt Gallagher. I'm Executive Director of the DC Dental Society. Thank you for the opportunity to testify today. I'm going to go fast because I remember last week you liked the fast testimony. So we have three requests. First, to reduce the fees to become a dental assistant in DC. In Maryland, the fee is $88, including the exam fee. In Virginia, it's $100. And in DC, it's $240, including the background check fee. This creates a barrier for members of the public to enter the dental profession at the entry-level position. Second, I want to thank you, Councilman Henderson, for introducing the Future Smiles program. We are eager to see the success of this program, but we have a few suggestions to make it stronger. First, we'd like clear and transparent and a functional process to establish and authorize externships for those who are in the training program. Externships allow those who are in dental assistant training programs to gain important hands-on experience in dental practices. The barrier is the Board of Dentistry. The process is not clear, transparent, or functional, so we ask that the board be mandated to establish such a clear, transparent, and functional process. In addition, we should not forget the adults who also may have an interest in joining the dental profession. And to that end, we support the creation of establishing new dental assistant training programs. We ask that the Council take the approach of the Licensure Pathway Program to ask the Board of Dentistry and OSSI to collaborate on guidance for potential entities that want to create a training program for dental assistants. So we ask that they publish guidance on the accreditation and application process, but also coordinate on the processing of those applications. We've had members who've applied to establish programs, but they couldn't navigate the bureaucratic process, and we don't want any more applicants to get caught in a game of ping pong or not it. In terms of the Future Smiles program, we also ask that you consider incorporating the functions of a level 3 dental assistant, just to expand the capabilities of graduates. And finally, thank you last week for asking the Board of Dentistry on statistics regarding licensure application times. Today in the Board of Dentistry meeting, the Board of Dentistry reported statistics on those processing times, but those numbers beg the question, do they include renewals or not? The reason why I raise this is my understanding is a very large percentage of renewals are automatically and instantly approved by the DC Health's licensing portal. If those applications are included in the statistics, then they would, of course, skew the numbers, making it look like the processing times are lower than they actually are. Thank you for your attention, and I'm happy to answer any questions.
Thank you. Colleen?
Hi, thank you very much for this opportunity. I'm here because I believe DC needs a much stronger animal control contract, support for animals in this city and our community members. And I'm specifically passionate about having more accessible spay and neuter services, including free events and better education to the public, as well as it clearly stating a place for owner surrender of their pets in the contract. For spay and neuter, the city is in a crisis in its animal shelters, and I see this firsthand as a volunteer at the animal shelters. We have had a lapse in low-cost spay and neuter for over 5 years, and with overcrowding and euthanasias are happening at this because of an alarming rate. Currently, the low-cost spay and neuter for a large dog in DC is $250, which is still inaccessible to many. In Chicago, at the Anti-Cruelty Society, the low-cost spay and neuter for pit bulls is $150, and the ASPCA in New York City offers free spay and neuter to income-eligible residents. And these are just 2 examples that I found in my research. We can do better for our community members. DC also needs in its contract a guarantee for owner surrenders. It is unacceptable that when having to make the unthinkable decision of surrendering their pet, people are turned away with no option. Animals are often then left as strays, which is an unsafe option for everyone. All you need to do is go on Nextdoor and see how many dogs and cats are found as strays. And we have also seen this at the shelter where dogs are left tied outside and left alone because they were unable to properly surrender their pet. Thank you, and I hope you will consider better support for the animals and our community members in DC by making low cost and free for income eligible residents spay and neuter program and prioritizing a guarantee for owner surrenders in our city with the contract as it moves forward with our current vendor. Thank you.
Thank you. Thank you to this panel of witnesses. I don't see Vic unless Vic is hiding. I'm looking. Okay, I don't. All right. Thanks again to this panel of witnesses. Michaela, thank you for being here and for the work that you're doing. A couple of weeks ago, I had a meeting with the interim chief of police, and we were talking about homicide statistics in the district at that point. And at that particular stage, the majority of homicides that had taken place in DC at that point had been domestic related. And we're seeing an uptick of this, not just in the district, but across the country. Can you just say a bit more clearly what we're hoping for DC Health to do in terms of stepping up their education in this regard?
Yes, thank you for the question. DC Health is working with us. The amount of funding, while greatly appreciated, is really minimal. And as I noted, this is the first time that DC local funds are being used for prevention efforts. And so we are training these critical DC MAP folks who are having real-time in-home or in-the-moment opportunities for intervention and resources really with families at this highly critical time, postnatal time period. So that's really critical, and more funding could increase our ability to train additional folks and additional programs. As I mentioned, we're also increasing efforts in schools to do additional prevention work. I do think that there are a lot more opportunities for connection across DC government agencies. In my testimonies in front of the Judiciary and Public Safety Committee, for example, one of the things that we talk about is how gun violence intervention and community violence programs are really siloed and treated separately from domestic violence, as though domestic violence has not been a persistent, at least around 10%, if not higher, 14, 15% of homicides in the district. And not having that expertise and those folks in the room to make sure we're really addressing the entirety of a problem, it means that we're not addressing it at all. And so as we look at other issues like maternal mortality rates, and we look at truancy and other issues that are related to domestic violence is a piece of those, making sure that we are not only recognizing the connections, but making sure we have all of the expertise in the room to address the totality of the problem, I think is really another step that could be implemented.
Okay. Thank you. Thank you for that. Kurt, thank you for being here and for your continued advocacy. Look at that. You got some quick action from the Board of Dentistry. Not 100%, but some progress that was being made. And we continue to ask these questions around processing. Now, I know that as the boards are switching in terms of renewals, there's going to be some hiccups, right, in terms of the swiftness of that. And we had some testimony earlier from Dr. White. We have some questions we need to ask about the transition that has taken place. But we'll definitely follow up on some of the other questions around the dental piece as well. So thank you so much for being here. Okay, Anne and Colleen. So on the question of spay and neuter, let me ask you this. What do you believe is supposed to be the kind of ideal pricing for low cost? Because I looked up what Montgomery County's Humane Rescue charges. Prince George's County their clinic is actually not accepting new applications right now. So they point you to some of the neighboring ones. So Bowie would be another one. And they all seem to be aligned in terms of their pricing structure with what Brandywine has, but perhaps I'm missing something, and that there's a lower cost option somewhere in the region, but they all seem to be quite aligned in terms of their pricing structure.
I think ideally what I would like to see is having maybe a sliding scale, or like they do in some other cities where they do have income eligible, so that they can work with people that, $150 or $250 is quite inaccessible, I would assume, to a lot of people. I mean, even to myself, I would be like, I might question that. So yeah, I would like to see something like that, or like the free mobile clinics that they have, just making it accessible to people that might be a little bit out of the realm of expense for them.
Okay. Anne, did you want to add anything?
That wasn't on my list, no.
Oh, okay. All right. We'll certainly ask some questions in terms of follow-up. I think this is some of the tensions in terms of being in a tri-state area, if you will, is trying to make sure that we're kind of matching some of the services that are being provided in other jurisdictions. We'll ask some follow-up to the folks at DC Health about how things are going with both the new contract and the new vendor, and how they can work for improvement on certain things. But I don't have any further questions for this panel. Thank you so much all for being here.
Thank you.
Okay, we're going to go to the next panel. Fernanda Ruiz, Will Doyle, Kristen Yoakum, Rosalind Brown, Jocelyn Johnson, and Kent Peebles. Again, need to affirmatively accept our invitation to become a panelist. It's a little box that pops up on the screen. All right, I see our first three. So I see Fernanda. So why don't you go ahead and get started?
Thank you. Good afternoon, Chairperson Henderson and members of the committee. My name is Fernanda Ruiz, and I'm testifying on behalf of Mary Center. Thank you for the opportunity to share our experience with the recent closeout of McBee-funded home visiting programs and to offer recommendations for system improvement. Last year, DC Health released a funding opportunity for McBee home visiting services for fiscal year 26 and 27. Mary Center applied but was not selected as a grantee. As a result, in September 2025, we sunset our Healthy Families America at Parents as Teachers programs when our funding ended. We recognize that funding decisions are competitive and complex. However, looking back, the planning and coordination around program closeout and family transitions could have been more thoughtful, collaborative, and centered on preventing service disruption. I want to highlight three key issues. First, the funding timeline created a gap in services. The request for applications was released on July 7th, with awards expected in September and a start date of October 1st, 2025. Our funding ended on September 30th, and we closed our programs accordingly. However, awards were not announced until January 2026. This resulted in a service gap for district families during the first quarter of fiscal year 26 and left providers with little ability to plan responsibly for families or staff. Second, the transition planning lacked sufficient lead time and system coordination. Mary Center proactively requested guidance from DC Health in late July. We received closeout guidance in early August and submitted our transition plan in September. While the template provided is a standard and useful, receiving it so close to the funding end date limited meaningful planning. More critically, we learned that very few alternative home visiting options were available. Only 11 of our 127 enrolled families were eligible for other home visiting programs at Mary Center. Other providers were reported being at capacity or having wait lists. We asked DC Health for assistance identifying programs with capacity to receive families, but no additional options were identified. Third, the impact on families was significant. With guidance from the Healthy Families America National Office, we adjusted graduation criteria to honor family progress. As a result, 53 families graduated and 11 transferred internally. Despite these efforts, 63 families, half of the families we had enrolled, were discharged from services because no alternatives were available. These families lost trusted relationships and consistent support during a critical time for parents and young children. Based on this experience, we respectfully recommend three actions. First, set earlier timelines for grant cycles to prevent service gaps. Second, conduct system-wide assessments of capacity and need to guide transition planning. Third, collaborate closely with grantees early in the closeout process to support continuity of care. In closing, grantors and providers, we share responsibility for the well-being of district families. Last year, 63 families lost access to home visiting services. We offer this testimony in the spirit of learning and partnership so that together we can do better for families and their children. Thank you for your time.
Thank you. Will?
Thank you, Chair Henderson, council members, and council staff. My name is Will Doyle, and I'm the Vice President of Housing First at Pathways to Housing DC. I want to highlight some positive changes that the Department of Health has made in FY25 and FY26 in regards to social work regulations. As of November 2025, the Department of Health implemented the educational pathway for licensed graduate social workers. This alternative maintains DC's high standards for health professionals by emphasizing the role of supervision in preparing and evaluating social workers. It has already been quite impactful and successful. Between November 6, 2025 and January 16, 2026, 246 educational pathway LGSW licenses were issued. As of October 27, 2025, DC had 1,388 LGSWs. Therefore, DC has increased its LGSW workforce by 18% in just 72 days. Thank you to the Committee on Health's support of this change. I urge you to closely follow this policy to monitor its effectiveness and review the data that will be collected in collaboration with researchers from the Catholic University of America. As of January 2026, the Department of Health implemented group supervision of LGSWs, allowing up to 40 of the 100 hours needed for advanced licensure to come from group supervision. This is consistent with over 40 other states. It also reduces the financial burden for supervisees, exposes social workers to a variety of perspectives, and counteracts stress. I and many of my colleagues are deeply appreciative of this change. Both of these policies directly reduce barriers to the social work profession and contribute to addressing workforce shortages. However, they could be more effective if the Department of Health communicated these changes in a more substantial way. All I have really seen is that links have been quietly posted on the Board of Social Work's website. This theme of inadequate communication is also felt in regards to vacant board positions. The need for board members has been repeated at board meetings, but communication has not been sent to licensed health professionals or done more broadly with the public. The Board of Social Work has struggled with vacancies like many other health professions. However, from 1993 to 2025, all 39 confirmation resolutions for the Board of Social Work were approved for eligible applicants. The inability to fully staff this board, therefore, lies with the process prior to a confirmation resolution being introduced. Despite my FOIA requests to the Mayor's Office of Talent and Appointments, they have thus far not been willing to provide information on the number of applicants to the Board of Social Work who have not been proposed through a confirmation resolution. To fully understand and address vacancies on the Board of Social Work and other health professions, I urge this committee to investigate the recruitment process so that all barriers to fully staffed boards can be identified and addressed. Thank you for holding this hearing. I'm happy to answer any questions.
Thank you, Will. Kristen?
Thank you, Chairperson Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Kristen Yoakum, and I serve as the Executive Director of Operations at Paul Public Charter School in Ward 4, where we serve more than 750 students in grades 5 through 12. I'm here to speak about the current state of school-based health services following the transition of the School Health Services Program from Children's National Hospital to the Department of Health. We appreciate DC Health's recent efforts to strengthen communication with charter schools. The Leader Calls and Newly Shared Roles and Responsibilities Guide are helpful steps forward. We know that this transition is complex, and we are committed to partnering together to support our students. However, the transition from Children's to DC Health was not smooth. It was filled with confusion and uncertainty for Health Suite staff and for schools. Communication about staffing was provided at the last minute before schools opened in August. Even now in February, there are still components of the transition that remain incomplete. One significant example is the new requirement that Administration of Medication Trained Staff, or AOM, complete specialized training that was not included under children's training. That training has not yet been offered to staff who were previously trained. Schools are being held to updated standards without a pathway to meet them, and that creates compliance risk and operational strain. In addition, there are still clusters across the city without nursing coverage. Healthcare staffing coverage is not the same as having a school nurse on site daily. Paul receives coverage from a health tech and phone coverage from a nurse manager. Both are dedicated professionals, but a nurse available by phone is not a substitute for a nurse in the room during a medical emergency. Yesterday, a student at Paul experienced a medical emergency in class. Our health tech and trained staff provided excellent maintenance care, but the health tech does not have the training to assess advanced medical needs. The student did not begin to improve until the EMTs arrived, began treatment, and prepared to transport. This is not an isolated incident. Research shows that access to school-based health professionals improves attendance and academic outcomes. We see that impact firsthand, but partial coverage, downgraded cluster models, and incomplete implementation make it difficult to provide the consistent care our students deserve. We understand the broader nursing shortage, but schools need transparency, a clear recruitment and retention specific strategy to school-based positions, and full implementations of the systems promised during this transition. Our students deserve stability, our health suite staff deserve clarity, and schools deserve honest communication about what services we can realistically count on. We remain willing partners, but in February, we are still in transition, and that uncertainty is felt in our schools every day. Thank you for your time and your continued oversight.
Thank you. Rosalind?
Good afternoon, Chairperson Henderson and members of the committee. My name is Rosalind Brown, and I'm the Director of Healthy Foods at Martha's Table. I'm here to speak on behalf of the Joyful Food Markets program today. For 45 years, Martha's Table has been a cornerstone of growth and opportunity in Washington, D.C. What began as a sandwich and safe place for youth after school has grown into a powerful community-led organization serving over 45,000 neighbors each year. We believe every child and family deserves the opportunity to thrive regardless of zip code. Our goal is to strengthen family stability and build pathways for strong children, strong families, and strong communities through access to quality education, health, and wellness programs. Since 2015, with support from DC Health, Martha's Table has focused our efforts east of the river in wards 7 and 8. We transformed cafeterias and gyms into joyful food markets, vibrant, no-cost, choice-based pop-up healthy food markets. Every month, in addition to fresh vegetables, fruits, and pantry essentials, Joyful Food Markets also offers quick, easy, child-friendly recipes, along with recipe demonstrations, samples, and hands-on nutrition activities. By boosting fruit and vegetable consumption, we aim to directly address food access and and improve health outcomes through ensuring proper nutrition that is needed for enhanced learning is provided to families to help them prepare nutritious meals together. During the school year, we host monthly markets at 50 schools. In the summer, we transition to weekly market sites at 8 strategic locations to ensure year-round access to healthy foods for families. And since 2015, we have grown from 4 schools to our current 50 locations. Since 2021, in partnership with DC Health, the Equitable Food Access Grant, and the Capital Area Food Bank, we've shared over 3 million pounds of healthy foods to our families and our children and families. But the real victory is in our behavior change that we've seen. Since 2021, we have seen daily fruit consumption jump by 26% and vegetable consumption rise by 13%. Over half of our households report making permanent dietary changes because of the produce and the recipe cards found at our markets. And in FY25, we completed 416 markets over our grant cycle, supporting over 9,000 households with healthy foods and nutrition education resources. I have personally seen this impact most clearly in the moments between parents and children last month. Before the recent snowstorm, a mother and her young son visited one of our markets, and she mentioned that the son was a picky eater. But at the Joyful Food Market, she lets him lead. His face lights up, and he's given the freedom to select the produce he wants. She was thankful for our market because her son was given the confidence to try new foods. I'm going to skip ahead here. I do have a testimony submitted, but overall, we are really thankful for the support of DC Health, and we believe that Joyful Food Market is an essential piece of DC's public health infrastructure, along with others in the Fair Food Coalition, including DC Central Kitchen, Fresh Farm Food and Friends, and CAFB. We are thankful for the investment by council and the mayor to continue to build relationships and credibility needed to support our community needs. And we look forward to our continued partnership to ensure every child in Ward 7 and 8 has the nutrition they need to learn, grow, and thrive. Thank you for your time.
Thank you. Jocelyn?
Good afternoon, Councilmember Henderson. My name is Jocelyn Johnson, and I hope you remember me. I was the former chairperson for the Ward 4 Mini Commission. I actually am also a former ANC commissioner and a senior resident of Ward 4. I come to you this afternoon because I really want to bring somewhat of a horror story to your attention. I'm a little off from what you've been hearing today from your hearing, but I have a situation that's awful. In August of 2025, I was supposed to have had foot surgery from a doctor in Washington, D.C. He's a member of a podiatry association and all that. And in preparing for the surgery in August, he sent me in July to have a battery of tests done. So I had to go to my primary care. You know how that works. You have to go get different tests done. I had to go to Howard Hospital to get some different other things done. And so when I finished all of this toward the 24th or so of July, I went to his office to let him know I had finished it. He said, okay, everything's good to go. So around the 10th of August, I get a call from the office and they said, we're waiting on the results from all your tests. So I said, well, okay, let me go and do my due diligence to find out what's going on. And while I was calling to find out what was going on at Howard, the lady just kind of said, we don't see you listed to have any surgery on the 15th. That kind of concerned me, but we went on to find out what the status of my tests are and all that. And then the 13th, I went to him and I told him 13th, and I said, the hospital said they don't have anything registered where I'm supposed to have surgery. He said, oh, don't worry about it. I'll take care of it. And, I was waiting to hear from his office. His office never called me. The 13th came, the 14th came. I called, nobody called me back. The 15th of August came, and nobody called me. The doctor just abandoned me. And that was very concerning to me because I had gone to do everything he told me to do. And then I told him I did it. He even had me to go and fill my prescriptions so that I could get ready. So I wouldn't have to go get prescriptions for pain or antibiotics and all that kind of stuff after the surgery because my feet would have been messed up and all that. So on the 15th of August, I actually went to the Department of Health, DC Health, and filed a complaint with them. I think it was the Health Systems and Preparedness Administration. And I also filed a complaint with my insurance company because I thought that that was kind of strange. It almost made me feel like I was a victim of a scam. You know, the doctor didn't tell me that I wasn't going to have anything. He just abandoned me. And I went through all of this and I was very incensed because I was in a lot of pain. It was a lot going on and I didn't feel comfortable going back to him. So I've since, fast forwarded. I have since gotten new doctors. The surgery actually happened in January from another doctor, and I had to take the same tests over, the same pre-op, the same hospital stuff. But the problem I have is that I'm sure the insurance company paid for me to have this stuff done in August, July. And then what was, I'm getting a little ahead of myself. I got a letter from the DC Health in January, and it was signed by Vito Del Vento, who's the executive director. And let's say my doctor's name was Dr. Smith, and they said, we have completed the review of your complaint against Dr. Smith. And then they said in the letter, later on in the letter, the board concluded that there was no violation of Health Occupational Revision Act that will warrant disciplinary action against Dr. Brown. And I was like, who is Dr. Brown? So I was upset and I wrote them back and all they could say was, oh, that's a typo. Because they were telling me, I called them periodically between August and January to find out. And they said, well, we're getting ready for the meeting to review the complaints. And they didn't do anything. And that makes me wonder, what does the Department of Health do? The Health Systems Preparedness Administration, if the executive director could send me a letter that let me know that they did an in-depth revision or review of my complaint, and then have something as mistaken as with this kind of trifling mistake as this.
Yep.
I know things happen. I know people make mistakes, but I felt like I had to tell you about this and bring this to your attention. I'm in wrapping up. I just wanted to say to you, I will be sending this to you as in a written form with all my backup. But you needed to know that this is the kind of department and the kind of things that's going out. And it made me feel bad as
Thank you.
DC
Thank you, Ms.
resident.
Johnson. All right, Dr. Peebles?
Thank you.
Thank you. Good afternoon, Chair Henderson and members of the committee. My name is Clint Peebles, and I'm president-elect of the Medical Society of the District of Columbia, the largest medical organization representing metropolitan Washington physicians in the district. We advocate on behalf of all 11,000 plus licensed physicians in the district and seek to make the district the nation's model for patient care and physician practice. And I appreciate the opportunity to testify today on behalf of the Society and to speak on our work with DC Health over the past year. MSDC appreciated the leadership of Dr. Bennett and her leadership team in particular. And for this hearing, I'd like to briefly highlight 3 areas for the committee. First, thanks to the DC Board of Medicine, at their January meeting, the board recommended that the language on the medical license application pertaining to physician impairment be changed. The recommended language now aligns with recommendations by the Dr. Lorna Breen Heroes Foundation, which means DC joins 42 other states in the best practice of not stigmatizing physicians while protecting patients. MSDC will continue to work with the board to ensure the medical license process promotes best practices. The second would be the concept of overpayment for a 2-year license, which I think you heard about earlier today too. MSDC continues to hear from physicians who are required to pay a full 2-year fee for a medical license renewal despite being required to renew in under 24 months. We do not object to the change to birth month renewal, but at the same time, it's also absurd to ask a professional to pay full price for a license renewal and require them to pay the same fee again in less than 2 years. DC Health claims they they lack the statutory authority to change this. If this is the case, the council should pass legislation to fix that issue, but the DC code may already have language allowing that flexibility. The third would be on vaccine communication. We commend the department and the council for aligning DC's vaccine requirements to the scientifically proven AAP schedule. There's much communication work to be done to ensure families and providers know which vaccines are recommended and covered, but DC Health and the council took that very important first step. Please reach out to the MSDC office if our membership can be of any assistance on these or any other issues. We look forward to working with you and the committee to make the district the nation's model for patient care and physician practice. Thank you so much for your time, and of course, always happy to take questions.
Thank you. Thank you so much to this panel of witnesses. I'll start from the most recent and work my way back. So Dr. Peebles, we had some testimony earlier from some physicians who also complained about the lack of prorate, especially for physicians who either their birthday is like in December or in January, and they had just redone. There was a doctor who testified earlier, and he was like, they owe me 11 months worth of a license, and had a regulation citation that says that DC Health could do this. So we're going to follow up with DC Health about this. I'm sure we'll continue to receive complaints about this. Frankly, I would be pissed if I paid $500 for a 2-year license and then you told me 1 year in, I got to pay $500 again. We don't do that at the DMV. So why would we do that at DC Health? So we'll certainly ask some questions about that.
Thank you.
I'm glad, though, that this seems to be, and let me ask you, the payment issue seems to be the biggest complaint about the transition to birth month renewal. Have you guys heard anything differently?
We're happy to follow up in terms of any specific complaints we've gotten. I mean, the major issue, of course, has just been, the pro rata or lack thereof. But as far as the payment issue, I'm not directly familiar, but happy to follow up with you on that.
Okay, awesome. Thank you so much. Ms. Johnson, thank you so much for your testimony. We've been asking lots of questions to DC Health and the various health boards about their complaint process, particularly when it deals with physicians. And it's unfortunate that you received a letter not about the physician for whom you complained about. And so we'll ask some questions about the cleared up protocols. Like I said before, they just finally transitioned to an online form for complaints after years of asking DC Health to move in this regard. And I feel like sometimes, agencies are ancient beings, and moving them in modern technology takes a lot longer than we anticipate or expect, but we'll certainly follow up. Ms. Brown, thank you for being here and testifying about the Joyful Food Markets. It's part of, I think, a whole suite or access of healthy food access grant programs that we currently have in the district. And again, giving options for residents to be able to braid different things together to meet their various needs. And so the story that you told about the little boy having the opportunity to sort of guide where they were going to go, hopefully with some nudges towards more nutritious items. I think all of us find, like, if you have a child, when they are able to pick something at the grocery store, they have ownership over it. Sometimes too much ownership of it. And this could be an excellent way to sort of help there. So thank you for being here. Ms. Yoakum, thank you for being here for your testimony about school health services. We've had a number of witnesses who have testified about this, and we'll certainly ask some questions to DC Health on Friday. Let me ask you, earlier today, the representative from the DC Charter School Alliance had proposed that perhaps DC Health do something similar to what Department of Behavioral Health did around those schools that might be interested, granting them the funding and allowing for them to hire their own nurse. And we know some charter LEAs already have nurses on staff. What are your thoughts on this?
Yeah, thank you for that question. We very much support that. We've looked at our own budget to see if we can, if we can find the funding to do that on our own, because we do prioritize, having that RN or LPN. We do know that they are out there. We could find people, but it takes a lot to create that program without the infrastructure of the Department of Health. If they were to create a program like DBH has, I think it would easily facilitate that. Those of us who have higher needs could get the higher need staffing, the 40 hours a week staffing that we really, really need. And smaller schools with children that don't have the health needs might, not have to lean into a program to set something up on their own.
Yeah, I think one of the challenges we have, at least anyway, DC Health tells us that they assign nursing coverage based on the information that they have available to them. Okay, well, when I look at, the data that they send us around like universal health certificates, I don't know what data we're using, but it's not from the UHC because those are not being turned in the way that they're supposed to. And so I've even had, we have situations where a principal will contact us and say, I've got a kid who needs X. And then DC Health will say, I don't have that on file. Yeah. It's like, okay, well, if everybody had if everyone had 40 hours of nursing coverage, then we wouldn't need to do this sort of back and forth. It would just be someone who is there. But I know that we've got a workforce shortage problem. And so we're all trying to sort of kind of figure these pieces out. But I would say the rollout of this new model has been less than stellar thus far.
Yeah, and I think they are committed to working with us, and we are so grateful for that. But I would agree with that.
Okay. All right. Will, thank you for being here. I don't think it's just a Board of Social Work problem. I think this is we've had this, I think we did a hearing last week with DC Health, with a bunch of boards who, the board has supposed to have 5 seats. They're down to 2 members. So if one person can't show up, then, technically under their rules, one person showing up is quorum, which I think is crazy. That one person can make a motion, second their own motion, and then vote. Anyone who is following Robert's Rules of Order would say, nope, that's not something that we should be doing. But then I'll get notification from people who would say, I submitted an application to the Mayor's Office of Talent and Appointments, or I know of people who have, and somehow they haven't gotten through the process. Now, you got a whole office for whom their only job is to fill the positions on boards and commissions. And yet, when people raise their hand and volunteer, we're not hearing back. And so I don't know if we need an investigation. I actually don't think that I think we know what the problem is. But Will, I did want to ask, we did receive some information from DC Health about the new Board of Social Work educational pathway. It seems to be working. I don't know if you have any feedback there.
Yeah, no, it definitely, obviously the numbers I shared, I had requested that, so that's not something that they had shared. But in talking to people who have used it, in terms of impact, people suddenly have lots of job offers, but also like huge financial impact. People are able to access, positions that they were qualified for, but in terms of their preparations, but weren't licensed to get before. People who even were receiving like public assistance, food stamps are off of that now. So it's financially impactful, and obviously, yeah, 18% increase in that part of the workforce in 72 days is amazing.
Yeah, just for the public, because go to the council website and look up the stuff. But in case you don't, we're talking about the Board of Social Work Education Pathway. And since September of 2025, 285 licenses have been issued and 70 additional licenses are currently under review, which broadly expands the workforce opportunities for that particular area of licensure. And it was something that Will and others advocated for multiple years. And so it's good to see something moving in that direction on that front. So thank you for being here.
Ms. Henderson, I just didn't want you to miss that. I was talking also about the fraud. That was the biggest thing. Having done the testing and stuff and spent the money and there was no surgery. That was what got lost. And I sorry I didn't say that clearly. Thank you.
No, I heard you on that particular part. I try not to use the word fraud, just sort of thrown out there without not having all of the particular details, because it does have implications, particularly if someone is using a public health insurance program. I don't know what specifically happened with that physician where, as you said, he kind of ghosted you in terms of moving forward. And I think this is something for investigation
Exactly.
For the insurance company on that. So no, I didn't miss it. I just
okay, I
try
got
not
you.
to
Thank you.
accuse people of crimes.
No, and that's why I filed it, because I wanted to make sure they investigated it, and nobody did it. The insurance company didn't do it. It was like, oh well, it's only money. It's taxpayer money. Anyway.
Okay.
Thank you.
All right. Ms. Ruiz, thank you for being here. I wanted to ask, do you have a timeline of like, when did you all, when were you informed that you had not been awarded the grant for fiscal year 26?
Of course, thank you. We received notification on August 28th.
Okay. And at that time, did DC Health ask any questions about your existing caseload?
Yes, they had asked questions about our caseload in the transition plan that we submitted in early September, I believe September 9th.
Okay, but you're saying that nothing has happened since then?
Correct. When we submitted our transition plan, there was no options available for 63 families, and we were not able to secure any other services for them because all other programs were either at capacity, had wait lists, or families didn't meet the eligibility criteria.
Okay.
If the programs who are now awarded could have started on October 1st, we could have secured a transition because they're implementing Parents as Teachers program, which has a little bit bigger eligibility criteria than other programs like Healthy Families. So that would have been a much smoother transition in which 63 families would have continued with other programs receiving services. However, that was not the case.
Got it. Okay. We'll certainly follow up with DC Health on that. This was very helpful. Thank you so much to this panel of witnesses. I don't have any further questions. If you guys can provide your written testimony for the record, if you haven't done so already, that would be very helpful. Okay, we're going to go to our next panel. Sabrina Rhodes, Anna Roblin, Miriam Edelman, excuse me, Rachel Ingley, Shira Davidson, and Jaron Hill Lockridge. Again, you have to affirmatively accept our invitation to become a panelist. We have a little pop-up. All right, I see some folks coming in. But I see Ms. Rhodes. So when you're ready.
Thanks, Chair Henderson, witnesses, and staff. Good afternoon. My name is Sabrina Rhodes, and I'm here speaking as a resident, a community advocate, and an advisory neighborhood commissioner in Ivy City, also community organizer with Empower DC. We are in an environmental justice community that has carried an unfair and harmful burden for decades. Our neighborhood is surrounded by industrial land uses that emit volatile organic compounds along with other toxic pollutants. These emissions do not exist in isolation. They combine with limited shade, limited vegetation, and a built environment that is nearly 80% impervious surface of concrete, asphalt, and heat-absorbing materials. With only 11% tree canopy, our community experienced extreme temperatures that cause the urban heat island effect. trapping heat and pollution where people live, work, pray, and raise families. This is not just an environmental issue. This is a quality of life issue. This is a public health issue, I'm sorry. When VOCs and industrial pollutants are present both outdoors and indoors, they directly impact human health, especially for pregnant women, children, seniors, and residents with pre-existing health conditions such as asthma, cardiovascular disease, and compromised immune systems. For pregnant women, exposure to air toxics has been linked to low birth weight and preterm birth. For children, it affects lung development, learning, and long-term health outcomes. For seniors, heat stress and poor air quality increases hospitalizations and premature death. Again, we are in an environmental justice community, and our residents are bearing the brunt of toxins and pollutants that others in the city do not have to live with. This is why the question before us today is this: how is environmental justice being elevated within the Department of Health? How is Department of Health addressing the cumulative impacts of indoor and outdoor environmental conditions on communities like ours? Last year, we met with Dr. Ayanna Bennett, and the department shared that there will be an environmental justice or environmental health division established within the DOH. We welcome that commitment, but today we are asking for clarity, accountability, and action. Environmental justice is not a buzzword. It's about whether our children can breathe clean air, whether our elders can survive extreme heat, and whether pregnant women can carry healthy pregnancies without toxic exposures. And in my written testimony, I will have links to the ACLIMA study, the Ivy City Small Area Plan, and also the Ivy City Climate Resiliency Strategy Plan. Thank you for allowing me to testify, and I'll be here for questions.
Thank you. Anna.
Hi, sorry about that. I was trying to unmute. Hi, thank you so much for your time and attention. My name is Anna Roblin. I'm an ANC in Southern Trinidad, 5D03. I recently started an ANC animal caucus to safeguard animals of all kinds in the district. My complaint today is about Brandywine Valley SPCA Animal Shelter. DC's animal shelters are under contract with DOH. Brandywine Valley SPCA took over DC's shelter contract from the Humane Rescue Alliance in January 25. There had been numerous complaints about HRA by former HRA employees and volunteers. So the DC auditor did an audit titled DC Health Did Not Adequately Monitor Animal Shelter Contract, published August 20th, 25. I don't have time to go into their findings, but now 6 months after Brandywine's audit, it looks like DOH has not succeeded in improving conditions at Brandywine. DOH, I would ask, and this committee, is it possible to change Brandywine's contract, some of which violates DC code? Brandywine's contract, like HRA's did, contains no low-cost spay and neuter clinic or annual free vaccine clinic. That's a violation of DC code. Their contract does not require acceptance of owner surrenders, which should be seen as absolutely unacceptable. We're paying them $3 million more per year than we paid HRA, and HRA was open 24/7. Brandywine's open 12 to 7 weekdays and 11 to 5 weekends. I'm asking this committee to employ sufficient oversight to ensure that DOH fulfills its duties to holding Brandywine to decent and respectful standards. The following conditions and incidents have been widely reported on social media and neighborhood listservs: failings in responsiveness, shelter conditions, compliance with animal welfare standards, failures to conduct sufficient inspections of shelter conditions, and to ensure animals receive adequate exercise and cleanliness, to track and timely resolve dangerous dog cases, and to ensure compliance with statutory requirements for low-cost spay and neuter service. Reports say that they failed to respond promptly to calls regarding stray or injured animals and lacked diligence in responding to incidents involving dog attacks. Poor conditions were reported at their shelter in Southwest, including insufficient food, insufficient water, and insufficient enrichment for animals. And people have been told to hold an animal, let stray animals loose, or try to find the owners themselves. We've heard other witnesses describe severe problems at Brandywine, so I'm asking for your committee to please take action here to help. Please don't take these problems lightly. It seems very clear that DOH is not providing sufficient oversight, and I would hope that since Maryland and Virginia are not doing very well for our community with spay and neuter, that we choose to do better than them. I believe that we can. I don't see why we can't. And thank you so much for your time and attention.
Thank you. Miriam?
Good afternoon, Chair Henderson and members of the Committee on Health. I am Miriam Edelman, a commissioner of the DC Commission on Persons with Disabilities. The views of this testimony are my own. I'm a native Washingtonian. I am testifying about my strong desire that DC's Department of Health require that medical professionals take continuing education on disabilities, especially neurodivergence, to maintain their licenses. Current DC law is not sufficient. More than a quarter of Americans have disabilities. People with disabilities have poorer health than individuals without disabilities. The healthcare system needs to be prepared to care for people with disabilities, but many medical professionals are not properly trained on disabilities. According to reports, clinician training is a barrier to healthcare for people with disabilities. For example, the Government Accountability Office's December 2024 report, Healthcare Accessibility, Further efforts needed to address barriers for people with disabilities listed, I quote, insufficient provider training on healthcare for people with disabilities, end quote, as a barrier that individuals with disabilities may face when, quote again, receiving healthcare, close quote. Some medical professionals do not want to and feel that they cannot care for people with disabilities. In 2022, the New York Times published an article entitled, "These Doctors Admit They Don't Want Patients with Disabilities." Most practicing clinicians will not return to school. However, they need continuing education to maintain their licenses. In DC, to maintain their licenses, major medical professionals must have continuing education on certain topics, but not on disabilities. For example, physicians, MD-DO, must learn about LGBTQ cultural competency, a public health priority, and pharmacology. DC's Department of Health issued a public notice identifying public health issues for continuing education. Number 8 of 11, I quote again, public health priorities on the public, close quote, on the public notice is, I quote again, identifying impairment, physical or mental, in patients and providers, including complying with the Americans with Disabilities Act and the Occupational Safety and Health Act, close quote. Medical professionals very well may not learn about disabilities to maintain their licenses. Thus, mere inclusion of disabilities in the public notice is not sufficient. There is support in the disability community regarding mandating that medical professionals learn about disabilities. In the Health Equity Framework for People with Disabilities, the National Council on Disability called for, I quote again, requiring disability competency education and training of medical, nursing, and other healthcare professionals, close quotation. Thank you for your time and consideration.
Thank you. Rachel?
Thank you, Chairperson Henderson and members of the committee. My name is Rachel Ingley, and I'm the Crisis Response Team Manager for DC Safe. We serve a critical role in the city's public safety infrastructure as the only 24/7 crisis intervention agency for domestic violence. Last year, we received over 16,000 referrals for survivors immediately after a domestic violence incident, including 180 referrals from local hospital. We joined the performance oversight hearing for the Department of Health today to uplift the critical link between health and domestic violence. Domestic violence in a household has immediate health consequences as well as rippling negative health effects across the lifetime of a survivor and their families. The strong ties between health and violence are evident, but we want to emphasize the critical role healthcare providers can play in providing opportunities for both care and intervention. I began working for DC Safe as an on-call supervisory advocate, providing support and oversight for our 24/7 services, but more critically, responding out to the community, particularly Washington Hospital Center, when survivors presented with domestic violence injuries. I've seen firsthand the impact of providing both trauma-informed services and critical links to specific DV expertise and support in a medical setting. I also want to highlight the specific protocols in place and access to immediate support available at Washington Hospital Center generates over 50% more referrals to our response line than from all other hospitals in the district combined. More needs to be done to provide training and implement a life-saving process of screening and support in other hospitals in the city. The same holds true for medical providers across the spectrum of care. Training and information gathering over the course of 2025 with the DC Primary Care Association shed light on fragmented protocol for screening, documentation, and more importantly, comfort in talking about domestic violence in a medical setting, a setting where most people have vital access to confidential support and a relationship of trust and care. I also want to uplift that as DC has recognized the danger of strangulation, elevating it to a felony charge in 2023. We want to see that recognition trickle down to medical providers. Specifically, I think about EMTs. With over 80% of our referrals coming from MPD, it's common to hear that a client gets checked out medically on scene and often declines further medical care. This is particularly concerning for strangulation, which we know can have potentially fatal consequences hours to weeks later, and damage that is often impossible to detect without advanced medical equipment. Strong training for medical first responders could be a vital link in explaining the dangers of strangulation and connecting survivors to care. While we are not direct partners with DOH currently, we would very much like to offer our expertise and strong track record of crisis response as a resource to agencies and organizations in their purview. In hosting Dr. Jacqueline Campbell, a leading voice in domestic violence and lethality research at our luncheon event last year, she leaned heavily into emphasizing the vital role that healthcare providers can play in helping survivors find safety. We believe DOH has a vital role to play in bringing critical access to services in a medical setting to more providers in the district. Thank you for your time, and I'm happy to answer any questions.
Thank you. I don't see Shira, but I do see Jaren.
Hello, can y'all hear me?
Yes, ma'am.
Awesome. Good afternoon, Chairwoman and members of the council. My name is Sharon Hill Lockridge, and I serve as the Director of Strategic Partnerships at Dreaming Out Loud and as the Chair of the Ward 8 Health Council. Thank you for the opportunity to testify. And because we just did this again last week, I'm not going to go through it all. But I am here with 3 specific requests for DC Health that are based on clarity, coordination, and accountability within our public health ecosystem. The first thing, it's a lot going on with the Cedar Hill, GW, UHS, all of that. I'm asking for the council to support DC Health to publicly clarify what's going on. Residents in Ward 8, we're hearing a lot of fragmented information. It's not clear, nor is it unified. But when it comes to healthcare access, particularly east of the river, that uncertainty creates a lot of fear. So we're looking for clarity on decisions, how decisions are being made, who holds oversight responsibility, continuity of care, a lot of things. This transition should not be happening in the shadows, and we ask the council to work with DC Health to provide a clear public update so we can talk about the facts, not the rumors. The second thing, clarification on the food is medicine space. Food and medicine, food is medicine, whatever you want to call it. As you know, food is my love language, and working at the intersection of food and health is really what I do. But the line between DC Health and DC Healthcare Finance is very unclear. What role, if any, does DC Health play in this, specifically around nutrition strategy and public health guidance? Recognizing that healthcare finance's role is very much sitting with like the insurance places and things, but there has to be more to the conversation than just insurance. And without the interagency alignment, CBOs and the folks who are doing the work in real time are struggling. And then the last thing, I'm real proud that the Ward 8 Health Council has recently released our strategic plan that can be found on our website that really speaks to how we are a systems level convener. Thank you for your continued support. And we're asking for the council and DC Health to both review that strategic plan. Again, it's available on our website. And one of the things that it makes clear is that we don't need more studies, we don't need more data. We need alignment, transparency, and very clear partnership. So I'm not here to criticize, I'm here to collaborate, asking for clarity where there's confusion, clear coordination where there's fragmentation, and partnership where we have shared responsibility. So thank you for your time and for your continued support and service. And I am here for any questions that you may have.
Thank you. Thank you so much to this panel of witnesses. Jaren, we received the strategic plan. And I look forward to being able to sit down with you and talk more about what you all have planned, but also sort of the larger ecosystem piece. I know that members of the community have some specific questions. The question is, which agency is the appropriate agency? I don't know if DC Health is the appropriate agency when it comes to Cedar Hill. However, it is the appropriate agency when it comes to some of the other things that you discussed. So we can certainly talk more about those things. Ms. Edelman, thank you for being here. Ms. Ingley, thank you for being here and for your continued advocacy. We can certainly ask some questions on some of these things. Ms. Rhodes as well. It's not the first time that you've joined the committee. And as I mentioned earlier, DC Health has this new environmental health administration. And so we certainly have some questions around how they are leaning into their role or not in terms of the environmental health space, particularly as it pertains to some of the things that you brought up. Ms. Roblin, so in the intervening time, we've had a number of witnesses who've testified about animal control. So interestingly enough, if you go to the Brandywine website right now, there is a box that just pops up about spay and neuter clinic and scheduling. And right now they are offering dog spay and neuter for $100 and cat spay and neuter for $50. I know that is not always the norm, but for those who are listening who might be looking for this particular service at a lower cost, this $100 and $50 is certainly lower than everybody else who's currently offering something right now in the region.
Well, that is great. But I heard it's not always that way though. So, I think
that is true.
A sliding scale maybe. Sorry.
No, go ahead. Sorry, go ahead.
No, I was going to say maybe a sliding scale like one of the other people suggested.
Okay, I think we can ask questions about that. I think there was a question someone earlier said, can we just change the contract? We don't have a mechanism to sort of change the contract mid-year without cause. But as we think about option years for the future, what does that kind of look like? I think there are some misinformation in terms of what the contract costs with the previous contractor rather, without realizing for several years, even years when I was chairing this committee, there would be a base contract amount. And then midway through the year, we would be providing some additional supplement of $3 million plus to cover the rest of the services. That's not a good way to do contracting for any government contract, but I think that creates this misperception that somehow we are drastically overpaying our current contractor and getting less services, when in fact, we were supplementing throughout to cover what we currently have. And I think overall, people just want to make sure that When they call animal control services, they're getting a clear answer. We've had some situations where some of the services are still bifurcated. So for instance, while animal care may be under one contractor, if you're calling with regard to an animal enforcement issue, it is a different contractor, and people may not know the difference. And even frankly, sometimes the individuals at both of those organizations might not know the difference when somebody calls to ask who's responsible for X. So we all just need to get really clear in terms of communication, which I think is a theme throughout everyone's testimony here is transparency and communication truly does help the public. And so we'll certainly ask DC Health some of those questions. But thank you all for being here. If you haven't provided your written testimony for the record, please do so. And we will move on. Okay, we're gonna go to the next panel. Khalil Northington Kenyat. Hayden Morgan. Chioma Ukbasi. Makia Penero. Nora Banero. Shahad Madeline. Okay. These are all students. So let's see, it's 2:30. Well, let's see how many of these folks are here. And then we might add to this so we don't just have two people on this panel. Give me just a second. Okay, we're gonna keep adding some folks. Deborah Wells. Maya McCowan. Patricia Stamper. And we'll stop there. Okay. Okay. Callie? Am I saying that correct?
It's Collie, that's correct.
Oh, okay.
Greetings, Chairperson Henderson and members of the committee. My name is Collie Northington Kenyatta. I'm Director of Operations, Development, and Programs at Crittington Services of Greater Washington. I'm here on behalf of our President and CEO, Sheena Foster, and the hundreds of teen girls and families that we serve in DC. For over 40 years, Crittington has partnered with DCPS to provide consistent programming for teen girls focused on healthy relationships, reproductive health education, goal setting, and life skills. Each week, trusted adults would work in schools, building relationships and equipping teens to make informed choices about their bodies and their futures. Although Crittington was not selected to continue the teen pregnancy prevention program this school year, we remain unwavering in our commitment to walk alongside our students as they navigate their health and their lives. And for over 10 years, DCDOH has invested in our work. However, in December 2024, our funding was cut and then it formally ended in September. Even then, we continued offering students resiliency tools and support. But without sustained funding, the weekly groups and sacred relationships that defined this work came to an end. The challenges teen girls face, however, did not. Teen pregnancy rates remain highest in Ward 7 and 8, with Wards 5 and 4 close behind. These are the communities we served, where teen girls are navigating economic instability, mental health stress, exposure to violence, and uneven access to consistent reproductive health education. At Crittington, prevention looks like a student practicing how to communicate her boundaries, like honest conversations about consent and healthy relationships. It looks like connecting today's choices to tomorrow's goals, college, career, financial independence, and more. It's not only about preventing pregnancy, it's about protecting a young woman's future. Because of the recent snow, our students were unable to testify today, but I want to share a few words from them. One said, Crittington has taught me how to control my anger, and now I know what I need to do to get out of something unhealthy. Another wrote, I had a goal to get honor roll all 4 quarters, and this program helped me stay on top of my grades. Finally, another student shared, since joining this program, my confidence has gone up and I can see myself going to college. I didn't think I would be able to go, but I definitely know now that I want a degree. That is what prevention sounds like. We are not here simply to revisit a funding decision. We're here to say that the work remains urgent and we remain ready. We urge you to restore and sustain more funding for school-based teen pregnancy prevention so programs like Crittington can continue serving teen girls. Teens deserve stability, safe spaces, trusted adults who stay. And we stand ready to continue this work, and we ask for your partnership to make that possible. Thank you so much for your time.
Thank you. Shahad?
Hello. First, I want to start off by apologizing that our young people were not able to testify today. We thought that was going to happen after school, but because of the phone ban and just access, we weren't able to get them online. But good afternoon, Chair Henderson and members of the Committee on Health. Thank you for the opportunity to testify today. My name is Shahad Mahildeen, and I serve as the Youth Health Educator Program Manager of the Young Women's Project. YEP specifically develops youth as sexual health champions who work to reduce DC's unintended teen pregnancy rate and STI rates through peer education, resource provision, and clinic referral support. I'm here to highlight urgent sexual health gaps for DC youth and to push for stronger school supports. This year, YEP has trained and employed 82 youth staff. Since the start of the school year, our peer educators have implemented a range of strategies to improve the sexual health literacy among high school students. To broaden access beyond the classroom, youth send messages to their peers covering a variety of sexual health topics, offering clear information and direct access to services. These messages have reached over 7,800 students. This year, over 1,200 DC youth participated in our Youth Sexual Health and Wellness Survey. Their responses reflected an urgent need for stronger school-based sexual health supports. First, DC youth aren't receiving adequate sex education. 46% of surveyed students reported receiving 0 hours of sex education this year, and only 22% said that they were satisfied with their school's curriculum. Second, condom and contraception use is declining among sexually active youth. 43% did not use a condom the last time they had sex, and around 60% do not use any consistent form of contraception. This is extremely alarming given that condoms are the only method that prevent against both STIs and pregnancy. Access to condoms remains a major barrier for DC teens. YWP youth have distributed over 25,000 condoms to 10,000 students, yet our survey data shows that the lack of access still limits use. 30% of students did not use a condom simply because they didn't have one. School-based condom distribution is one of the most effective and youth-preferred strategies for increasing access. While our youth are actively distributing condoms, we need sustained adult investment in school-level support. The agency has reduced its reach and funding dedicated to this work. We're recommending and requesting that the committee provide support and funding to revitalize DOH's Sex Is program and campaign, which would allow students and teachers to serve as RAP MCs. STI testing rate among DC youth remains extremely low. Over 48% of sexually active young people never received STI testing. DC continues to have one of the highest STI rates in the nation, making this gap extremely concerning. Because most STIs are asymptomatic, testing is the only way a young person can know their status. Low testing rates combined with declining condom use means that many young people are unintentionally transmitting infections simply because they don't know that they have them. To address this, we need more school-based testing events, screenings, partnerships that bring these services directly to where students are. Despite these barriers, our youth staff continue to meet an enormous need and are doing so effectively. But young people should not be responsible for filling gaps that the school system is meant to address. Young people deserve to be compensated for the critical public health role that they're playing, a role that supports DOH's goals. Our youth are stepping up where the system falls short. Safe sex education is essential, and young people deserve reliable, youth-friendly resources to protect themselves. Thank you for your time and for your commitment to supporting DC youth.
Thank you. Deborah?
Good afternoon, Chairman Henderson, members of the committee, and council staff. Thank you for convening today's performance oversight hearing for DC Health. My name is Deborah Wells. I am an ANC commissioner for Single Member District 8E01 and a store navigator for the DC Central Kitchen Healthy Corners program. As this is a performance hearing, I want to state clearly that DC Health's partnership and technical expertise has become essential to how we perform each day and how well we are able to address hunger, poverty, and health disparities in our city. Our Healthy Corners program is an award-winning model bringing healthy food, infrastructure, technical assistance, and community outreach to small corner stores in neighborhoods like mine without easy access to grocery stores. Through the Healthy Corners program, we can provide information and outreach while providing fresh fruits and vegetables to our most vulnerable neighbors facing chronic diet-related illnesses. I have worked with DC Central Kitchen's Healthy Corner program since 2018 when we started the SNAP Match program. As a store navigator, I am part of the Nutrition and Physical Fitness Bureau collaborations, which include educating WIC customers about Healthy Corners offerings, informing eligible residents about the Sunbuck Summer Nutrition Program, and coordinating up-to-date information and resources when necessary. After shifting our program model to include smaller purchases of fruits and vegetables in 2025, we've reached the highest redemption rates for our SNAP Match Produce Incentive Program. Now, DC SNAP customers purchasing a produce item for as little as 50 cents at a participating retailer can receive $5 in additional purchasing power for fruits and vegetables. So far, this fiscal year, we have added new Healthy Corner store locations in wards 4 and 8 and continued introducing new products like salad mixes actually grown in Ward 8. Healthy Corners is making a difference for DC. Thank you.
Thank you. Maya?
Hello there, Chair Henderson and council members. My name is Dr. Maya McEwen, and I am a board-certified general pediatrician in Washington, D.C., practicing in wards 1 and 5 and a resident of Ward 2. I am speaking as a member of the D.C. chapter of the American Academy of Pediatrics, which represents over 450 local pediatric healthcare providers. D.C. parents are concerned about vaccine access, and so are we. In the pediatric intensive care unit, I recall caring for a school-aged child with meningitis, a vaccine-preventable brain infection. This patient had such severe brain inflammation, it led to life-threatening brain swelling, requiring multiple invasive neurosurgical procedures to keep her alive. It's important to note that even when patients survive this level of illness, as this patient thankfully did, many do not return to the life they had before, incurring hearing loss, seizures, learning difficulties, lifelong neurological disabilities, and deconditioning that require extensive rehab and therapy. What makes this especially tragic is that many cases of dangerous bacterial meningitis are vaccine preventable. Routine childhood vaccines protect against bacteria like Haemophilus influenza type B, pneumococcus, and meningococcus, bacteria that historically cause devastating meningitis in otherwise healthy children and young adults. Vaccines don't just prevent a fever or a missed day of school. They prevent things like ICU admissions, invasive procedures, permanent disability, and death. Because of immunization programs, these cases are now far rarer than they once were, but when vaccination rates fall, they return. The U.S. is facing currently critical levels of vaccine-preventable illnesses and associated avoidable childhood deaths. It's essential to protect and promote equitable vaccine access in the district. In January, as mentioned previously, the AAP has published their evidence-based and FDA-approved 2026 childhood immunization schedule based on extensive review of evidence by pediatric experts. We applaud the council's efforts to ensure that healthcare providers are able to follow these evidence-based recommendations. Despite proposed changes by HHS, the AAP vaccination schedule protects children and teens when they are most vulnerable to disease and keeps them protected well before exposures. DC Health and DC Medicaid quickly communicated with clinicians their commitment to the AAP vaccination schedule. DC AAP appreciates the DC Council's commitment to this vaccination schedule and supports policies for minimal vaccine exemptions, except in situations of true medical contraindication as certified by a healthcare provider. DC Health's immunization programs largely depend on federal funding, which unfortunately has become unpredictable and insufficient. Given the importance of equitable vaccine access in the district, it is imperative for DC Health to build local autonomy, allowing essential teams to continue their work. A well-supported DC Health immunization team could implement immunization education campaigns, administration fairs, and support for providers detecting and managing re-emerging infectious diseases. Keeping DC medical providers informed is particularly important, especially in the context of ongoing fragile herd immunity and more frequent vaccine-preventable illnesses. We appreciate your commitment to keeping children in the district healthy. The DC AAP will continue to support vaccine access and education and hopes that the council will act to ensure adequate funding for DC Health's immunization initiatives. Thank you to Chairperson Henderson and the council for your time.
Thank you. Thank you to the witnesses on this panel for your testimony. Dr. McEwen, I think your testimony is sort of spot on, and it's been a part of an ongoing conversation that we've been having with DC Health, especially over the last year, in terms of how we build local capacity to do the things that we used to depend on the federal government for, that no longer are givens. And so we actually introduced a bill, I introduced a bill a few weeks ago around authorizing DC Health to be able to enter into purchasing cooperative agreements with other jurisdictions when it comes to prescription drugs and things like that. Because if it got to that point where we need to now start to build up our own supply and capacity to be able to continue some of these programs, you know, it's cheaper in larger quantities. And so if we could partner with Maryland, or if we could partner with Virginia and enter a purchasing agreement with them. So I totally hear you on that, and we'll certainly ask some follow-up questions to DC Health about progress sort of in this regard. It's unfortunate that we have to do this, but it is something that's happening nonetheless.
Thank you so much for your advocacy and efforts there. I totally echo your sentiments. We're very appreciative.
Ms. Wells, thank you for being here. We had some earlier testimony about the Healthy Corners program. I love our Healthy Corners program. It doesn't, obviously it doesn't take the place of, having a full service grocery store or supermarket, but it has provided some connective tissue in parts of the city to help these small businesses, frankly, be able to expand their offerings to the community. And I think we were at the Stanton Market together last year for their ribbon cutting and their expansion. Is that?
Yes.
I think that's right. I think I saw you there.
Yes, that's correct.
Okay. All right. But thank you so much for being here. Okay. So I want to ask a question to Shahad. I think you said in your testimony, 46% of students are getting zero sex education. Was that based off a survey? And was that high school students or middle school students?
Yes, this is a survey, an annual survey we do every single year. So it's DC public and charter high school students. And so we kind of asked them, how many hours of sexual health education did you receive this year? And 46% said that they received 0 hours of sex education this year.
Okay, so that then begs the question of some questions I got to ask the Office of the State Superintendent of Education. Because I know what the law says, I know what the curriculum says.
Yeah,
and for 46% of our students to be saying they got no sex ed, that I know is not supposed to be what is happening.
Usually what we're seeing is that so students are required to receive health education as the class, right? And so they're usually receiving that in 9th or 10th grade. And sex ed is a mini portion of that. And so usually, they receive it right when they enter high school. They forget all about it throughout their years of high school, especially the years where they probably are going to become sexually active.
Okay. All right. It's a different committee and a different agency, but we will certainly ask some questions there about that, because that could sort of correlate a little bit. I don't know if Ms. Kenyatta, you want to sort of add into this conversation in terms of the young people that you deal with.
Yeah, so I was thinking our experience has been just the opposite, where the students that we work with, when they're talking about having received some sex education, it's usually occurring in the middle schools. And then as they move forward through high school, they're receiving none. And so we are filling in the gaps for that as well. So yeah, but it's just the opposite in terms of our experience.
It's kind of interesting that we kind of approach this as a checkbox situation as opposed to like a continuous education position, right? So yes, in terms of middle school, having those conversations specifically about consent and your body and touches and things like that makes sense. But also when you get to high school, your body has changed. And if we're not talking about that, as well as the relationships that you might be having I'm sort of thinking about a little bit about what Michaela Deming was testifying about a couple of panels ago. Healthy relationships in connection with sex education, like those should be going hand in hand in terms of
They go
talking
hand in
about
hand, absolutely.
what those things are. And, I'm sure I'll hear a teacher who's saying, okay, but when are we supposed to slide that in between science and math and reading and all of these different things? But it can't just be a conversation with a pediatrician. All right. That wasn't a full question. That was more rhetorical, if you will. But thank you all so much for being here and for the work that you do each and every day. If we don't have your written testimony, please make sure you provide it for the record. Thank you.
Thank you.
Okay, we're going to go to our final panel. Libby Bukel, Kamoni Freeman, and Chris Avila. Give it just a minute. Okay, Mr. Freeman, I think you are solo dolo.
Okay. Greetings, Chairman Henderson and members of the Committee on Health. I'm Kimon Freeman, representing WEAC Radio, based on the radical side of Martin King Avenue in Anacostia. On my first trip to Cuba, who, by the way, has 100% literacy rate and a far superior healthcare system than these United States, I learned that Cuban medicine prevents diabetic amputations. And when I was afforded the opportunity to meet with the U.S. intersection chief, because there's no diplomat to Cuba since U.S. imperialism has been trying to crush the revolution there for 6 decades. But when my delegation met with him, I asked him about the U.S. blockade that prevents goods from entering the country. Why wouldn't they allow the life-saving Cuban medicine that will alleviate diabetic amputations here in America? He told us that it was in America's business interest not to do so. So therefore, the U.S. government business policy prefers to cut people's feet off like Kuta Kinte rather than support better health outcomes, which is why we have a plethora of liquor stores and dialysis centers in Black communities throughout this country, which brings me to this point. The late, great DC psychologist, Dr. Francis Cress Wilson of Howard University, taught us that until you understand the institutional white supremacy, what it is and how it works, everything else you think you understand will only confuse you, which leaves us with a crisis of white corporate control over our political, economic, and health-related destinies. And by ignoring the importance of understanding the sophistication of the system, it's not merely about the faces of the people that move the system, but rather it's a question of the impact that system has on people. You have been hearing a lot about the negative impacts today. And this system that exists in these United States and around the world is a system that undermines the humanity, quality of life of people of African descent, people of color, and poor people in general. These things are manifested by the egregious disparities found here in this city, whether it be the 20-year life expectancy disparity between Ward 3 residents and Ward 8 residents, 71 grocery stores west of the river, only 3 east of the river, with the National Library of Medicine confirming that the lack of nutrition is directly associated with violent and criminal behavior. And so is the exposure of lead in the human body. With DC Water not expected to replace all the lead pipes in the city, located mostly east of the river, until 2037, but the mayor and this council approved $1 billion of taxpayer money to the billionaire owner of the Washington Commanders, who would pay no property taxes, but would complete a new stadium with the first game played by 2030. DC is one of the most dangerous cities in America for a Black woman of any socioeconomic background to give birth. The national child poverty rate is 17%, but in DC, it's over 28%, and it's almost entirely comprised of Black children. There's a direct correlation between violence, crime, and illiteracy, and DC has over 40 bookstores, but had 0 east of the river for 25 years. Now Ward 8 has 2, and Ward 7, home of the new stadium, still has 0. They do prison population projections based upon third grade reading scores. And the average white family in Washington, D.C. has 81 times the wealth of the average Black family in this city. And we've seen the president of the United States weaponize SNAP benefits. And even our own outgoing mayor, in her capitulation to the Trump regime, under the threat of a lawsuit, was refusing to release the allocated funds for SNAP benefits. Now, soul food may have killed Big Mama, but Big Brother is trying to kill us all. And without a racial equity and social justice lens applied to government policy, without the Office of Racial Equity being empowered with binding influence over government policy, we are merely rearranging chairs on the Titanic, and the system will continue to do what it was designed to do. And most of our elected officials will continue to serve as sharecroppers for white corporate power in maintaining the status quo. Now, Martin Luther King taught us that we need a radical revolution of values. And I would add to that, we should have more food co-ops, grocery stores that are actually owned by the people in that community, as opposed to more exploitative national corporate chains. And these are the things that should be taken into consideration if there's going to be any changes to address the egregious health disparities in the nation's capital. Thank you for your time.
Thank you. I let you go because, well, I like what you were saying, but also you're the last person to testify today, and this was on a serious issue.
Thank you for saving me for last, Chairman.
No, I think what you talked about in terms of diabetic amputations and just overall in terms of the quote unquote business model that we have here in the United States when it comes to healthcare is something that we all should sort of reflect on. And why is it, right, that we have such high levels, or why is it that in the United States, it's able to get to that level such that we're not able to salvage limbs or help people in general.
If I may add, it's because America is the only industrialized nation in the entire world that does not provide healthcare to all of its citizens. And that's because of racism and white supremacy.
Yeah, I would often say, like, after we were in the middle of a global pandemic, I thought that that was an opportunity. You know, sometimes they talk about like the Overton window when the sort of policy shifts. And that was an opportunity for us to do better in terms of both universal health care and paid sick and family leave. And we weren't able to accomplish either of those things. But thank you so much for being here. And of course, we'll ask some questions. We did have somebody who joined us. You are not the last one.
Stealing my thunder.
Nah, sorry. Libby is here. Maybe, possibly. Libby, if you could hear us, you have to accept the invitation to become a panelist. There we go. All right. Libby, when you're ready.
Okay. Thank you, Councilmember Henderson. My name's Libby, and I'm one of the co-coordinators of the Parents United for School Health Advisory Committee. I'm here to talk about some history. The 2023 Council allowed Children's to move to a cluster model with clusters of 4 schools with 2 nurses and 3 health techs per cluster for a total of 5 staff per cluster. The 2024 staffing plan from DC Health showed that the planned 5 staff members was now down to 4 staff members per 4 schools with 4 schools. We were concerned about this, so PUSH conducted a survey of health suite coverage, which we presented in October of 2024. Our survey showed that only 70% of health suites had coverage on a given day. After that, Robin Diggs of DC Health contacted PUSH and asked us to form an advisory committee with DC Health. We had our first advisory committee on January 30th, 2025, and we sent them our draft charter in March of 2025. In our initial meetings, Robin expressed a commitment to increasing the number of school nurses. She was open to discussing recruitment strategies with the advisory committee to increase the nurse pipeline. In April 2025, Robin notified us that DC Health was taking over the staffing of the cluster model, and she soon left DC Health after that. Our June 2025 meeting was canceled with DC Health. On October 3rd, 2025, PUSH finally met again with DC Health, At that meeting, we learned that from the council-approved plan of 4 schools per cluster, DC now has 5 schools per cluster. Their staffing plan now includes only 39 RNs system-wide and 32 LPNs. They had 38 RN positions filled in October 2025 and only 1 vacancy, according to our conversation with them. We sent our DC Health, our advisory committee charter in March of 2025, as I said. DC Health just started reviewing it recently, and they've placed a lot of restrictions on what we can talk about or work on. They say our charter can't say that we're going to advocate for more nurses because DC Health stated they don't plan to recruit more nurses, despite the fact that 39 nurses in the system is the lowest RN staffing rate we've ever had. This is no longer a nursing shortage problem. It's a refusal to recruit problem. Thus, our charter can't say we can work with DC Health to develop innovative recruitment and training programs because they're not planning to bring any more in. PUSH has copies of the cluster models in 2023 and 2024 showing nurses per health techs in the school, but DC Health saying so they will not release this information for 25 to 26. So parents have no idea who's covering their school, what expertise that person has, etc. Our charter says they say we also can't say that we are going to help them with monitoring school coverage, even though DC Health had told us previously they wanted to partner with us on this. The Centers for Disease Control recommends a minimum of 1 school nurse per 750 students. DCPS's system and DCPS shows right now that we have about 1,382 students per nurse. This is dangerous. No one's trying to recruit more nurses, and we're going through the wrong direction. I believe that DC Council is allowing DC Health to violate the agreement with the staff to a dangerous level. Thank you, and I'm happy to take questions. I'm sorry for being late.
No, it's okay. Thank you, Libby. There are several witnesses who testify about this, and your testimony is not incorrect. What we were told at the beginning of the school year in terms of the planning around staffing has not come to fruition. And so we have questions for DC Health on Friday, but thank you for being here and for the continued advocacy on behalf of PUSH around this particular issue. Okay, I don't have any other public witnesses. For today. So I want to thank everybody who testified and provided testimony. I think this was a rich and robust conversation that covered a lot of different issues in terms of the full scope. And actually, it wasn't even the full scope of the things that we know that DC Health deals with. Like, no one talked about food establishments today, which is interesting. And a couple of other areas and issues that DC Health works on. For those who have not submitted your written testimony for the record, or you weren't able to attend and speak today, but you have some commentary, you have until March 4th at 5:30 p.m. You may submit your written testimony on the council's hearing management system site, dccouncil.gov/hearings. The committee will reconvene this hearing on Friday, February 20th at 9:30. We'll be in room 412 of the Wilson Building, and we're going to hear testimony from DC Health Director, Dr. Ayana Bennett, as well as her team. So I appreciate, again, all of the public witnesses who took time out to testify today, and I look forward to continuing the conversation on Friday. The time is 3:02, and this part of the hearing is adjourned. Thank you, everyone.